surgery, single-handed, two-handed surgeries. We have an endoscopic stapedotomy. And we have 3 orations of our prestigious guests and our professors. So I hereby start the session for the morning. Well, for the morning, I have 3 chairpersons, Dr. Bharat Jobanputra, Dr. Ritesh Bhagyavant, and Dr. Uday Monga. I welcome them. I asked them to take the chair. I guess they are not here. Okay, Bharat is here. Okay. They are still having breakfast. No worries. Yeah. Gadre sir, please. No, the chair is there only. No, we're going to shift them down. Okay. So the first lecture is by Dr. Ramesh S. sir. So please welcome. Yeah.
Respected teachers, my seniors, and my dear friends, a very good morning to you all. Now I am presenting endoscopic versus microscopic stapedotomy, our experience. We all know that one of the common cause for the non-suppurative conductive hearing loss is autosclerosis, in where there is a fixation of the foot plate which leads to conductive hearing loss. This can be treated by hearing aids, surgeries, to prevent the progression with medical treatment also. Coming to the surgery, there is so many surgeries, variations from the erosions to the supinate to so many varieties. But small fenestra stapedotomy first developed by Shia in 1962, which was done by microscope. After 50 years of a microscope stapedotomy, Poyo develops a endoscopic assisted stapedotomy in 2000. Java Flove Nogoria in 2008 done a fully endoscopic stapedotomy. There are so many papers now. There is a meta-analysis and systemic reviews also, where they are telling that there is no proven advantage of endoscopic or microscopic, and they are telling that the sample size is small and the effective size is, that's why it is defective. So which needs a proper randomized double-blind controlled trials to confirm these things. So here we have done this study between 2016 to 2018, which sample size is 60. 30 are blocked randomization done to the endoscopic stapedotomy and microscopic stapedotomy, which are follow up to 12 to 18 months. These are the same indications, contraindications, where they will to have the target population and this one. These are the inclusion and exclusion criteria. To come into the success, when we will tell it is a success, when it is there is no result. So here, if the AB 8-bone gap less than 10, yes, you have a excellent work. When the 8-bone gap between the 11 to 20, it's good. At the same where preoperative and same, this is a poor. When it is decreased, whenever that, if you are doing any surgery, preoperative consultant to only tell. So what is the expected outcomes? What is the results? What are the complications? So we have to tell everything in this for the patients. So in this study, what we have done is we have the compare between these two extent of curettage of posterior superior external canal, time taken for surgery, post-operative hearing results, post-operative complications, and post-operative pain. So now if you go to one by one, you can see here in endoscopic stapedotomy, when you are coming to the incision, this is a panoramic magnified view. Whereas in case of, if you see for the microscopic, here we are using a single hand. Here, even though you use the speculum, you can use both hands, but the constricted view. As you know, the isthmus has to, the light has to go, so it has some constricted view. So coming to the elevation of TM flap, see, you can see here very big cotton ball. Why I am using? Because it is single-handed. What happened? Whenever there is a bleed, to control the bleed and to prevent the damage to the TM flap also I am using. But if you see the endoscopic one, even though your vision is constricted and not that much good visualization of like that, but here if you can see, I am using a suction. If you see, the field is very good. I am not telling that it is so both there is advantage and disadvantage. Here again you have to take very important is to prevent the damage to the TM flap, where there is chance of TM tear to the tympanic membrane. There you have to repair with the fat or temporal fascia. So coming to here, see visualization without any curettage. You can see the pyramid, stapedial tendon, anterior crura, posterior crura, facial nerve, everything, malleus and prostococcygeal, everything you can see without any curettage. But see here, barely you can see the includostapetal joint. When I am a student, postgraduate, there is no monitors at that time. Our professor told that, see, that is the includostapetal joint and that is the carda. For me, just I have to see the photos in the textbooks and I have to imagine, illusion, yes, it may be. But because of nowadays, all the postgraduates, because very lucky, they're having all the gadgets to see very clearly. So I told there is everybody thinks that endoscope, you can see everything, but to manipulate without curettage, it is very difficult to keep a piston. Everybody tells there is no need of curettage. You have to curate to manipulate your piston, but minimal curettage. But if you see in the here, you have to curettage more. Until where you will curettage in the microscope, you have to see the horizontal facial, you have to see the base of the pyramid. If you don't do, we don't know what the control. If you do more also, if you go up to the above, there is chance of subluxation of incus. So very difficult. If you go posteriorly base of the pyramid, the facial will be there. There is chance of facial palsy. So you have to know where, how much curate also you have to do. So coming to the carda. So here the carda is not coming in our way. You can see our area of target is foot plate. The carda is here. So there is no problem. But if you see in the microscopic, it is the middle of the surgical field. So our target area is occluded by our carda tympani. What you have to do? You have to make the carda away from the surgical field. That's why you are having more chance of injury to the carda. So there is chance of discussion, change of this one. So this is the main advantage of endoscope. Less chance of injury to the carda tympani. So coming to the stapedotomy tendon, I told See how I am facing difficult to cut the tendon because I am not created more bone. But if you see in the same, because so much of bone curate is easy to there. So everybody is thinking that no curate is, you have to curate something, but maneuvering is very, very important here. So you have to curate. The perforation of the foot plate. If you see here, I'm using a hand perforator where to perforate this one. There is so many articles where is micro motor or everything is because endoscopic is we lost the three-dimensional view. As you are making the more magnification, our three-dimensional will be lost. So better to keep the away from our field. Then we have that with experience we know. But whereas in microscope, we have that advantage of three-dimensional and two-handed. So measurement. In the measurement, there is no much difference between these two. We will measure from the foot plate of the stapes to the middle wall of the middle end of the long process. We will measure and we will add 0.25 to the what we have measured. In this, there is no much difference between the two things. Here, everybody, if you are seeing our seniors doing the stapedotomy, they're keeping the piston to the handle malleus to the or fenestra. We think that yes, it is easy. The easiest thing in the stapedotomy is this one. But for me, for the first case, I have taken 45 minutes to keep the piston. It's very difficult. For initiation, as you are having that practice made man perfect, simple. So as you practice, it will be. Here the one of the major thing where you can dislocate your ankles. So if they dislocate ankles, what you have to do? So everything you have to, before doing any surgery, my thing is, if the things go wrong, what we have to do next? You have to plan B, sometimes plan C also, if that's also not work. So preparation, don't prepare to fail. Here also, the main advantage here is you are having two hands. You can stabilize the handle of long process of fingers with one prick and you can negotiate. But here, Mubarak sir kept the two-handed. I have not used that. We have to see what the advantages now. I have not done that. For me, the main advantage of two-handed in the why I am not using it, just I will explain. I am not criticizing. Your extraordinary canal size is 7 to 8 mm. If the isthmus, it is 5 mm only, narrower. If you keep endoscope constantly, if you are single-handed, it is dynamic one. You can go out, go in, so your instruments go in, you can accommodate. So, endoscope constantly in the middle ear, the 360-degree rotation of my, and is very difficult for me. Sir is keeping very nice. Every time I have seen more than 10 times. Sir is doing very well. Maneuvering everything, and sir made the curved instruments also. But for me, somewhat I am difficult to maneuver those things. But I don't have these curved instruments, so I'm not used. But I have to learn how to use the two-handed. That this problem we can overcome in the endoscope. So here, what I'm telling, maneuverability and making the piston difficult. This video is taken from the Sriramut sir only. Sir only done this. So sir given a very good idea. So our target area is foot plate, posterior. So why want to keep your target in front of you? Why? So here you can keep the patient like this. And in this case, see what happened. Your posterior external canal will come into your view. The target area comes in front of you. It is not behind. And there is no need of much curettage also. See, in this case, very simple. And minimal curettage here also need to maneuver. But placing the piston is, see how easily you can see ponticularis, you can stability and on. So here, somewhat easy to this. I have not done 1 or 2 cases. This is we are learned from this Sriramut sir only. So this what we can experiment. So coming to the observations. Here we know that it is between the most of the cases between the 21 to 40 years. You know everybody is most commonly females. See why I kept this is you have to have a stratification where if you see between the 25 to 35 it is no, there is no that much difference between these two. So what are the problems I faced? most of the in this is we had injured the carda. Carda most commonly you injured in that stretched in the two cases and sectioned in this. But 4 to 5 months, most of the cases are regained their taste. But most of the time in the microscopy. This is the only advantage of comparing the microscope and endoscopy. This is the advantage. I already explained. The range of movements are decreased because of a constant, you are keeping that endoscopy external canal. So to increase our maneuver, we have to go accurate also. So these are post-operative things. I will go again. So these are the complications because you are entering into the middle year. So we have to explain them for 1 to 2 days if you can have, and you have to treat for, if you give 2 to 3 days, everybody in 3 days, most of the time people have regain their normal balance. Some people 1 week to, for me, it will take 2 weeks also. So coming to the results. So our main endoscopic mean AB gap is 35 plus or minus SD. So endoscopic, my p-value is not less than 5. So there is no statistically significant difference between the airborne gaps. So audiologically, there is no much difference between these two groups. If you take them operate time also, there is no statistical significance. Coming to the pain, there is statistically significant difference between the two groups because we are less curetase. That's why there is statistically significant. So time again, first endoscopy, it needs some learning curve. Yesterday I was seeing a steep learning curve. So it will take some time. But if you use it to it, there is no difference between these two groups. Here, how much bony curetase is for the endoscopic, maximum curetase is up to 2 mm only, but it may go to up to 5 mm. What I kept posterior and superior, both, I am telling. So coming to the discussion, I told already there is a, if you go to the National Library Medical database, we have the 5 systemic reviews and meta-analysis. That means there's so many papers when the systemic reviews are came. So the systemic review by Alexandros, where the endoscopic versus microscopic stapedotomy outcome, if you see the forest plot, the effective size is that not that much. So this is a confidence, this is the, if it is falling in the midline, there is no difference between these two groups. If you see here in effective size, that is the diamond, there is not difference between this. There is no statistically significance when it is, when you are seeing for the post-operative hearing results. See, another I told system review by the Nicholas. Here again, if you see for the airborne gap, there is no difference. But if you see for the post-operative dysgeusia, it is in favor of the endoscopic. So endoscopic stapedotomy is for the less damage to this cardiac tympani, less dysgeusia, less curetase, less pain. That is the only advantage. Another, in 2020 only, it is would endoscopic surgery will be gold standard for the stapes surgery in future. Because if you go to any otology conference, everybody is debating or fighting. I am an endoscopic surgeon, I am a microscopic surgeon. As I am, when I am studying, we are using only microscopic. I never think that endoscoping and microscopic is not a competitors. There is a complement to each other. We should not be telling I am an endoscopic surgeon, I am a microscopic. We are otological surgeons. We are in favor of for the patients, not for the gadgets. If anything gives good results, that is acceptable for the patient, not for us. So I am not telling that anybody is microscopic and microscope. Otological surgeons we are. So in this, he clearly mentioned that the small sample size and poor methodology quality are more for the ES surgeons. So it requires more randomized double-blind studies to see whether there is a clear-cut evidence or not. But by this, and what he is telling, it may be a bright future for the endoscopic, definitely. Because if you see in the so I already discussed all this. What are the disadvantages of endoscopic? There is loss of stereoscopic view. Now we have seen we are already using 3D endoscopics. So when they use 3D endoscope, we may, but I have used somewhat difficult one. That is also not that much easy. So difficulty in biomanual usual, we have to use for the endohold by our Mubarak Khan sir, and heat. There is more chance. There is theoretical. There are so many experiments done on the rats and rabbits with the 25, 50%, 75%, but the theoretical. But they are use the optimize. That's why aspiration 50% of lights. Optimize when you see very clear view, just keep there only. And the important is significant burden curve. But burden of learning this one. So better to start with the all things endoscope. Most of the time we will use our right hand to the when you're doing endoscope. Use your left hand and use your suctioner thing. So you will be hand coordination will be there. Some the PG only we have to find first year only you have to use the utilizing in the everything. Then you have a good hand-eye coordination. Of all these, I already told, when I am a postgraduate, I am in a hallucination illusion. I don't know. Even there is no thing also, I think, yes, there. There is no monitor at that time. I am seeing through the Bell microscope. First, what is the Bell microscope? I don't know how many may know Bell microscope. We can't see that much. Our processing see that, yes, I have seen. But see, because of the endoscope, the learning is very good. That's why I'm telling, even though I use microscope to demonstrate even septoplasty or it is a tonsillectomy or the MLS, everything, I definitely a microscope and endoscope should be there in my OT. For demonstration purpose, microscope will not come into the competition. Excellent visualization, but we can see every corners. If you keep it 0, 30, 40, 70, everything you can see. That's why for the learners, definitely it is a champion. So coming to the conclusion, there is no difference in the post-operative hearing results. Even though initial cases, stapedotomy take more time, as the time gone, there is no difference because the less curettage, less damage to the chordae tympani, less changes on the. Here, endoscopic stapedotomy, if it not superior to microscopic stapedotomy, it is as good as microscopic stapedotomy in view of your giving post-operative hearing results. Advantage is less chance of dysgeusia and pain. So these are my references. Thank you.
Thank you, sir. That was a great presentation.
You want to make comments after the questions or anything? After the all three, yeah.
So you can tell any.
A very nice presentation, Dr. Ramesh.
Thank you.
And but except I think even microscope has a very good thing for demonstration because of the cameras and all. They are very good.
Yes, sir.
So,
nowadays,
yeah.
Nowadays, everybody has I have seen Vijayendra sir demonstrations. I think endoscope also, but that depend upon the how gadget is. Sir is doing very good this one. Nowadays, I completely sir agree. But you have a very good this one, sir. And how to I try to show my PGs. I am failed somehow. I am not able to. It needs expertise to expose through the microscope, sir.
Okay. And secondly, I think so as a thing about thermal injury.
Arun Gadre from Danville, Pennsylvania. I'm forgetting where I'm from.
Good morning, sir.
I really enjoyed your presentation. Now, the question is, when you talk about double-blinded studies, how are you going to double-blind?
But here,
I mean, it's ethically impossible to do, right? You can't. It's really not possible. The other thing
randomization we can do, sir. Single blinded, sir.
Correct.
But having the good evidence, the level 1A evidence is from the meta-systemic review and meta-analysis of RCTs of double blind, sir. But here is not possible.
Exactly. So
not possible, sir.
So, for example,
single blinded we can do, sir. Patients we can tell that which we are doing, we will not tell to say. So single blind, randomized, you can do, sir.
Correct. So, but we have to be very careful about, in this day and age, we're always talking about evidence-based medicine, right?
Yes, sir.
Everything has to be evidence-based. You have to remember one thing, that absence of evidence is not evidence of absence.
True, sir.
Yeah.
Actually, in the systemic reviews also, sir, you are losing this systemic bias. That means the publication bias.
I'm not criticizing you, Dr. Ramesh.
Yes,
I'm
sir.
just making a comment, right? The other thing is, I enjoyed watching that picture where you're sitting on the opposite side of the patient. Do you know who is the first person who did that?
Sir, I know Sriram sir, he is the guru for, he learned everything, sir, endoscope, everything. I have seen from him only, sir.
Victor Goodhill.
Okay, sir.
So look at Victor Goodhill's work, the textbook. He's not spoken about surgery, but he has spoken about sitting on the opposite side. At UCLA, he was the one who was popularizing that a long time ago.
Sir, Victor Goodhill used to have that microscope and used to do the meninoplasties sitting in front of
In front of the patient. correct.
patients. Now, if you sit in front of the patient, your aim is posterior side,
Correct.
not the anterior side.
Correct.
That line from the greater superficial petrosal to posterior is a posterior side.
Correct.
Then your view is very, very, very clear, number one. Number two is your curating is not necessary at all. Number three is more accurate. That is a Ferguson's square. That means the square between the facial nerve, then tensor panel, the stapedial tendon, then long process of the incus,
Incus and
and pyramidal process. That's
Correct.
called Ferguson's square. The square is very clearly seen.
That's
If you are sitting posteriorly, your posterior crest will definitely obstruct your view. You can
Correct.
see that. You can verify
So the
that.
reason I mentioned this is for the younger people in the audience, when you're writing papers, don't forget to acknowledge those people. Because what happens is I sit on the review board of for the laryngoscope. And what happens is we oftentimes see papers where people are claiming, right? It's not they're trying to cheat. They're ignorant. They didn't know that this has happened before. So it's important to check your literature before you send it out. I think it's a good paper. I think you should publish it.
Okay, sir.
All right. Now, where it comes to curettage, for me, what was my problem was when I started to do endoscopic, because I was a student of Dennis Pope at that same period when we were starting to do endoscopic. We were at the Leahy Clinic. I was his fellow, right? Now, the problem for me was opening the forceps and letting go of the piston. If you did not cure it, you did not have enough place. So you could get the piston in and then you could not release it. So that was the problem. So you're absolutely correct. And Mike Paparella was the one who, said you should see the facial nerve, you should see the base of the pyramid. I'm not so sure you really need to see the base of the pyramid. And you're also correct that if you overcure it, you will get hypermobile incus.
Incus.
So very nice presentation. Congratulations.
Thank you, sir. Thank you very much.
Thank you, sir. I would like to call Dr. Sanchita Kalita for the next lecture. Thank you.
Check. A very good morning to all. First of all, thank you, SEOCON 2023, for allowing me to deliver a lecture in this respected podium. The topic which I'll be presenting today is a tryst with endoscope in otology. Now, there are so many varying uses of endoscope in otology practice. What I have done is I have curated some cases where we had very favorable results by the use of endoscope. And we had also used microscope. It's not an exclusively endoscopic ear surgery I'm talking of, but how we can use endoscope for better results. Starting off with a simple endoscopic examination in the OPD. This was a case of bilateral autosclerosis. And a quick look into the tympanic membrane in the OPD, and we had this picture. It was a very flaccid drum, both sides. So this changed our decision to go directly to a stapes surgery, to a staged procedure. We went first for a cartilage tympanoplasty and then went for a second stage stapes surgery in this case. In this case, it was an intact tympanic membrane, and we can see this bluish bulge. In PTA, it was showing moderate conductive hearing loss, and there was also CT evidence of ossicular erosion in this particular case. So we decided to first have a look transcranially with the endoscope. After lifting the tympanomeatal flap, we opened up the Prusac space and we saw this golden greasy fluid coming out, cholesterol granular crystals. Of course, the ossicles were eroded. But what I would like to focus here is after removal of pathology, there was this particular bony bulge at the eustachian tube opening, and we knew that this was probably the primary pathology, which was drilled and removed. And this patient has been followed up for a long time now, and it's having favorable results. There's no recurrence. This was a case of attic cholesteatoma with granulation. On the pure tone audiometry, we found that there was mild conductive hearing loss. So here in this case, we had to be very careful, because if at all the hearing would be, we can preserve the hearing, we should do so. So we went for a transcanal endoscopic approach. After opening up, we removed this cholesteatoma sac from the attic region. Then the attention was particularly focused onto this granulation tissue around the ossicular chain. Now, with this direct visualization with the endoscope, we could achieve removal of this granulation around the ossicles without causing any harm to the ossicular integrity, and we were successful in doing so. Now, this was a case of extensive cholesteatoma. On CT scan, it showed there was already automastidectomy done. So we thought, let's look up transcanally first, what's the picture? So when we went inside, we lifted the tympanomeatal flap, we saw that there was already gross erosion there in the mastoid region. And there was this infiltrative cholesteatoma matrix there, which was removed. And we can see that there's no evidence of ossicle till now, and the horizontal tympanic facial canal is evident there. After removal of the cholesteatoma, the canal wall down mastodectomy was completed transcanally, and then this granulation was removed from the tympanic area. After removal of this granulation, we saw that the stapes foot plate was present. And even after removal of all these granulations, when we had a closer look, we found that there was this bit of granulation still there in the round window niche area. Now, with this direct visualization, quite a magnified view, we could successfully remove this. And in this case, actually, the patient had severe mixed hearing loss, and we were able to have hearing gain in this patient. Now, this particular slide is to focus on microscopic, endoscopically assisted cholesteatoma surgery. Focusing on two cases. In the first one, we can see that there is extensive cholesteatoma also going to the supralabyrinthine and protympanic area. So after clearing out by microscopic approach, we decided to have a look with the endoscope into the whole middle ear cleft. And here we could see some residual cholesteatoma still there in the supralabyrinthine and protympanic area, which was successfully removed with the help of this endoscopic visualization. In the second case, also, there was extensive cholesteatoma, which was removed. And then in the end, there was this bit of cholesteatoma still there in the supratubal recess, which was removed microscopically. Then we had a look with the endoscope, and there was still this amount of cholesteatoma there in the deep-seated pocket, which was removed endoscopically. Now let's talk about the role of endoscope in cochlear implant surgery by posterior tympanotomy approach. Of course, experts would not require this, but for people who have just started off with cochlear implant surgery, whenever there is any difficulty of visualization of the round window niche area, what we can do is we can have a quick look with the endoscope, and this round window niche area, the hypotympanic cell, it becomes very clear. And after proceeding further microscopically and removing the bone in the round window niche area, we can have a clear picture of the round window membrane. We can take this a step further by endoscope guided active electrode insertion. We can have a direct view of the round window and then go for the active electrode insertion. Now, the role of endoscope in lateral skull base surgery, I am showing two cases. The first one was an acoustic neuroma case where there was profound hearing loss. So in this case, after microscopically drilling and everything, the neurosurgeon was given this endoscopic picture after labyrinthectomy, he could go for a complete tumor removal. And this was the picture after complete tumor removal, the neurovascular bundle there in the CP angle. The neurosurgeon was very happy because there was no post-operative neural deficit. The second case, it was done by a minimally invasive retrosigmoid approach for an epidermoid cyst in the CP angle. I'll show the endoscopic picture which the neurosurgeon had. Here, we can see that the cyst was seated just near the neural bundle. And with this direct visualization, the cyst was opened up, the fluid was evacuated, and there was complete removal of the cyst. And thankfully, there was no neural deficit in this patient. So it was a win-win situation for us because the neurosurgeon was very happy and he wanted to do all cases with us after these two cases. Yeah, we also tried with exoscopic ear surgery. This was actually our adaptation. So what we did is we took Hanser's Justach, mounted it on the microscope, and then we used the laparoscopic 10 mm port, 10 mm scope, and then also the laparoscopic port for stabilization. And the picture which we got was this. Of course, it cannot match the Storch exoscope picture, but good thing is that we have asked the Storch people for demonstration, and possibly if we can procure it, I'll have better videos for presentation next time. Now, to summarize, if we have to optimize the use of endoscope in otology, we can near about achieve a very good hearing preservation surgery. It is very useful in exploring every corner of the middle ear cleft and beyond for removal of all pathology there. And if I may say, endoscopic ear surgery plus the use of exoscope, it might also eliminate the need of procuring high-end microscope, especially in developing or underdeveloped countries where procuring these high-end microscope is still an issue. I cannot conclude without paying my regards to my hospital, Pratiksha Hospital, Guwahati, under the able mentorship of Dr. Gautam Khan sir and Dr. Bishajit Gogoi sir. Also, thank you, Dr. Mubarak Khan sir, who first introduced me to the world of endoscopic ear surgery. It was like an eye-opener for me. And thank you, Sir Prasuti and Professor Marchioni sir, for bringing up these wonderful textbooks and atlas, which were of a great guidance to us. With this, I would like to conclude my presentation. Thank you.
Thank you, Dr. Sanchita, for a wonderful lecture. Any questions, any comments?
Yeah, I have a comment.
Yes. Sir.
I think I have to visit your center and come and learn from you now. It's lovely, lovely work, and particularly the posterior cranial fossa was.
Thank you, sir.
We've been using it for even posterior cranial fossa that is extending into the internal auditory canal. You can still go retrosigmoid with a 30-degree endoscope, look inside.
Yes, sir.
And use a cup forceps to deliver the tumor out into the cerebral pontine angle.
Yes, sir.
So there are lots of advantages. The biggest problem with hearing preservation in posterior cranial fossa surgery is the blood supply, because these are all end arteries.
Yes, sir. Yes.
And so it's coming from the brainstem, it supplies the tumor, and then goes out to the labyrinth.
Right.
And one of the other tricks that I learned from Noel Cohen was to use papaverine. So if you have papaverine in your office, and if you're monitoring ABRs in real time in the operating room, you can put papaverine and you'll see your ABRs improve almost instantaneously. So that's just a tip that you could probably use.
Thank you, sir.
Is it going to be durable hearing? I don't know, but excellent presentation.
Thank you, sir.
Excellent presentation. I think you have shown a lot of things, especially the lateral skull base. Very good. Thank you so much.
Thank you, sir.
The first question on your first case where you showed the bulging drum.
Yes, sir.
How did you diagnose the otosclerosis on CT scan, or how did you?
No,
because
sir.
you on tympanogram you'll probably have.
Sir, the first one, sir.
Yeah, yeah.
I'll show you, sir. Just turn my screen. Yeah. One second. So it was already like the PTA was done in this case. So it showed moderate conductive hearing loss with, there was this typical Kahat's notch and bilateral AS. There was this typical picture of autosclerosis. I was showing this because it's pretty interesting to have this picture on Valsalva.
You shouldn't get a AS
Yes,
impedance.
we got AS in this case.
The thing is, you may get a type A, you may get an AD type of curve with a that,
Yes, sir.
that
Yes,
thin,
sir.
thing. So
Yes, sir.
it was hypermobile. Also, that flaccid segment
Yes, sir.
almost behaves like a perforation.
Right, sir.
So
Right,
you'll
sir.
have a low frequency conductive hearing loss just when you have
Yes,
this.
sir. So we verified again and again. They were like very sure. Yes, it's AS. I'm like, okay, fine.
So did you check the mobility when you did the first stage operation?
Yes, sir. So it was like an exploratory tympanotomy. So we
Okay.
checked the staples, whether it is an autosclerosis case or not. And then we went for a second stage surgery.
Okay, very nice.
Then what did you do? You put a cartilage graft to stick
Yes,
in the
yes.
drum?
We used cartilage.
Did you excise that flaccid segment or left it alone?
We excised it.
That's-
Thank you.
Thank you, sir.
Thank you, Dr. Sanchita. I would now like to call Dr. Sriram Murthy, sir.
Where is my?
Here, sir, pen drive is here, and this is your video, right?
Play that.
Yes.
Stop.
Yes.
I'm. Yes, okay. I am Dr. Sriram Murthy, ENT surgeon, South India, Visakhapatnam, South India. Before starting my lecture, I would like to pay my gratitude to the Professor Marchioni, because as an assistant, I was with him for so many days, so many months, not days, so many months to learn the endoscopic ear surgery, what. Nowadays, everybody is saying endoscopic ear surgery is limited to the middle ear and external ear. The levels of the endoscopic ear surgery is level 1, tympanic membrane, level 2, middle ear cavity, level 3 is stapedotomy and cochleectomy, level 4 is internal artery canal, level 5 is CP angle. Now we have to pass, because I am regular visitor of the Europe. I know every once in 3 months I go to the Europe. This is a case presentation. This is a case presentation. Well, yesterday you have seen beautiful dissection of the Professor Marchioni, the cadaveric dissection of the internal artery canal through the transmeatal. Now it is a live, because this patient, 35 years or 40 years old, intractable years, because dropout attacks are so many. He was treated all the medications and everything. He was even treated by Jack Mannion also with medicines, but it was not. Now, the hearing is completely lost because he is medically some unfit fellow, and we have done via the transmeatal vestibular neuroanatomy. It is a very simple procedure for you. You have to learn, because we are all should not be limited to the middle ear just at us. It's a good, but you have to extend your knowledge, because you are good anatomist and you know everything. The distance between the stapes foot plate to the distance between the stapes foot plate to the internal carotid artery is 7 millimeters, because God has given 7 millimeters space for you to do whatever you like, except that internal carotid artery, like that, so many things. Now I want to show my case of the vestibular neuroanatomy. It is a case that we have taken recently. I am a vice president of Indian Society of Otology. we are giving the degloving incision completely. We will remove. In these cases, we don't do the brain sac approaches. We only do the complete blocking and putting the cartilage tympanoplasty. We have done a lot of cases. If the case is really a complete deaf, we will do this. If the case is really hearing case, we will do endoscopic fully mid-fossa approach. That is our theme, completely mid-fossa approach by Professor Canani of Marseille, France. I was trained with him. It's very easy to do the mid-fossa with Canani's approach. Now we are remove completely the tympanic membrane. Is a 20, I have been given 20 minutes. It is within 17 minutes.
Professor, are you, in this case, are you sitting on the face of the patient or the back of the patient? What is your orientation?
No, it's a friend. It's a friend. It's a friend. Because for stapes like that, to see the retrotympanum, we used to facial nerve decompression. It's very easy for sitting friend.
But this one is usual position.
Is usual position. Now we have removed the ossicles. This is a cochlear process. This is a cog. This is a vertical tensor fold. This one. Then how to identify the internal artery after seeing the middle ear is very important. This line, you remember, this is a line of 3 ridges by Gurrier. The inferior border of the horizontal part of the facial nerve corresponds to the vertical crest of the vestibule. Second, the opposite side, it corresponds to the transverse crest of the fundus. The 3 crests are at the same level. That means it should be near. Suppose if you take this upper part of the facial nerve, this is the top of the vestibule and top of the internal artery canal. These 2 points you have to be in mind before doing all these things. This is a line of 3 ridges by Professor Gurrier. Is a great anatomist, great anatomist of the French. Facial nerve, that is a superior petrosal artery. Actually, this specialty of the artery is it runs between the epineurium and periosteum. That's why it is very visible. It's not gestatus, it is a single-handed. It's no gestatus, all these things is a very single-handed. I cut the stapes tendon. Now we remove the stapes. Now, I was a resident of Professor Fish for 1 year. Fish is always used to say, you take a horizontal line like this center, just below the horizontal line at midline is a point of insertion of the stapes piston, because it is the deepest area. Don't go anterior. Suppose if it's because our mind, suppose if it's a flight driver or divers, we will put the piston little posterior because it is a deepest area. But the only problem here is if we put a piston little posterior, the angulation is little bit obtuse. The 10 decibels hearing loss will be there. It is a scientific theory from Alexander Huber from the Zurich. That's why this is the center. This is exactly horizontal line. This is the center. The piston should be inserted. You can insert 0.5 mm deep inside without any trouble. This is the only surgical point of here. Your another main point is this cochlear form process. This cochlear form process is exactly opposite side the Bill's bar. Suppose the Bill's bar is an indicative outside by the cochlear form process. If you exactly go medially, it is a Bill's bar. That means the facial nerve passes anterior, the vestibular nerve passes posterior. This is the indicator of the Bill's bar. There are the 18 points about the cochlear form process. You can study very clearly the cochlear form process. This we call a bast crest. Bast crest is very important, very important. Bast and Anson, they are the very great anatomists. This is a macula. Deepest part of the vestibule, right? From here, it is a 8 millimeters because God has given you a place like this. It is an initial approach for the transcochlear and transaortic approaches. You have to do this procedure before transcochlear and transaortic approaches. This is a Jacobson's nerve. Don't remove the Jacobson's nerve because Jacobson's nerve maintains your ventilation of the middle ear, sir. I have attended 5 memro meetings, middle ear research meetings, because Jacobson's nerve gives a beautiful ventilation to the middle ear. Once you remove the Jacobson's nerve, automatically after 3 months, it is an evidence-based. 3 months, the tympanic membrane will be collapsed. This is an evidence-based. It contains a lot of oxygen ventilatory chemoreceptors. It gives central stimulation. Then the eustachian tube will open because Jacobson's nerve is such an important nerve. This is a Jacobson's nerve. This is a lesser keratotympanic. This is a Jacobson's. Then lesser supraepithelial nerve. That is the inferior vestibular nerve area. This is the anterior space. We are going now the Lampert's approach to the Petrus apexis from this. This is a place we are drilling exactly under the anterior half of the anterior commissure of the foot plate. That is the area what Professor Marchioni was telling. That is a cochleovestibular crest. That is a cochleovestibular crest. We are drilling. Suppose if you want to put the cochlear implant, you go little towards the vestibular side to preserve the cochlea. If your patient doesn't want, you can drill little bit towards the cochlea. That is the main area. I have already opened the internal artery canal. That is a vestibule. That is a foramen of Putigno. You know, foramen. That is an inferior cochlear vein foramen. There is cochlear duct and inferior cochlear vein passes along that foramen of Putigno to go deeper. That is a Putigno. There is a scala vestibuli, scala tympani. That is the dura of the internal artery canal. The leaking is there. This is the most dangerous area where the facial nerve comes from the labyrinthine part, enters over here. This triangle is called periceous triangle. That periceous triangle, the facial nerve parts, is exactly mirror image from the horizontal canal with 70-degree apart. So both are the same. That is the area we have to drill for the internal artery canal. That's opened internal artery canal. Now this is the first we see in this transpromontory approaches. One is the inferior vestibular nerve, second is the cochlear nerve. Above is superior vestibular nerve and facial nerve. These are the sequences we have to see. It's not like the translab approach. It is a transmeatal approach. We are very clearly seeing. This is the inferior vestibular area. Inferior vestibular nerve. The deep is a facial nerve. We are cutting the nerve. Thank you. Once you cut, this is a cochlear nerve. See the direction of the cochlear nerve towards the modulus. There is a gap between the facial nerve. That triangular gap is very, very, very important. Otherwise, you will knock off the facial nerve. This is the superior vestibular nerve. This is a cochlear nerve. This is a facial nerve. You see the direction, it's going like this. The triangle between the facial and cochlear is very important to identify the R2 nerves. These are very important. Before starting, we give the 8 mg of decadron, then mannitol drip. Otherwise, the CSF will be very, very, very more. We'll start. Now we are seeing very clearly the cochlear nerve. After cutting the inferior vestibular, that is the inferior vestibular, that is a cochlear, that is a facial nerve. The turning of the facial nerve is like that, is going into the internal level. This is a superior vestibular nerve. So at the superior level, you see the two nerves. One is anterior is the facial and posterior is the superior vestibular. Inferior level is cochlear and inferior. We are cutting the superior vestibular nerve. All the three branches. Number one is for ampulla of the superior vestibular superior canal. Second is arterial. Third one is lateral ampulla of the lateral sensory canal. All the three we have to cut. This is a Scarpa's ganglion. Sometimes it's only one problem here is sometimes the labyrinthine arteries comes too laterally to come to the fundus. That is a danger you have to be in mind. This is actually the porous. Suppose if you want to do only a cochlear implant, you cut down that, you come little superior. You remove this budge also. We can see more clearly the facial nerve. This is a meatal point where the facial nerve turns into the internal artery canal. This is a meatal pointer. This is a meatal ring, according to my professor, Fish. This is a meatal pointer. Meatal constriction. Meatal foramen, otherwise. That's why, to my mind, we can't approach the meatal foramina through the transmastoid approach. That is, to me, is very clear. Now that is a superior vestibular nerve, all the three branches, including scarpas. What we are dissecting is a scarpas ganglion. If we do simply the vestibular nerve, superior, inferior, without scarpa ganglion is really not good. We have to cut the scarpa ganglion. Now we are very clearly seeing the facial nerve, cochlear nerve, the cut ends of the both superior and inferior vestibular nerves. This is a cochlear artery. This is a cochlear artery. This is a porus. The turning of the facial nerve. This is a thank you very much. This is a very simple approach for the vestibular neuroanatomy. If the patient is having hearing, not hearing defect, we will do the mid-fossa endoscopic, fully endoscopic, no retractions, nothing. If the patient is having complete deaf, we do this transpromontory approach. This is, thank you very much for your kind attention. Do you ask any questions? I will tell. So the beauty of this was done under local anesthesia. Oh, that is great. This was done under local anesthesia. You see the brain, how it cooperates with the local anesthesia. Because I opened so many retrolab approaches with local anesthesia. Patient kept very quiet. After 5 o'clock, I asked him while I am cutting the vestibular nerve. He said, "Oh, it's a tremendous vertigo, sir. I can't." Because that is only momentary. Unless otherwise it's a local anesthesia, it was done. It's very safe, like a stapes surgery. It's very safe, no bleeding. Thank you. Any question? Yes, that's good. Nowadays, I recently visited Poland. The best, I know Professor knows very well. Previously, we used to have a fat. Nowadays, we are taking the temporoparietal fascia, temporalis fascia along the temporalis fascia with temporalis muscle. We'll completely cook up the temporalis fascia, temporalis muscle, including fascia, plus eustachian tube with the muscle of the malleus. We will remove the muscle of the malleus and put it inside with additional fat. Now completely middle ear is filled with fat. Again, we put a cartilage tympanoplasty. Wow, that I don't do it. Blind sac closures because I have to experiment. I have done a lot of cases, no leaks so far for the past 5 years. Temporal, we take the temporalis muscle fascia, we'll cook it up inside. Then second thing is we'll close completely the eustachian tube after roughening of the eustachian tube with a malleus muscle, that is the tensor simple, and put it over which we will put some fat. No, I didn't fact because it's a miliary mucosa, it is only cuboidal epithelium. Except eustachian tubal end. Otherwise, it's a cuboidal epithelium for the ventilation, not for secretions. Okay, it is a ventilation. Really, it is a very peculiar thing. The posterior part is ventilation, the anterior part is little secretions and all these things. But is most of the okay, we did it. Most of the middle ear mucosas are lined by cuboidal epithelium, mainly for ventilations. Okay. Anything? Thank you very much, sir, for giving the chance. Professor.
Thank you, Dr. Sriramurthy, for an excellent presentation. I request the moderator, Dr. Joban Putra, to honor Dr. Sriramurthy. I request Dr. S. Ramesh to come forward and receive the honors from Dr. Ritesh Bhagyavant. I request Gadre sir to felicitate Dr. Sanjita Kalia. Thank you. I now call upon Dr. N.V.K. Mohan for his presentation.
Good morning, ladies and gentlemen. At the beginning, I would really like to thank my good friends, Mubarak Khan and Sapna Parab, for inviting me here and giving me this honor of addressing this august audience. Dr. Sriram Murthy is a very tough act to follow. And Dr. Sanchita also made a wonderful presentation, but I'm going to stick to the basics. And this is primarily aimed at any juniors and any beginners who are there. So I'm going to talk about the surgical anatomy relevant to endoscopic ear surgery with a special emphasis on cochlear implantation. And that's my team. I'd say the beauty and the three beasts, or the three idiots as we call ourselves. That's Arjun Shiro and myself. We've been working together as a team for the last few years in Kolkata. We all know cochlear implants have revolution as treatment of severe to profound sensorineural hearing loss. And endoscopic ear surgery is now an established form of treatment for diseases of the ear, even threatening the existence of the microscope now. Both these fields are expanding, and our knowledge base is also expanding because of the extensive work that's happening. But what is fundamental is that knowledge of the anatomy is absolutely crucial to have, prevent complications and have good outcomes. So there are standard landmarks that we all use. I mean, I'm not going to go too much into the details. The lateral semicircular canal, the digastric ridge, the stylum foramen, posterior semicircular canal, and the chorda tympani nerve. This is the standard landmarks that we use for, a posterior tympanotomy when we are doing a cochlear implantation or even mainly surgery. Word about the orientation of the facial recess.
Sorry to interrupt, but we are starting with the case here in the OT.
Okay, right. So I'll just continue. So this is a quick, reminder about the orientation of the facial recess. So this is the superior part of the lateral part of the,
the case of left mucosal COM.
kind of horizontal.
The main surgeon for this
when we are,
OT is the doctor.
looking at it from the
sir.
surgeon's standpoint.
Excuse me, sir.
Yes.
Hello, OT. Can you switch off your mic? Yeah. Sir, please continue.
Right. So this bone is nearly, oriented horizontally when from a surgeon's perspective when we are operating. So the direction of the burr would is better, more vertical and parallel to the posterior canal wall rather than going horizontally like this. In which case we actually run the risk of suddenly hitting the bone giving way and we hitting the ossicular chain and jeopardizing any residual hearing. So that's a quick thing that we need to remember. And if you look at that, that's the pyramidal recess. This is the facial pyramidal process. This is the facial recess, and this is how we want to go in so that we don't injure the ossicles. I'm not going to dwell on this. We all know all these structures. There was this wonderful study by Shraddha Jain et al., and this was published in the International Archives of Otolaryngology. They did a study on a few, about 50 Indian temporal bones to, assess the dimensions of the facial recess in, the Indian population. And what they found that they, well, we all know that the the chorda tympani arises at a variable distance from the stylomastid foramen, and they found this to be in their study the distance to be between 2 to 5.5 millimeters. And there are multiple variations that can happen, as in the nerve can bifurcate in the posterior canal wall, or it can start origin at the level of the lateral semicircular canal as well. And that would be sad, because in that case that nerve would need to be sacrificed when we are doing a posterior tympanoid paracochlear implantation. The chorda facial angle that they found in the Indian population was about 25 degrees. Also, what they found that the greater the pneumatization of the temporal bone, the longer was the length of the facial recess was longer, and also the greater the angle of the chorda facial angle. Now, and the maximum dimensions, they found was about around 2.93 millimeters. That's nearly about 3 millimeters. So that's something that that we need to keep in mind. And where do you get this maximum, width of the facial recess? They found that this was about 3.5 millimeters away from the short process of the incus. So that's the area where you get maximum, dimensions of your facial nerve. Facial recess. And width at the level of the round window, that's about 2.65 millimeters. So if you have a diploic bone, then you expect trouble when you're doing the facial recess, right? Now, I've taken the liberty of borrowing very extensively from Professor Daniele Marchioni. So I'll talk about the retrotympanum. So the midline of the retrotympanum has got two major prominences, that is the pyramidal eminence and the styloid eminence. And quite often when we are doing a posterior tympanotomy, we find that there is a ridge of bone that connects these two, and that is called the pyramidal ridge. Now, this pyramidal ridge actually obstructs the view of our round window membrane or the round window niche area, and this can be present nearly in about 60 to 70% of the population, and that can cause an impediment, and you need to take that down when you're doing a cochlear implantation. Now, the round window prechamber. The round window prechamber, it consists of the round window membrane, the round window niche, and the round window niche itself is formed by the this is the posterior crust. This is the anterior crust, right? And this is the canopy, or the canon, as they call it. Now, this entire region is the prechamber. And this the round window membrane is actually located anterolateral to the hook region of the cochlea. Now, we all know the subiculum, right? It goes towards the there we can see this subiculum, and this is the funiculus. That's the ponticulus going towards the pyramidal recess. Now, the funiculus actually divides the demarcates the region between the inferior retrotympanum and the hypotympanum, and kind of points towards the jugular dome of the jugular bulb. And the space between the subiculum and the funiculus, this region is the sinus subtympanicum. Now, the fustus is a very important landmark that we need to keep it. Sorry, what? Oh, I'm probably touching the touchpad. So the fustus is a very important landmark for us when we are doing a cochlear implantation. Professor Daniele Marchioni demonstrated yesterday wonderfully that the fustus is actually pointing towards the round window niche, round window membrane region, and it actually forms the floor of the sinus tympani. So it and the And this area around the air cells that develop around the fustus area, this is called the area proctus area of proctus area concomerata. And between the fustus and the funiculus, between these two structures, you can have the developed subcochlear canaliculus. Now, why this is important is that sometimes if this is a very well-developed subcochlear canaliculus, this can be mistaken as being the sinus tympani, and people have been known to insert electrodes there erroneously. So as long as we stay above the fustus, we are safe, right? So subcochlear canaliculus, I'm not probably going to go much into detail about this. There are three types. Type A is where it's pneumatized right up to the petrous temporal bone, and this is the type of subcochlear canaliculus that we must be wary of when we are doing a cochlear implantation. We will study that on the coronal sections. You can see this well-developed area. So the type B and the type C are lesser pneumatized, where type C, there's hardly any pneumatization there. And that is the importance of the subcochlear canaliculus. Electrodes can be placed in this region. A quick word about the cochlear orientation. The cochlea is like a cone, and the base of the cochlea, the basal turn, is actually directed laterally and inferiorly, while the apex is actually pointing towards the tensor tympani tendon. It's just anterolateral to the geniculate ganglion, and it points towards the tensor tympani canal, right? So the reason this is important is that the long axis of this cone will represent the situation of the site of the modulus. So when you are inserting the electrode, you have to keep that in mind so that you do not hit the modulus, right? A quick discussion about the cochlear hook region. This is of very major importance for us. What happens is that the proximal part of the cochlea, which is actually what the hook region is, it is in this area where all the cochlear compartments make a 90-degree rotation. So what starts off as a horizontal part, the osseospiral lamina, the basilar membrane, and the spiral ligament, where they start off as horizontal here, and then they assume a more vertical orientation. So when you are inserting the electrode, when we are doing a round window membrane insertion, so we have to be aware of this region so that we do not strike the basilar membrane and cause fractures of the delicate intracochlear structures. However, having said that, the sinus tympani still kind of follows up approximately straight line until the first cochlear turn, which is about, say, 9 millimeters. I would around 9 millimeters. So if you are angled down and inferiorly and anteriorly, that's when you get a better trajectory. So that's how the orientation changes. Now, if you look at this picture, this is the round window. This is the spiral lamina. This is scala tympani, scala vestibulis, the spherical recess, and the vestibule here. This is the pyramidal eminence here. This is the fustus. See, look at the fustus. So it is pointing, towards the floor of the sinus tympani. So if you remain above it, this is how it goes. And look at the way it's turning. It's horizontal here, and then it assumes a more vertical position. So you have to be aware of this so that you don't go and directly strike the spiral lamina, osseospiral lamina, and cause a fracture there. Now, this is a picture of, taken from this, study by Starovoit, and shows an optical coherence tomography picture of the crista fenestra and the, secondary spiral lamina. Now, these are the secondary spiral lamina is here, and the crista fenestra is here. The crista fenestra is anterior inferior to the round window membrane. Now, these two bony projections actually narrow the entry point, and sometimes you can have a very well-formed crista fenestra, and you need to take that down to actually get a better trajectory to insert your implant. Now, another quick word about drilling in difficult situations where you have a ossified basal turn, or you're doing a cochlear drill out. The two important things to remember: one is, how do you access the middle turn if you have a ossified basal turn? Now, Yesterday, Professor Marchioni demonstrated very beautifully. You drill just below the processus cochleariformis medially, and that's where you get the lumen of the middle turn of the cochlea. So you can access that there. So just below the processus cochleariformis, you drill the bone, the otic capsule, and you enter the middle turn of the cochlea, right? And also, if you are drilling the basal turn, you would want to remember that the internal carotid artery is about 12 millimeters from the round window membrane. So you've got 9 millimeters, around 9 millimeters of the length of the basal turn, and around 2 to 3 millimeters, sometimes it can be a bit lower also, is the internal carotid artery. So you've got to be careful about that. So just a CT scan image just to show you. This is the processus cochleariformis. This is a tensor tympani tendon, and this is where the middle turn starts. This is a basal turn coming up and merging into the middle turn here. And this is where you drill medially and you get the middle turn. So just to sum it up, knowledge of anatomical landmarks, we all know, is the key to successful surgery and avoiding complications. The facial recess gives us access, and as long as we are aware of the dimensions, and Professor Gadre demonstrated yesterday very beautifully, the length of the the body of the incus and short process of incus along with the malleus, that distance from the short process of incus, that is where the facial nerve will lie. So you keep that in mind as well when you're opening the facial recess. More pneumatized than mastoid bone, the wider will be your facial recess, so it's easier for you. And proper identification of the round window membrane is always vital, so you do not end up entering the subcochlear canalicus. And the fustus is a wonderful guide in that matter. And we have to be aware of the hook region and the changing cochlear orientation of the scala tympani when we're doing a cochlear implantation. Thank you very much.
Thank you, Dr. NVK Mohan, for an informative presentation. I request Dr. Sandeep Sindhu sir to do the honors for him.
Action? Yes. Good morning, one and
Danny,
all.
please ready.
We are starting with our OT here.
Yeah, please. Yeah, for this session, I request.
Good morning, one and all.
Dr. Rajiv Yande is a leading ENT surgeon from Pune.
We are starting OT here in Dr. D.Y. Patil Medical College, Pimpri.
Okay. Yeah, please.
Our OT is headed by Dr. Daniele Marchioni. We are starting with our first case, who is Sadhna Kalbhor, 41-year-old female, who is a case of bilateral mucosal COM. She
Cottonoid with the adrenaline.
Pune, Dr. Shailesh Pandey from Mumbai, and Dr. Ashok Gaikwad, a leading ENT surgeon from Nagar.
Our first patient for today is Sadhna Kalbhor, 41-year-old female, who is a case of left mucosal COM. The patient came with chief complaints of right ear discharge since 5 years, which was insidious in onset, gradual in progression. The discharge was intermittent, moderate, mucopurulent, non-blood tinged, and foul smelling. She also gives a history of left ear discharge since 2 years, which is insidious in onset, gradually progressive, intermittent in nature. The discharge was scanty in amount, yellow, foul smelling, and non-blood tinged. She has a history of right ear reduced hearing since 2 years. This is her otoendoscopic picture, which has medium central perforation in posterior-inferior quadrant. On pure tone audiometry, she has bilateral 32-35 decibel hearing loss. Now, I would like Daniel, sir, to take over.
Can you hear me? Can you hear me? Hello.
Yeah,
Good
yeah,
morning,
yes, sir,
Professor.
yes,
We
sir.
can hear you.
Hello. Yes, sir,
Hello.
yes, sir. Good morning. Where with you?
So this morning they asked me to do this patient with a perforation of the extent of the eardrum.
Yeah.
So we are doing the preparation. We put a cottonoid with adrenalinic solution, and we have just to wait. The plan is to do the meringoplastic with the cartilage.
Okay.
Is,
Yes, sir.
so we are just wait a little bit in order to have a good anesthesia in the skin, and after we can start. Usually I'm doing the incision with the monopolar Vesalius, but of course I think that is not possible here, so we can try with the ram knife, because with the monopolar you can have less bleeding, of course, and you have to maintain the monopolar in low power, and after you can raise the flap. In this case, of course, I don't think that we have a monopolar. We have a monopolar. No, it's too big. You can see that this is monopolar. It is not possible to use in the canal. You need a smaller tip, so we can do incision with a round knife. And the plan is to raise the flap over the malleus and put a cartilage graft. And I call this graft composite graft because it's a perichondrium and the cartilage. And so we will see. We will see. What's that? A crocodile. So now we can check the objectivity of the patients. Okay. So you can see here the perforation. Do you have a sickle knife? Now we can refresh the margin of the perforation, and I'm expecting a little bit of bleeding because probably there was an infection around. But anyway, okay, I think that is already sufficient.
Professor, we see some amount of myringitis.
Yes.
Is
there
that a cause of
myringitis.
concern?
Okay, but the bleeding is good. Cotton ball. No, now I'm using a 2.7 endoscope. The best endoscope to do the one hand. The endoscope just like this. The camera, it's you can see the distortions of the camera. So this is because it's too small. And instead, with the 3 mm, you can have a good view without distortion, and probably is the best camera for a one-hand endoscopic approach. Okay. I just. Of course, in this case, we use underlay technique. A round knife. This is really big, but anyway. We can do the incision. It's really important, go over the malleus. And we can start to erase the flap. Cotton balls.
Professor, you raise, this is, as we can see here, it's a small flap. Is that,
Yes.
is that what you do regularly, or it's a case dependent thing, whether the size of the flap is smaller or bigger depending on what you see?
In this case, because I'm expecting that I have just to work in the mesotympanic eardrum, I needed to do a large flap.
Okay.
And so I think that is sufficient. And after with the bipolar, do we have the round knife, please? Round knife, okay. Difficult to cut. Okay. Cotton balls. Suction. So it's really important to use the cotonoid with one hand because the cotonoid is your friend. You can see that you can maintain clean the surgical field. And you are able working close. This is the coda.
Yeah.
But now you can see that there is something bleeding here. It's so with the bipolar, sometimes you can have the best control. No, give me another cotton balls. I just want to use this cotton ball because in my department, we are not able to use the cotton balls, but we have just to use a huge cotonoids with you know, the landmark, it is not good. Anyway. So now we are push a little bit the cotton balls. And we can check the situation here. L'aspiratore, cazzo. Non si pulisce molto. Okay. We can start to see here the annulus that is here. The cord. Okay. We are in a sickle knife. Sickle knife. Really important to following the annulus because there is a granulation tissue inside and the plane of the cord. Okay, suction. Now we can remove the cotton balls.
Professor,
No, the crocodile, no,
yeah,
not this.
the middle ear mucosa seems quite edematous.
Yes.
Are you intending to open the mastoid by any chance?
No, no, I don't think it's useful. In this case, I'm using just a transcanal approach. Let me cotton balls. Can you have a bigger one? This is too small. The behavior could be different, of course. In my opinion, in a case like this, it's sufficient to do the reparations of the eardrum. Crocodile. You can see that here there is something. La mucosa, dai, aspetta, dammi il falsetto qui.
Sickle knife.
Is that some tympanoclerosis?
Tympanoclerosis here, probably. This.
Can't see the ossicles.
Dammi coccodrillo, va. So now with the crocodile, we have to detach the ligamental fold of the malleus here. And entering into the Prussac space.
Yes.
Yes, it doesn't work. This crocodile doesn't work. I don't know. It's difficult to. Yes. Cotton balls. Large. So now I detached the ligamental fold of the malleus, and I have to. This is too large, probably. Dammi l'aspiratore. This cotton ball is too large, but dammi da togliere. Give me less larger, because this is too large. L'aspiratore. Crocodile. Can you give me a smaller one? Because this is too large. Dammi prima un falcetto che mi sta facendo rovinare tutto il lembo, guarda. So we have to pull. There is here that the adhesion with the cord. Cotton balls? No, no. Give me the cotton balls. Aspiratore. You can see here a lot of mucosa and the granulation. You can start to see the round window. And cotton balls. Suction. We have to be patient and pull the mucosa. È schifo. This is the Prusak space. Okay, so the cord is here. Forbicine piccolo. Anzi, dammi il falcetto. There is a tympanosclerosis under the cord, you can see. Dammi da togliere il cotonoide, vamo.
Yeah,
Crocodile, dai. Forbicine.
Scissor.
We have to try to save the cord because it's inside the. We have just this endoscope because this endoscope is not so brilliant like
4 millimeter.
4.
Okay.
If you want, we can try with the 4 millimeter because this is really not a good view.
4 millimeter endoscope, 0 degree, 0 degree, 0 degree, 4 millimeter.
Cotton balls, we can try to change the endoscope because in this case, the endoscope is not so brilliant as a view. So it's probably too small.
Smaller.
No, I speak about the endoscope. No, not one.
Yes.
And suction, okay. There is a medialization of the malleus. Schifo, o no? Dammi a togliere il cotonino.
Abbiamo l'ottica.
Okay, we can try to change the endoscope with the 4 because the view is not so good. So we can try to see if with the 4 it's better. Oh, I think that is better. Yes.
It's a much wider view.
Section? Okay. Now I think that the view is better, totally. Yes. Okay. Toglie il cotonino.
Sister.
Crocodile. To remove.
Yes.
No, non si riesce a muoversi. Sickle knife. Of course, now the view is much better. Look, there is a medialization of the malleus with touching the incus. Section. Quantum balls. Smaller. Lascia di buttarsi una bella fascetta lì, senza posto. Non ci passa. Section.
Dicono che potrebbero necessitare di poco, perché dicono che le immagini erano sfocate.
È sfocata, è poco. Are you able to see in the focus of the picture or no?
Yes, we are able to see.
So can you see now the round window?
Yes.
Il fuoco dove? Cazzo. Dov'è il fuoco? Io no. So now here we are. I think that we can check the status of the mucosa. The status of the mucosa now is good. It's not so bad, honestly. And the incus is good. The stapes is good. The movement is present. There was a lateralization of the malleus with not a good contact between the head of the malleus and the incus, but moving the incus, you can see that you are able to move the malleus. So for me, it's okay. The isthmus is open. You can see the isthmus over there.
Professor, can you see the
No,
biggest tendon?
Crocodile. Sickle knife. So now we can do like this. We can put here.
So you won't remove the tympanoplasty patch?
No, now we can cut here in the umbus. Do you have it's too big.
Ooh.
No, it's too big, this one. It's too big. Do you have a smaller one? Because this is really big.
No.
Oh, it doesn't cut. Sickle knife. Ragazzi, la staffa credo che sia un'ipotesi. Siamo alla petrosectomia e basta. Ok? So now it's okay. Because we have all the flap around here. And we can see the anterior edge of the perforation. That is here. Ce l'hai un dissettore curvo, qualcosa?
To measure. Measuring grid or something curved. Curved, yes.
Ma ci vuole della fascia qua, sai?
Professor, would you be,
Curve dissector, please.
would you be taking out
Something
the
curve.
patch?
Now we are ready to put the graft. In this case, we can use different graft. We can use fascia, cartilage. Eustachio tube is there.
So anteriorly, is there any tympanosclerosis where you're probing right now?
And so now we can use a perichondrium or a cartilage. It's really important to pull all the flap here. On the anterior wall of the external auditory canal. Cotton balls with water or with adrenaline solution is good. Okay.
Big one.
Another cotton balls?
Yeah, big, yeah.
Professor, can you hear us? Hello, Oti.
And now we are collecting, perché così mi scola meno sangue.
Ora tengo io questa.
Sì. We can use, in this case, as a first choice, we can also use a fascia. Because if you have a failure, you can use a cartilage as a second option. Yes.
Hello, sir. Daniel, sir.
Yes.
Just a minute.
Sir, we saw some tympanosclerotic patch. So would you be addressing that or?
I think that in this case, the tympanosclerosis, there was just a small piece that we removed at the beginning. Now, I don't think that we need to remove more from the eardrum, honestly. And it's really important instead to put a large graft to cover all the eardrum and to fix with just a small incision.
Bipolar? Where is the pedal? Okay.
Give me a padiglione, per favore. Right. Forbici, vai.
Scissor?
Vai, vai. Just a small incision behind the ear, just to collect the graft, right? Yes, sir? Yeah. Oh, this is really big. Alessia, non farmi troppa luce che io non vedo, sai? Perché spara.
Queste sono un po' più piccole.
È un clemmerino troppo?
Oh, ok. This is the fascia.
Un divaricatore autostatico.
Ce l'hai? Divaricatore autostatico?
Retractor, self-retractor.
Trovi che non c'è quella luce lì che mi dà fastidio. Illuminami, ma non. No, io non riesco a vedere niente. I need the light because I'm in the dark completely. So it's not possible to harvest nothing. Mi togli un attimo gli occhiali, poi me li rimetti perché io così faccio fatica. Doesn't work. Bipolare.
Bipolar.
Right. 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 Come facciamo per divaricare qua? I need something just to enlarge. No, attenzione. Tu non hai una manina, qualcosa per divaricare?
Do you have a
Dai, Bipo.
Qua, venale.
Right?
Sì.
Okay, so
Ma io non vorrei lasciare questo.
tanto non credo che li freghino. Ok, knife. Tu potresti lasciare questo e tenermi il padile perché io
Ok.
we can harvest just in 1 second the vieni qua, su.
Ok, di parare.
Do you have a forceps?
No. Yes. Yes. Ma in che modo, no?
Fai le most. Can we have something to press? Do I have to press something? I need the light. No, no, too much light.
Like focus on this.
Yes, can you have the light and no. I need the okay. So now we can try to press the graft. I need something to press. Do you have something to press? No. 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 So I'm pressing the graft. I'm trying to press, of course, in order to become dry. And so now, this is our graft. And we can press. It's really important to get dry the graft.
Professor, do you normally use temporalis fascia only or?
No, I'm using especially cartilage, but in a case like this, because there was not a so large perforation, is a paracentral perforation, you can use as a first option the fascia, and if you have the failure, you have to do a composite graft with the cartilage. But in this case, the rate of failure is not so higher. So with the fascia, it's a good option. And you can maintain the cartilage if you need.
Okay.
Knife. But of course, you can use directly also the cartilage in a case like this. Is not a huge issue. We can use this to cover part of the drum, and this is for the perforation. Of course, the cartilage probably is the best material for tympanoplastic type 1, but in some cases like this, the fascia is a good option also. Okay, so the if you have something to press is better. That's it. No,
We sometimes use a hair dryer to dry the fascia.
sorry?
Sometimes in our OT, we use a hair dryer to dry up the fascia and it's too wet.
Non ho capito niente. It's a quite low the signal here, so I'm not able to understand because I'm not able to hear you. It's too low the signal. Okay, so this is the fashion. So now mi rimetti gli occhiali. Now we are ready to see the situation. No, me l'hai messa male perché mi appanno. Devi stringere la... dai il coso curvo.
Okay, the curved instrument.
And please, I need the gel foam. Do you have a gel foam?
Understand? Gel foam? Gel foam, yes.
Okay, a small gel foam. No. So I have to pull my graft under here. This is the anterior border of the perforation.
Yes.
See.
Crocodile. And please, can you give me the graft? And a persicle knife.
Yes.
It's not so dry. Another important aspect when you are doing it, one hand is to wash the surgical instrument, because if you don't put water on the instrument, your graft can back with you.
Yes, sir, that's a very valid point.
It's not so dry. I think that we need and when you put the graft, you have to do like this. Put superiorly in the canal. Put superiorly. And after you have to control the anterior border. And you have to put and you see the anterior border is here.
Yes, sir.
You have to pull, push. Do you have the curve? The curve instrument?
Is one.
And now we have to put the gel form in order to maintain the adhesion.
Size. The smallest.
So, sir, Professor, do you use the gel foam only when you use fascia, or you use it also when you put cartilage?
I have no signal here. Can we repeat?
Do you use gel foam in the middle ear only when you use fascia like this, or also for with cartilage graft?
No, I'm using gel foam. Yes. This gel foam, especially if you are using the fascia, can support your graft. So it's very important because if you don't use gel foam, sometimes the adhesion is not so good. But no problem to use the gel foam if you have a good mucosa like this. It's really important to preserve the mucosa. Gel foam. Can I have the gel foam here? It's wet.
Dry.
No, I would like wet.
Wet. With the
And you can-
antibiotic drop.
No, wet.
And normal saline.
Sickle knife. When you are using the gel foam, you have to use wet, because if you use dry with one hand, you can see that you can have an attachment of the structure. So it's very important to use a wet gel foam. You needn't to correct too much. Where is? Dammi il curvo. Il dissettore curvo. Curve the sector. And you have to push the gel form
Anteriorly.
anteriorly in order to support the graft. This is very important. If you are using a 3 millimeter endoscope, you can use the endoscope really close. With the 4, honestly, you have to maintain the endoscope outside the tympanic cavity. That it's a pity, because the endoscopic one-hand technique is for endoscopic approach to the tympanic cavity. With the 4 millimeter, it's quite difficult to push the possibility curve of the endoscope. Dammi un po' più grande, diciamo. So today we are using the 4. And in my opinion, the 4 is not the best endoscope. You can see in a good way, but you can't push your approach inside the tympanic cavity.
Yeah. Bigger. Yes.
Hello, sir. Are you looking for a Eustachian tube in tympanoplasty?
Yes, this Eustachian tube was perfect. The mucosa was perfect. The Eustachian tube opening was possible to see when was perfect. And the isthmus also was open. So there was no problem inside the tympanic cavity. For this reason, also, I decided to use the fascia, because if you have no huge problem inside, you can use also fascia without any problem. Instead, if you have a problem of the Eustachian tube, if you have no opening of the Eustachian tube, etc., it's better to use the cartilage. In this case, I saw a good isthmus, good mucosa, and an opening of the Eustachian tube. So I was a little bit happy about this and decided to use the fish. And the fascia is not good material like the cartilage, but to perform a meningoplastic in case with the normal perforation and without any huge problem, you can use as a first option. So in this case, it's possible to use. So now we are almost finished. We have to check, and you can see the border of the perforation. That is good. Jeff?
Also bigger.
Professor,
Yes.
can you hear us?
Yes.
You have freshened the margin of the perforation.
Yes.
You haven't taken out that tissue there. Any specific reason for that?
When I talk to the question of the preparation.
No, it's really important. It's not important to remove. It's important to scraping the border in order to have the bleeding, in order to have a reaction of the scar. So it's if you want, you can do, but it's not so necessary. The most important thing is to have the bleeding around the perforation. That is mean, that mean that you are in a hilly tissue, and it's possible to have a good reaction of the. Dai quell'altro segmentino di. Now here
Fascia.
I put the last piece of the fascia.
Okay.
Mi puoi tagliare questo? Tagliamo bene perché tanto non serve molto. Vai. Taglia. Taglia ancora.
Così lo vuoi.
Sì.
Second knife. Yeah. Perfetto.
We need to put here. Just to cover this small defect. A curve?
Yes. Yes.
Okay, so I think that now is good. And you can see here the perforation. And we have the fascia in the right place with the good contact.
Yes, sir.
And now we have to put the gel form, and also putting the gel form is really important to put around the perforation. So, a gel form. Is wet.
Yes.
Okay.
So do you soak the gel foam in any antibiotic solution or just normal saline?
Just water, and we can put around the perforation. You can see like this, in order, sickle knife, in order to create an adhesion between the flap and the eardrum. So you have to put here, close to the border. Anteriorly. Again, gel foam.
Yes. Wet.
Sickle knife. Dammi l'antipannante. All around. All around the perforation. Another gel foam. Please. Sickle knife.
Professor,
Yes.
this gel foam is soaked in normal saline or any antibiotic solution?
No, this is saline, but anyway, if you want, you can put also antibiotics. It's not, but in this case, we put saline. But the most important aspect of the gel foam here is to create the adhesion between the flap and the eardrum. Also here, in the border of the tympanometal flap, it's the same. You have to press just a little bit in order to create the adhesion.
So we give to the patient antibiotic drops.
In the post-op, we are always use eye antibiotics drops. And after one month, we can check the situation. We don't use to perform medication every day or something like this, but just to check the patient after 1 month. And maintaining the external auditory canal, the bigger one, please. And okay, so.
Very nicely done case, Professor. Let's give a big applause to him.
Okay. Okay, so this is all. Thank you very much.
Thank you, sir. You have a round of applause from the audience here.
Thank you very much. Thank you. See you soon in the next case.
Yes, sir. Thank you.
Thank you very much, all the moderators, for making the session lively and interactive. On behalf of the organizing committee, I would like to, as a token of gratitude, this small appreciation.
Oh, thank you very much. Thank you. Insomma, è venuto abbastanza bene, anche se lo faceva cagare.
Va bene, già.
Okay, thank you very much. Thank you. Thank you.
Yes.
So mica si con la staff.
Dr. Bharti Mohan for his presentation.
Elettrosectomia, vai.
Tanto per, appunto per il skitter, presa come stai aggiornando.
No, ma anche con le forbici, se devi tagliare la staffa.
Top line.
Oh. Where do you put this?
Red.
Okay.
Però vediamo un po' questa roba.
Just.
Hello.
Dr. Jovan Putra, sir. Dr. Uday Monga.
So good morning to you all. Amidst endoscopic activist presenting microscopic considerations of cholestoma management is a bit, I am feeling like yesterday. After 9:30, singing a Tamil song amidst a crowd of expecting the dancing peppy numbers. So what is extensive cholestoma from my perspective? It's not it's open for discussions, my perspective. Yes. Before that, to present the microscopic considerations, there should be some contraindications to endoscopic AS surgery. This is what I found in the literature and the online. These three things only discussed. Only extensive cholesteatomas, some canal considerations like stenosis, exostosis, like that, and insufficient equipment availability. So how I aimed that presentation is to discuss the limitations, not endoscopic or microscopic. So all through transcanal approaches, to discuss the limitations of transcanal approaches in extensive cholesteatomas. When to go transmastoid approach, when to use microscopes. And my presentation based on intact canal, what are the advantages of intact canal wall procedures, and what are the problems with soft tissue reconstruction when we do a inside out and reconstructing the canal. So I'm going through the topic through the following subheadings. So cholesteatoma is a cystic bag-like structure lined by squamous epithelium containing squamous epithelial debris in a connective tissue matrix of varying thickness. That's the definition given. And the cholesteatoma can be congenital and occurred. The occurred can be a primary occurred, secondary occurred. Primary occurred by far being the commonest, and it can be an attic cholesteatoma,
with the attic retraction stages and can be a mesotympanic cholestoma with the tensor retraction stages. So I'll go just by case with each conditions. So limited cholestoma. What's a limited cholestoma? It's confined to middle ear epitympanum, adytus, and just extending to the medial or anterior aspect of the antrum. So my case one for your thing is, it's a, it's going forward, sorry. You should give me training before that, how to use this. Yes. You can see in the slide that this is a attic retraction with cholestoma flakes with endoscopic picture showing that it is limited to the attic area. And the CT shows on the right side, it is on the epitympanum, attic, and the mastoid, entire mastoid antrum. How to approach this? This is a pure, we can approach through the endoscopic approach. I approach all through the endoral. My cases all are endoral approaches. So my center is a single-handed endoscopic center right from 2000. Many are doing endoscopic ear surgery single-handed. Myself, I got my training under Mubarak in 2019 here, but slowly I'm getting adapted to. I'm not well versed in double-handed. I am also doing single-handed. But it's my center has not got still approval for double-handed endoscopic surgeries. But I got the thing, one important thing, endoral approach from Mubarak Khan, how he doing his extensive cholestestomas through the endoral approaches. So this endoral approach, we see the cholestoma as per in the otoscopy, as per in the CT scan. It is also limited perioperatively in the mastoid antrum. So we remove the disease. But one important aspect is the cholestoma has eroded the ossicles, head and body of the male, and has draped the medial wall of the epitympanum. And it's on the horizontal facial now. When we clean all around, finally what remains is the suprastructure of the stapes for reconstruction. Already the hearing is near normal, preoperative. We got this postoperative results and near normal hearing after reconstruction. So what I'm going to stress in this particular case, if you work around both anterior and posterior aspects of the posterior canal wall, leaving minimally damaging the posterior canal wall for disease clearance and maintaining the perfect middle ear volume, the reconstruction and the acoustic gain is going to be near normal. That's the point I want to stress. Next, I'm going to the extensive cholestoma. By definition, it is going beyond the boundaries of temporal bone. So in the case 2, we have a case with a granulation, looking like a granulation on the postoral region. It's a recurrent case. Already they had done a cartilage tympanoplasty that miserably failed, and there is retraction. We thought it's just we explore and secondary suturing this. But on an exploration, it goes inside, and it's a huge cholestoma sac. That is supported by our CT scan also, cholestoma extending from tegment tympani to the hypotympana. Yes. The hearing is almost profound hearing loss. There is no thing for reconstruction, that we are sure. Cholestoma is coming out. It's an extensive cholestoma. We explored the external thing and we traced into the mastoid cavity. There are whirls and whirls of cholestoma flakes, all removed. And finally, we enter into the lateral semicircular area where it's a semicircular erosion. And we made it point that the posterior canal wall is so thin, but it should be maintained. So we are able to see the anterior epitympanic sinus and even the hidden areas. And even if you want to see So you can see the posterior tympanic area. I tried to drill, but if these portions, retrotympanic portions are still hidden, we can still go with the posterior tympanotomy and reach that space. But being our center is endoscopic center, we can anytime use the endoscope to see the hidden areas. But that is the point. So I stress upon the lateral semicircular canal erosion, anterior epitympanic sinus, facial nerve, the wall window area, sinus tympanic area. We can go anything. So by keeping the posterior canal wall to its thinnest, and we can see all the areas. We can reconstruct with the cartilage, and the final results are cavity-free external auditory canal and dry. Though it could not be reconstructed, patient felt very happy. So the next case in this extensive cholesteatoma is, it looked like the tensor retraction, posterior superior retraction, and the canal wall granulation. But the real thing is, there is a posterior canal wall erosion, huge erosion of the posterior canal wall. So if you see the posterior canal wall erosion by the disease, definitely we will plan a canal wall down procedure. In this case, we planned we wanted to reconstruct the canal wall. We don't want to leave any cavity. So the CT shows the extensive nature of the disease, the posterior canal wall erosion, the disease going up to the tip. As expected, in the mastoid, there is a huge volume of disease with extensive granulation, bleeding, very adherent to the mastoid bones, going to all the cavities, sinodural angle, perifacial, perisinus, and worlds of cholesteatoma thing is coming out. And here also, we are able to see the lateral semicircular canal erosion. And through the canal wall erosion, we are able to see the retrotympanum and the stapes suprastructure is freed of the disease, and sinus tympani, all this area freed of the disease. So what I'm trying to convey in this video is, if you reconstruct it, if you try to reconstruct the posterior canal wall from the mastoid side, you can stabilize well your cartilage. So we closed by supporting the erosion of the posterior lateral semicircular erosion with the perichondrium and neotympanum with the cartilage and temporalis fascia. So postoperative hearing is little bit improved than the preoperative hearing. In the postoperative period, we got granulations in the external auditory canal that were cauterized with the trichloroacetic acid. The in the immediate period, it looked like this. After a period of 3 to 4 weeks, both the grafts, canal reconstruction, all have taken up well epithelious, and look very strong. So next we go to extended cholesteatomas by our definition. Cholesteatoma more in the mastoid. What we defined was it going up to the tip, going perifacial, going perisinus, and going to the inaccessible area, the anterior, inferior, and lateral, which could not be assessed through the endoscope, which is placed in the adytus. Without sacrificing the posterior canal, these areas could not be reached. When we look for the literature, what it says, above the Donaldson's line, we do either a endoscopic approach or a combined microscopic and endoscopic approach, keeping the canal wall intact. And below the Donaldson's line, it should be a canal wall down procedure to remove the disease. That's what the literature says. So for our thing, so case 4, it shows an attic retraction with the erosion of the scutum and going into the adytus. And the audiogram shows almost near normal hearing, almost 25 decibels. One important thing in the CT is, you see cholestoma in the thing, but it looks like the epitympanum looks ventilated, and the adytus is ventilated. Only it looks like a small disease in the mastoid, and it shows in a sclerosed mastoid soft tissue haziness, a small area of soft tissue haziness. So what it is in the software in the tympanomeatal flap, we are able to localize the cholestoma sac in the epitympanum, and we can also see the chorda tympani over the sac. And this is the mastoid disease. Such an extensive disease. The disease is more in the tip area with a lot of dirty white keratin flakes, pus, granulation, and everything. So this kind of extensive cholestoma, definitely if you go transmastoid and preserve the posterior canal wall, we can remove the disease. As well as we can even reach the hidden areas by drilling the medialmost aspect of the posterior canal wall. In this particular case, what we are able to see is the near normal hearing, but we can see the cholestoma sac is draping on the foot plate. So it's a perfect example of cholestoma hearing. The foot plate is there, draped with the cholestoma, and we are slowly teasing the cholestoma sac matrix out of the foot plate without damaging it. So definitely when we use both hands, we will have a very good control of clearing these kind of diseases, preserving hearing. So this is a facial now, foot plate area and the sac. So teasing the sac, we are slowly removing the disease. And wiping out the retrotympanic area, the cotton wool. And we are sure we are clear of the disease. Even at this stage, we can use endoscopes if you have any doubt. And the defect is reconstructed cartilage. So we have this post-operative results, and the hearing is almost maintained. This one, another important case, is an discharging attic retraction pocket with intact pars tensa. The patient is a medical student, so there is a high frequency hearing loss. Right from the beginning, we wanted to preserve the posterior canal wall. Being a medical student, she has to use her external auditory canal for all kind of auditory purposes. So one important thing in this particular case, you look at this area. The mesotympanum looks ventilated. For our surprise, what happened? On the table, when you elevated the tympanomeatal flap, the malleus, behind the malleus on its anterior aspect, we are able to see a pearly white sac. It looks like a congenital cholestoma. The only thing is the Prusac space, there's a granulation. So definitely it's acute cholestoma, but looks like a intact sac anterior to the malleus. This is the volume of the disease in the mastoid aspect. This is a sinus area. This up to the tip, perisinus. In fact, it is going to the retrosinus, sinodural angle, perifacial, and all kinds of areas. It is going, creeping in. So what we did? So after removing the disease in the mastoid, we are removing the malleus. So before the malleus is entangled on the sac. After removing the malleus, we are seeing the chorda tympani over the sac. The sac is slowly teased from the aretus. And the cyst wall is getting unfolded, exposing the contents. That's a huge sheet of matrix there. Yes. Sorry. So what we see is, yes, this is removing the malleus. So while removing the sac, we are able to remove the entangled incus also from the sac. That's a hidden incus from the tympanic retrotympanic area. And along the posterior canal wall, we are able to see a double-headed stapes suprastructure that is nothing but the fractured lenticular process of incus that was removed. So this case was reconstructed with cartilage. So we are able to get this result, and the high frequency hearing loss improved. So surgery for cholestoma, not endoscopic or microscopic, should be discussed under canal wall up procedure or a canal wall down procedure. So transcanal procedure, it could be a transcanal, it can be endural extended. If there is extensive cholestoma, naturally it goes to inside-out mastoidectomies and soft wall reconstructions. So complications of cavity and soft wall reconstructions, you all know. Some procedures may not definitely need not an endural or a transmeatal. There's post-oral approaches are needed for these kind of cases, presenting with the sinuses and granulations post-orally. So what is the carry-home message? So intercanal wall tympanomastoidectomies with the tympanoplasty should be the first choice for a cholestoma surgery, irrespective of the extension. So our approach should be graded. Acoustic gain in ossicular reconstructions in intercanal wall procedures is good. That should be a flexible approach, as preoperative otoscopy imaging could not assess the real status of the mastoid extension, because one text says CT scan is 60% sensitivity and 80% specificity. So you cannot always rely upon the CT scan and also the otoscopy. So you have to rely on the perioperative findings. So canal reconstructions attempted from the mastoid side give more stability. So there should be as a follow-up protocols. Could be otoscopy, CT, in selected cases, diffusion weighted MRI periodically, as case basis. Some references. Thank you for your patient listening.
Sir, what are the prerequisites? I mean, what are the important points to be kept in mind in case of intake canal wall procedure in extensive cholestatoma? Other than disease clearance.
Who is asking? Where?
Yes.
Where's
Hello.
what is the repeat the question, sir?
Hello.
Hello. What are the important points to be kept in mind for doing intake canal?
Intercanal mastectomy in cholestatoma. That's what. Definitely, it should be the case. Each case should be assessed arthroscopically, imaging wise.
Okay.
And it should not. The thing should be assessed whether it's an intercanal one or a canal one should be assessed on the first your approach should be an intercanal approach. So you assess perioperatively on the table. Then you decide whether it is a completely transcanal or whether you want to preserve the posterior canal wall or extend the procedure soft wall. The basic thing is, as far as possible, preserve the posterior canal wall. Don't drill. Minimize the drilling at the posterior canal wall.
Okay, sir.
Okay. Thank you, Dr. Bharti Mohan.
Thank you.
I request moderator Dr. Ritesh Bhagyavanta to honor Dr. Bharti. On behalf of organizing committee, I felicitate Dr. Ritesh Bhagyavanta for the moderation. OT, Dr. Mubarak. Hello.
Hello.
Dr. Mubarak, are you ready?
Yes.
Yeah. Okay. For this operative session, I call upon Dr. Vijay Sonone, a leading ENT surgeon from Pune, who is also the organizing secretary for the upcoming SEOCON, Dr. Haritosh Velankar, and Dr. K. Jivan Pradeep to moderate this operative session. Welcome, Dr. Vijay Sonone.
हो यांच्याकडे आहे ना परफोरेटराइज किटर बी आणलंय हा तर
Dr. Vijay.
Hello, Mubarak.
Yeah.
Morning.
Hello.
Vijay here. Good morning.
Good morning.
Yes, you're operating?
Yes, I will just. This is an extensive cholestatoma. Totally atico, going from the attic, and the whole of the mesotympanum is there. I will just show you. I'm just trying to take the end oral incision. Chal pat suction law. Dusra आपण suction लावू शकतो का जरा time वाचवायला? So I will show you first. I've just taken narrow canal. Okay.
Yes.
Very narrow canal. Can you see that?
Yes, yes.
Yeah. So let's go inside. Can you see?
Yes, yes. Very clear.
Can you appreciate that?
Yes.
Yes. Suction, please.
Disease.
So such attic cholestatomas which starts at the Prusac space are really extensive. This patient is a 19-year-old boy. So see.
Right.
Now you can appreciate. Okay.
Yes, yes.
So it's on the CT scan. Everything is gone. There are no ossicles and extensive cholestatoma extending to till the tip. So the plan is first to give a safe here and if possible try to reconstruct. Okay, by creating the pseudomastoid and the soft wall doing the soft wall reconstruction. Let's see.
Yeah. What is the hearing?
Hearing is it's a conductive hearing loss, moderate to severe. So it's an patient is hearing cholestatoma hearing.
Okay.
We have not assured the hearing. but we'll try to do the ossiculoplasty in one setting if possible.
Okay.
By doing the boomerang or okay. So I have taken the first intraoral incision, this one. Already I have taken this incision. I will create a flap by taking the incision in the outer 1/3 at the 6 o'clock. Right. So give me the blade. I will harvest the temporalis fascia from the same incision and the cartilage also.
Okay.
So this is the first. Take a time to create this flap. Okay, this is very important because we don't do the meatoplasty and all. The same flap can go inside and rest on the mastoid cavity if we'll end up doing the modified radical mastoidectomy. The lower incision.
Yes.
This periosteal incision is very important, okay?
Yes, yes.
Yeah.
It will line the cavity later on.
Yes. So now the plasters elevator.
Is it extensively pneumatized mastoid?
Extend, yeah.
Okay. So you have to have a good exposure.
Yeah. That is the beauty of endoscope. Now you will see it's still mini endoral incision and you will be seeing everything.
Okay.
So the flap is created 2 by 2.
Even the cartilage you harvested?
From the same incision, okay?
Okay.
Now with just an angle, see how you can see the fascia, okay, for the harvesting. So give me the suction cautery. दूसरा सेक्शन भी लगा क्या नहीं? चलो ना, ओके, चला. Just a simple ear suction which has been insulated. Yeah. Okay. Give me the artery fusion. Now we'll use the zooming. Focusing. This is a Akinote system, Erato 3, and I'm using a 4mm endoscope. That's a storage endoscope.
Okay.
I hope the picture is good there.
Yes, yes. Very nice.
Yeah. See how the angle, external camera picture दिख रहा है क्या? हाँ. So show them what the angle I have in थोड़ी सी और.
Yes, we can see the external picture also.
Yes.
In PIP. Yeah.
Yeah. ये right angle. See why that third incision was important. If you don't take this, it's very difficult for you to harvest. End oral is a little bit as an tough incision, but almost I can access everything.
Right.
Due to endoscope, obviously.
Yeah. I thought you'll take the fascia graph later on.
Huh?
I thought you'll take the fascia graph later on, depending on.
No, because that will save the time.
Okay.
Because we need an extensive drilling here, so we'll harvest the thing.
Okay. So you use a dried fascia.
You just keep saline soaked gauze piece over it. It will remain wet. So take a time to, it's only a difficult part, okay, to harvest the temporalis fascia from the end oral incision. जरा आर्टरी फोसेप जरा चांगला देता का मोठा वाला काही मोठा लागेल उलटा सोडे थोडासा will extend a little bit because it's very blade there. That fibrous layer need to be broken, so you will get an accident.
Yeah, one more cut.
Just I am cutting that fibrous layer because that's see this.
Yes.
Yeah. Okay. Yeah. Many of the time the connective tissue takes a time for, but take a time for harvesting. There's good. See how you can see inside?
Yes.
Yeah. Separate it properly. All around. मला हे दे SMR elevator दे SMR elevator आणि सीजर दे periosteum चालणाऱ्या सीजर द्या काय आपल्या डब्यातलं आपल्याकडलं आणलेलं काय हे यांचे इन्स्ट्रुमेंट आहेत का नाही मग आपले काढ सेक्शन ब 2 मिनिट सोड हा आता पकड हा जरा चांगला जो हे लाव फुल चांगलं कर so separate all this full fascia plus connective tissue because you need to have a good graft and whenever you are expecting a big cavity try to harvest. Yes. In extensive cholesteatoma, many of the time, if the temporalis fascia we don't find, it's with of adequate size, we harvest the fascia lata too.
Okay.
Yeah. Hey, chala.
But in a fresh case, I think the temporal fascia is better. You can get as much as you want.
Yes, yes. That's why एवढं छोटं देऊ नकोस, आपल्याकडे दुसरे आहे. हे आतल्या ह्याच्यासाठी आहे. हा पकड. काही होत नाहीये. पॉटरी को देखो, सिर्फ आवाज कर रहा है. किती? हा तर तू वर लावलेस का त्याला? हा. Okay, better. Again, SMR elevator. If you use a 30-degree fantastic view here, I'm using the 0-degree only, and I given the angle with the endo hold.
Okay. That PIP picture is gone.
PIP gone? Arvind, कहाँ है audio visual? Audio visual guy? अरे वो किस यार कब ये कहाँ है देखो? So PIP का चला गया. तो ये पिक्चर नहीं दिख रहा है उधर. काय झाले बघ तिथे जाने से दुसरा सेक्शन चालू आहे का? लावू ना त्याला, काय फायदा आहे नुसतं ठेवून.
चालू केलं नाही. चालू केलं सेक्शन लाव चालू.
कारण हे एकतर बसत नाही ह्याला बरोबर. ह्या सेक्शनला एक दुसरं लावून ठेव म्हणजे ते. हा हा. Can you see the PIP now?
Yes, yes.
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 Yeah. So remove all these things, okay? So that your fascia will not shrink later on.
Okay.
And in many times you face a lot of connective tissue. So that take time. And end oral is a tough approach to harvest this. Vijay, you must be knowing this because you do.
Yes.
Yeah, you do the end oral a lot of, huh?
Yes. Yeah. I'm not always.
Yes, Dr. Vijay Sonawane is a senior otologist from Pune, and he is a very good friend of mine, and he is organizing secretary of coming SEOCON.
Yes.
So Pune is hosting the SEOCON, the prestigious event. So I invite you all to this event because I am also a part of this team, and you should come and enjoy the fantastic academic feast in SEOCON. So give me the.
Thank you, Mubarak.
You're wonderful organizers. Huh?
With all your help. Yeah.
Yes, we will make it great success.
Yes, I invite all of you to come again to Pune in November. The dates are 24th, 25th, and 26th. It is at Hotel Marriott, Senapati Bypass Road, Pune. November 24th, 25th, 26th November. Me and my team, including Mubarak, Sapna, have planned a good academic feast, and I hope you enjoy that as you are enjoying this today.
On a lighter note, all delegates can request Vijay to give some concession for the registration.
It is already there, Mubarak.
No.
We are planning to increase it.
The registration in SEOCON, immediately some discount, okay? For the group registration.
This is the lowest. It is the lowest for this year's.
Yes. No, it's very lowest. Huh? Considering the event venue and 3 days of the registration is quite attractive price. Huh?
Yes.
Yeah.
So you all take advantage of that registration fees, which are very less.
Yes.
Maybe in another 8 days, we might have to increase those. So all the information is there on the website, www.isocon2023.com. Hi, Mubarak.
Yeah.
Kailash Chand has joined me. Just want to say hi.
Sun sir. Good morning. Good
Mubarak.
morning. Good morning.
Fantastic show going on.
Yes, thank you so much, sir. It's all your people, deep blessings of all of you. See the beauty of endoscope, how you can see. If you do like this, you will see this much fascia only. Okay. I will just give a 30-degree angle through this endo holder. So you can see a much.
Yes, yes.
Yes, large fascia, and incision is still a mini endoral. Huh?
Yes.
Yeah.
The picture quality is too good. Very nice.
Yes. And definitely Dinesh is the man behind this, and
he is going to be there for the ISOCON also.
yes, he's a and I'll take this opportunity to thank the Department of ENT, D.Y. Patil Medical College, specifically Professor Mayur Ingre, Professor Vinod Shinde, Professor Paresh Tawan, Head of the Department, G.D. Mahajan, and all other team. This is Rashmi, Dr. Karodpati, and above all the residents. Without them, it's very difficult to do all these things.
Very true.
They have screened the patient, they have gathered the patients, and they have given a wonderful setup, excellent class OT where I am operating. Okay, so let's go. Many of the time, I think this is a vessel. Many of the time, vessels goes like this. So be careful. It bleeds. It's till this fibrous layer. So see this, how much fibrous layer. So take that out.
Yes, yes.
Yeah. Give me the blade. So we want pure fascia. Otherwise, due to that connective tissue, it shrinks.
Otherwise, you have to prepare it later on.
Yeah. It's better to harvest.
Mubarak.
Yes, sir.
Many people like to have this fascia as a separate graft.
Yeah.
To keep on a bare bone if the original graft remains little inadequate. This fascia also, many people call it as a fool's fascia.
No, I use it many of the times, sir.
So
Okay.
you can preserve it.
Yeah, that's what I'm getting.
And then you can use it for many
Yes,
other.
I'm dissecting that and taking it out. Mastoid surgery, whatever material you get, preserve it. If you're going to create a huge cavity, yeah. हे चालत नाही आपल्या घे आपली सीजर घे बदलो सीजर Yeah.
Daniel sir is asking whether you have a hook in staples set.
Hook? Which hook? इसको preserve कर. What hook?
In micro instrument is asking, so we don't have it.
नहीं क्या चाहिए exactly? Who can उसको? Just ask him what he wants.
Curved रहेगा. He doesn't want
क्या?
हमारे पास angled ball point है.
Hmm.
We have pick also angled. He doesn't want pick and all. Hook जैसे जो pick थोड़ा J shape.
J shape. हाँ वो that's an hockey stick type sir. That's मुश्किल है because I don't use because I bent my all instruments. याला touch करू नकोस ना. हाँ. Okay. हाँ. सोडू नकोस.
उधर staples लेना है.
हाँ ले लो क्या बीच में से दिखाओ क्योंकि ये हार्वेस्ट कर. हाँ नहीं ठीक है ना he can finish the staples हाँ हाँ simultaneously दो इसमें दिखाओ because मेरे को भी टाइम ये लगेगा. हाँ हाँ देख आप हमारे इंस्ट्रूमेंट में क्या है देखो हाँ so they can Daniel can take a staples there हाँ there is no problem.
तुमचे instrument त्यांना
He
दाखव. तरी पण त्यांना बघायचं आहे एकदा.
नहीं बग show no that all instrument का set में इसमें जो लगा and see the skeeter is also there and then course prosthesis is also there. Show it to him हाँ. Yes sir. तो जब कभी वो ready रहेंगे उनको simultaneously दिखाओ थोड़ा because I will be taking a time here okay this and then harvesting the cartilage and I lot of drilling and all okay. हाँ so बीच में ये भी रहेगा. The audience will also I करते हैं. Yes, so now better. Yeah. Give me the saline or SMR elevator. Caesar है.
फक्त त्यातलं ठीक आहे सर. ठीक आहे.
Okay. Okay. Now we'll give much more angle and ह्या बाजूला असं इकडे this is better. This one okay. हाँ बस थोडस या हाताला इकडे हे करून एका हाताने saline.
So you're injecting saline?
Yeah.
इधर आणि आधी दोन्ही हातात.
अजून थोडस दे saline. याला सोडू नकोस बघ तू इथं मला तिथं दिसणार नाही हा. We'll try to take this full fascia to later on okay. 15 number blade. नवीन आहे का? Artery portion. Artery portion. SMR elevator. सक्शन कर बघत बसू नको. थोड़ा बीपी को कम करो. उसको 90-60 आने दो. एंड पल्स also should be less. हाँ थोड़ा सा बेटर रहेगा. हाँ little bit blood pressure is high. ठीक है. These are
Mubarak, there's still tissue, yeah? Over it.
Yes. Yes.
There's a lot of tissue over it. That's what you're cutting, or it's a fascia?
It's a fascia.
Okay.
It's very thin.
Oh yeah, right.
See, you see the muscle here, huh?
Yes, yes.
Blood pressure is little bit. See, okay?
Yes, yes.
Yeah. पल्स को थोड़ा सा कम करो. हाँ हाँ बिकॉज और उचल. आर्टरी फोर्सेप चांगला नाहीये का? हे होत नाहीये तो. काय घेतले ते इन्स्ट्रुमेंट कोणाचे ते? अरे मग आपले घे ना तू. हे असं lot of connective tissue. Take it with the patience, there's no problem. Suction curve. Obviously, it's very, very small incision, okay? So you need to be patient, but you can harvest, believe me. Try to harvest as much as possible. You need to take out those things, okay?
Yes, sir.
Yes. So, चलो इसको spread करो, बाकी का ये तुमने कहा है. We try to see whether we have a मोठं करा आणि त्याच्यावर तू काढ सगळं त्याच्या मला SMR elevator दे. We'll see whether the this is all connective tissue. So if at all I need, I will take this, okay? Later on. If needed, we will take this.
Okay.
Yeah. Clean kara. So we'll harvest the cartilage also. Flush. दुसऱ्या ह्याला लावून ठेव, मोठे लागतील मला. हे सगळं सगळे तुझे ब्लॉक होतात, मोठे लागेल मला. आतमध्ये वर्ण नको करू. Okay. Skin hook. हम फोर्स है हळू. तू का नाही घेतले सगळे आपले इन्स्ट्रुमेंट घ्यायचे ना बाजूला मग. हळू. So dissect the skin and try to harvest as much of cartilage as possible, because we need cartilage for the reconstruction.
Yes.
Yeah, that's for the ossiculoplasty. And I create a mosaic pattern to create a pseudomastoid if possible. Let's see. The plan is to create a pseudomastoid.
Yes.
And then use those PRP sheets, lot of PRP sheets.
Yeah, people are asking for that PRP sheet.
Yes, so in between we will show that how to create.
Are you going to show that today?
Yeah.
Okay.
So we have not taken a blood.
Okay.
number blade change कर.
So I will try to harvest 1.5 centimeter by 1.5 centimeter. Password this. Yes, we have reached here. Look at the connective tissue, okay? So you have to dissect it properly.
ऐसे ही है, मैम एंगल वाला ये इधर भी लगेगा तर त्यांना अँगल पिक पाहिजे
कुठला
आपला सॉल्व्हरचा घेतात ते यहाँ पे भी लगेगा
दे 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 देख दे
ये ले लो और फिर लाके दे दो
डैनियल को जो लगता है दे दो उसको वट एवर इंस्ट्रूमेंट्स ही
थोड़ी देर बाद में फिर लाके
हो कुठला पाहिजे विचार थोड़ा सा पल्स कम करो एनेस्थेटिस्ट थोड़ा सा पल्स because if you don't reduce the pulse hypotension is of no use at least 70 72
बॉक्सिस नको धरू ते खूप
See.
मोठं होतं मोठं कर त्यांना मोठं कर लागतो त्याला मग पाण्यात टाक त्याला पाण्यात चांगलं चांगलं पाण्यात
so there is a defect here इकडे थोडस हे का 15 नंबर ब्लेड एखादे 2 ब्लेड घेऊन ठेवा दुसरे आहे ना ओके
तो चेंज केला हा मग तो जुन्याला टाकून द्या अजून एक लागेल नंतर
ठीक आहे चालेल worker
So you take the whole of it. So-
almost here I want and he's the male little bit small piece we will keep there see this okay
Yeah.
not my okay इकडे करा इकडे करा हळू होते त्याला एवढं काही करू नको ग त्याला सगळं सीझर okay
Yes.
yeah around 1.5 by 1.2 let's move थोड़ा सा बीपी कितना है सरक ना मला ब्लड प्रेशर बघू दे हो पल्स नहीं नो प्रॉब्लम थोड़ा सा क्लीन कर एंडोस्कोप ना so we will start elevating the flap here I am using the 4 millimeter endoscope while drilling I will use it as an exoscope and you see we will try to create a high facial reach in hope of reconstruction. If the cholesteatoma is going towards the tip, then we will do a modified radical mastoidectomy, but we'll try to reconstruct it, okay?
Okay.
I will show you how to create that pseudomastoid.
So that is inside out technique.
Inside out. So inside out is the way only for the cholesteatoma because you have to follow it.
Okay.
Where it originates. Do 2x2 चा नाही आहे दुसरा असला देऊ नकोस मला now good flush endoscope ला clean कर endoscope ला clean कर
Mubarak,
yes, sir.
you have modified some instruments. Also show wherever you have modified, you should show us.
Yeah. Because while doing the cholesteatoma surgery, it's very important to use those angle instrumentation. Otherwise, it's quite difficult to take out that cholesteatoma and follow the cholesteatoma. I will show you.
Okay.
Yeah. Oh, thoda sa. We will control little bit bleeding because I'm not happy with the because I want a clear field. फिर भी चलो cautery.
So this much exposure is enough. It is quite a big exposure.
It looks like if you see, if you look at with your eyes, it's very minimal. I am having only 2 centimeter by 2 centimeter. Okay.
Yes.
But there you will see a huge picture.
Yeah.
This is a quite helpful thing. So just get these insulated
suction. Yeah.
Small suction tips because we use nasal suction tips, but these are not the nasal suctions. These are ear suction tips which are insulated.
Right.
So you want a good clean field. So ये थोड़ा ठीक है. हाँ, चलो थोड़ा और. Okay, so again, see, it's a tortuous canal, very narrow canal. Okay, I am keeping the endoscope just outside the ear and see how the canal it is. Okay.
Yes.
It's not a nice canal where you can see the pars tensa and all. Okay. So I will be doing that canal plasty too.
Okay.
So you will see the extensive drilling here.
So there's no problem for you to put the suction and use other instruments.
Yes. And you will see how you can do it with the why the endo holder is needed for the cholesteatoma surgery. थोड़ा सा yes, so we'll create a flap. Let's go once again and see how the canal is. It's a tortuous canal.
Right.
Now I will use a smaller suction. I am now at the junction of bony and cartilaginous junction in external auditory canal. Okay.
Yes.
Yeah. So let's go inside. Now, after moving little bit, you can see some past tense. Okay.
Yes, yes.
So we will start elevating the flap. So see, this is a cholestoma, extensive cholestoma, and here it's also completely adhesive eardrum, and the sac is formed here also. This may be joining here. Let's see.
Yes, yes.
Clean. Total section. Give me the flag knife. See now this angle. Okay.
Yes, yes, yeah. So that's the modification, that angle.
Yes, yes. And this helps in not here. You will see how while elevating the cholesteatoma too.
That's the inferior, yes.
Yeah. Let's go near.
Inferior at 12 o'clock?
Yes. That's it. 15 number, because there is a tough skin here. So I will use a 15 number blade. 15 number blade. So I will show you by going here. Give me the circular.
The flap will be very thick there.
Yes, I'm going to cut that here right now.
Okay. So make it thin right now.
Right. Just that small bleeding because you will be seeing it's a huge bleeding due to the endoscope, huh? But even I don't want that. So give me the about 15 number blade. And this is a hyperemia. Okay, so this suggests the cholesteatoma is extensive inside, huh?
Right.
See this, huh? Yeah.
Yes, yes.
Yeah.
So it has come right up laterally.
Yeah. अंदर नंबरच दिलाय का वेगळा दिलाय normal saline. So whenever the endoscope gets spoiled, just put a normal saline, irrigate it.
Okay.
That's all, huh?
Yes, yes.
Suction दे जरा. This might be down defect also.
Okay.
But we'll thin the flap here right now.
The bone is eroded right there.
I think so, huh? That's why this is a fibrous tissue. So let's see. See here, it might be going. That's why the bleeding is there.
Right.
Give me the circular. I want some bone paste. I will try to see whether I will get here. Otherwise, I can feel the bone here. Very thick connective tissue.
You can see the bone below, yes.
Yeah, it's a nice bone. Now give the 15 number blade. Yeah, bone is there. This is a very thick.
Yeah, thick.
So the connective tissue,
Yeah.
lot of connective tissue. So that's why there was a little bit problem while taking out the temporalis fascia.
Right.
Yeah. Even this we will use it.
Yeah, to obliterate, right?
Yeah, we'll make it the strips again in a presser and use it for. Okay. इसको भी रखो. Looks better now?
Yes.
Yeah. Yes. Give me the circular. Cholesteatoma surgery is a surgery of patience. Create a flap. Now give me the, I will unpack.
Yes.
Spoon is there, huh?
Yes.
Yes. See the beauty of endohold. If you want to go near, you can just go like this, okay? By using the rack and pinion mechanism. Yeah. That is a rail system on which the endoscope is mounted.
Right.
So you can keep moving. It's not a static endo holder.
Like what you.
And that is what, yeah, that is what it is important. Yes. Yes, Vijay. Huh?
Yes.
Try comparing it with the microscope. Obviously, I don't want any controversy, and controversy should not be there in the developing science.
Right.
Yeah. What is the best? Because we are working for the patient.
You should
All
use
the
the
better.
technology wherever possible.
Yeah. Okay.
Yes.
Yes, it is nice.
There's the attic defect, yes.
Yes. So I will give the angle so that I will go near. See the beauty.
Yeah, that's the beauty of the endo hold.
Yes. And so if you compare it with the single hand now, and for this extensive cholesteatoma,
Right.
It's a very nice static picture. I am fantastic picture I'm seeing on the this medical grade monitor. And obviously I love this suction, huh? And
Yes.
you too, while doing the microscopic surgery, huh? So we have reached here, so let it be here. Aluminum foil tire tail. So now when I want to go here, again angled flag knife to go under the skin. Angled flag knife.
Another cuts for the flap, superior.
Come again?
Another cut for the flap inferiorly.
No, I will try to create a flap. I will go underneath this, okay?
Okay.
So I want a good flap.
Okay.
All reconstruction, it depends on this flap.
Right.
If you are doing the soft wall reconstruction, you need that skin
Yeah,
from where this nourishment will come for this temporalis fascia or cartilage. If it is not there, nothing can be achieved.
Yes. Is it
So
vascular?
see, I am going under the. I'll show you while going near.
Right up to the annulus.
Yes, I will go near. Yeah, I am now. Look at this. We have reached up to the.
Yes.
See this? 6 o'clock.
Yes.
And beyond that now.
So you have deepitalized the drum, right? There?
Yes. So here it's a sac.
It's a fibrous layer down there.
Yeah, so I will try to be overlay here. I'm
Okay.
going to throw it all, the whatever TM there.
But the angle to the instrument is really working well.
Absolutely. So that is the what. So you need to have these instruments. If you don't have these, then it becomes a difficult, and then you say, oh, it's not possible. For everything, you need to make those tools.
Right. Yeah.
So,
you open the sac here.
yeah, so I'm taking the cut here. So let it go. Obviously, the bleeding will be there because this is chronic inflammation which is going on. So give me the. Yes. करता हूँ बीच में करो मैं तो बीच में अभी ड्रिलिंग करेगा जब लगेगा so डैनियल का स्टेपिस दिखा देना and Vijay loves the steppies.
Yes.
Am I right, Vijay?
Yes. Sir.
Yeah. So Daniel is taking the steppies there. So जब उनको शिफ्ट करना है ये कर देना हाँ दोनों एक साथ दिखाएगा तो चलेगा when you will start give him a mic हाँ so they will see both the things because I am drilling the thing हाँ okay
Yes. Sir.
so
now you can proceed with the.
yes so यहाँ पे थोड़ा सा ये है उसको भी कट करें come out very narrow canal
Wash.
हाँ
Just give a wash, warm saline wash.
बिल्कुल this all red yes give me the so come out. Here is our mastoid, okay?
Yes.
Yeah. एक Xylokin adrenaline का pack दो इधर अच्छा. So I will collect the bone paste first, huh?
Yes.
Because I want the reconstruction of this peripheral part of the mastoid, huh? मला देना हातामध्ये काहीतरी. मोठा दे जरा.
But that is you cut it? Yeah.
No, sure.
I think so that flap should go up.
Yeah.
Superior. Yeah.
Yeah, that is coming in my way. Here again, this you need those good retractors. Huh?
Yeah.
So I am designing that one by one and all, so that it will nicely fit. Because these things are made sometimes for some surgeries, so you need to modify it. Huh?
Right.
Yeah, give me the blade because I'll just place the elevator. Huh? चले किती लक्ष द्यायचं ना.
Yeah, I think so. That is
yeah.
Yes. Or give a cut there. It will go up.
Yeah, I don't know. We will preserve because इसको इस्तेमाल करेंगे बाद में. This all things matters for the making that cavity small. Better.
Yes.
Interestingly, lot of connective tissue. Huh?
Yes.
Yeah, better. So, मला हे दे थोडंसं मोठा सेक्शन दे आता ड्रिल करण्यासाठीचे आणि बोन पेस्ट कलेक्ट करायचंय. ॲल्युमिनियम फॉइल दे. कटिंग बर.
This foil is from the suture material?
This is, I think, Iviloncha घेतलंस ना? The Ivilon pack, our simple Ivilon pack. Huh?
Okay.
This is a plastic material of that. Okay, but it's hard. Huh?
Right, right.
Otherwise, you can use those chromic catguts aluminum. Huh?
Okay.
Huh? No. चांगला आहे ना हा बरं. So now I will zoom it little bit more. I will use it like an exoscope.
So you're withdrawing it, or?
No, I have use the digital zooming.
Okay, okay.
Get oriented. I'll show ball point just
yes
for the beginners. Anterior wall. This is the left ear. I am typically operating and given the position like the way you do the microscopic surgery.
Yes.
Anterior wall.
Yes.
Posterior wall. Superior wall. Inferior wall.
Inferior wall. Okay.
Spine of Henle.
Yes.
Mark 1 strangle. Okay.
Okay.
This is a temporal line. Okay. So this is a Mark 1 strangle.
Yeah.
This is your canal, posterior canal wall.
Yes.
So some bone dust.
Ma con quelle curette là, I need the suction.
Yeah. It's audible.
Sure.
Is it ready? It's audible. We can talk. Okay.
Okay.
Yes, you can talk and they.
Angle,
yeah,
please.
yes,
Okay.
Okay.
We have to start, and so I need just the suction.
So we lost the picture, endoscopic picture. Mubarak. There's no endoscopic picture.
Wash. Saline.
Can I have the suction, please?
We want the endoscopic picture.
Niente, non si può bene.
Yes, we got it.
Yes.
Is it possible to have the suction?
They're getting the adapters.
Do you have the injection? Do you have? No. Posso intanto iniettare.
Okay, the other side.
Qui non lavoriamo.
No. Però fammi iniettare.
Sorry. Sorry. We need adrenaline to inject.
Can I inject, please?
Hello. We are hearing from the other OT.
Yes.
Can I inject?
Hello.
Can I inject?
You need pure adrenaline? Adrenaline?
Yes.
But they want previous. No, this is saline.
I need something to inject. Ragazzi, c'è. Vabbè, va bene che pure, dai. No, ma va bene che quella che hanno, dai.
Mubarak, can you hear me? I think so. We are connected with the other OT. Hello, can you hear us? In the please? Hello? Hello? Hello, Mubarak. We are seeing, hello.
अरे अरविंद काय करतोय?
Hello, Mubarak.
Hello.
So delegates are able to see your.
Hello.
Yes, hello. Mubarak.
Hello.
Hello.
Vijay, can you hear me?
Yes, yes, now I can hear you.
Okay. So I'm just taking a bone paste.
Okay, okay.
Yeah. Just tell the Daniel if you just started the case. तिकडचा आवाज काय येत नाही. डॅनियलला सांगा चालू झालंय म्हणून.
Yeah, we can see the other case there in PIP.
Okay. So आवाज तिकडे शिफ्ट कर. माझा म्यूट कर थोडा वेळ. आणि त्यांना सांग की चालू झालंय. हा चालेल. So now they are putting the Daniel.
Yes.
And, yeah, we will finish it in early. So
What is the other case? We can see the picture.
Hello.
Yes, hello, sir.
Can you hear me?
Yes, yes, we can very well hear.
So this is endoscopic stapes. And honestly, the endoscopic stapes, the suction doesn't work. The endoscopic stapes is the last step of the endoscopic one-hand technique. And you know very well that endoscopic stapes, you need always the same instrument with the same step. It's really surgical based surgeon, and it's not honestly, it's not easy to do stapes in another department without the own instrument, etc. You know. And so we will see, because we have a different prosthesis here. I don't use this kind of prosthesis usually, because for endoscopic approach, you need just one prosthesis. That, in my opinion, the best prosthesis to use for one hand technique, staple surgery, is the Kurz prosthesis, the traditional one, the key piston. Cottonoid with adrenaline solution, please.
Cotton ball.
Cotton ball.
So what is this case, sir?
Sorry.
That's what I am.
Sorry?
Is it stapedotomy? Endoscopic?
Stapedotomy. Endoscopic stapedotomy. We are discussing about this technique. Cotton ball, please. Bisogna lavare perché ci sono dei pelazzi dentro. Altro cotton ball.
Cotton ball.
Okay. Cotton balls.
Do you not say when you wash the canal?
Cotton ball again.
Cotton ball again.
Sono con l'adrenalina. we can pack the canal. And we are waiting just a little bit. Scissor. Honestly, I don't know the results because I have no my instrument, and the stapes for me is crucial to have a small hook. It's crucial to have a small scissor and a lot of instruments that of course are really important when you are doing stapes one hand, because it's totally different with respect to the technique with the microscope or with the holder. When you have one hand, you need to do the same step always. Possiamo alzare anche il letto, Yes. Okay, just a little bit and more. Okay, stop.
Okay, thank you. This is a cotton ball, and this is another one. No.
The skin is really thin. Oh, it's really thin. Crocodile. Crocodile.
Do you have a smaller suction? Smaller suction. Smaller? Yes.
It doesn't work. Look, I can't close. No, no, it's not working. Do you have another one?
Of course. Yeah.
Sì, ma ragazzi, perché era sul lembo. C'è. We can clean. No, foolish wrong. Okay. And a round knife. So we can start. The eardrum is not so good because it's very thin. It's possible to have a perforation during surgery, and we will see.
Yes.
So we can do like this. Incision.
Yeah. Circular.
Any region? I show close.
नहीं लगता है close, but half a centimeter है बाहर.
Suction. Questo è troppo grasso.
Yeah, we need smaller suction. Smaller suction. Okay.
And cotton balls. Cotton balls.
And this doesn't work.
No, doesn't work. The suction doesn't work.
This doesn't work. Yes.
So now we need Dammi la lentina, quella grande.
Round knife, the biggest.
The round knife.
I call upon Dr. Samir Joshi, Dr. Santosh Latkar, Dr. Deepak Hardipur, and Dr. Rajesh Yadav to moderate this session, along with Dr. Sonone.
Cotton balls.
Cotton ball.
More bigger. This is too small. Yeah. No, put here. So now we have to elevate the flap. And pickle knife. Is the annulus. There is a scar here.
Yes.
Tympanosclerosis, probably. Suction. Crocodile.
Yes.
You have to pull anteriorly. Oh, this is not working. It's not possible to crimp. So it's. Give me another cotton balls, a little bit larger. Doesn't work. This crocodile doesn't work.
Do you have another crocodile?
Aspiratore.
Fine. Okay, this. Okay. This is good for cotton balls. This is good when he asks for this. Okay. Vediamo un po' di lentina.
We have to detach here. There is the ligamental fold. So we need something like a crocodile working.
Yes.
Right?
Yes.
It's too big. Okay, we have to uncover the Prusak space. A sickle knife.
Autosclerotic.
The eardrum is really thin. And look, there is a scar. So
Hello, Professor.
yeah.
Which camera are you using?
Is a 0 degree 4, but anyway, the best is a 3, not 4, because you can manage, but it's too big for the one hand endoscopic ear surgery.
Okay.
You can see now here the incus and the stapes.
There's the
You
erosion.
can see the fixed stapes.
Fixed.
Can you see? This is the ponticulus. The round window is here.
Yeah.
The sinus tympani
Yeah.
and the isthmus is here. Aspiratore. Cotton balls. Now we can try to clean the skin and the blood for you, just in order to show you better the detail. Cotton balls. Suction. Cotton balls. I just want to clean the surgical field for you. The problem is that in order to do this approach, you need also a small curette. I don't know if we are able to have a small curette, but we can try to do our best with the instrument, because I just want to press and wait, just in order to avoid the bleeding.
Yes.
Crocodile. I know that is boring, but it's really crucial if you want to do one hand. Okay. Suction. Okay. Crocodile. We have to detach here. Another important principle in endoscopic ear surgery that it's totally wrong that with the endoscope you need to curette less. You need to curette a lot, because you have to move your instrument in an appropriate way. And for this reason, it's not possible not curette and performing surgery in this way. Okay, now here we are. We can put the eardrum on the anterior aspect of the external auditory canal. Suction. Adesso come facciamo senza uncino? Ce l'hai un uncino, qualcosa per...
Just point out the pyramid stapedius tendon seen nicely, no?
So the pyramid, the stapedial tendon, the answer was like this. This is the pyramid and this is the tendon. You can see.
It's a good exposure. You don't need to remove the.
Correct.
Yeah.
Do we have a correct?
Cotton ball?
Yes, cotton ball and the correct.
The previous.
Yeah, adhesion.
Yeah, but now we will see what's happened. So now we have to correct, and we hope to have a small correct, because to do this it's really important to correct all this bone you have to correct.
Okay.
If you don't correct this bone, you are not able to move your instruments. And in the stapes, it's very important to move the instrument in an appropriate way.
Professor, there's erosion of long process there.
Crocodile? Ok, dammi look.
The book?
Look.
I prefer this.
And you see here the anatomy of the retrotympanum is really clear. And also the ponticulus is really nice because it's a bridge ponticulus dividing the sinus tympani. So this is the chorda. We have to pull the cord anteriorly. And after, you have to wait just a little bit like this, in order to create an adhesion between the chorda and the eardrum. And after, you can stop and you can see that you can engage this correct. And after, with the curette, you have to remove this bone.
Yes.
And suction. You must be careful just regarding the cord. Hook. Hook, please. Hook. Guarda che te, cazzo.
Yes. No.
No, please, hook. Where is the hook? Facci dietro. Is this the posterior ligamental fold of the malleus that we detached before? Aspiratore, suction. It's too heavy, this suction. It's possible to have...
Lower the power of suction.
Correct. Ce l'hai più grande questa?
Table down.
And you need to see the facial now. Suction.
Table down.
Table down? No.
Now increase the suction because
No, it's probably need the hook. You can see now that the facial nerve is in front of you.
Yes, very well we can see.
Hook, please. Hook. I need the hook. Yes.
okay.
Dammi, non ce l'ho di prima. The bigger suction that so, and sister, that we have to cut this.
Scissor, micro scissor, below
You see that now this is our window. Good. So we have to cut here. Okay. Hook. And the suction. That's bigger, just to remove the bony chip. Again, the correct. Now a smaller suction.
Smaller.
Again, we have to correct again. You can see that for me, it's really important to do this. Okay. Piotr? Doesn't work. Sickle knife, please. Doesn't work. Devi cambiarlo, non so.
Right. Yeah, okay.
Now, I think that the exposure is good. I can work in this way. Suction and cotton ball in order to clean. I want to clean. No, it doesn't work. Let me check. Okay, it's working. So this is a web
Yes.
on the isthmus. Is the isthmus
Take the mobility, sir.
hook. Yes, of course. Now we can check the mobility.
Yeah.
Before we have to remove this web. Okay.
Okay.
And we can check the mobility and you can see that it's fixed.
The malleus.
The malleus is good.
Malleus is mobile. Okay.
The incus is quite good. But it's,
Yeah.
and the stapes is fixed.
Stapes is fixed. Yeah.
Suction.
Mm.
Cotton balls. Before to start our stapes removal, we have to clean. We need to maintain the surgical field clean. Another cotton balls. And sickle knife before. Sickle knife, just. I want to pull my eardrum here and maintaining here. Cotton balls again. And so we can put this and wait just a little bit, 1 minute, in order to maintain a clean the surgical field. So now we can remove the cotton balls, the crocodile. Okay, suction. And we can start our treatment, scissor. So before we have to cut the tendon of the stapes. After we have to cut the crura.
Okay, cut the crura. Okay. Yes.
Hook.
Yes.
And we can remove the superstructure.
Yes.
Fraction.
अभी तो जगह ही है.
And we can see here the footprints. Hook. So now we have to drill regarding the prosthesis. Here we have no good prosthesis for this kind of surgery, but we can try. Quella che abbiamo sul tavolo. We can try with the prosthesis that we can. Vabbè, fammi vedere questa. Ce l'abbiamo sul tavolo?
No, aspetta, guarda, seconda.
We have to check the prosthesis. Let me check the prosthesis. What is the prosthesis? It's 0. No, please. No.
È un po' storta.
Which piston are you using, sir?
Sorry?
Which piston?
I'm using the traditional course, but we have no traditional course here. So we have just a prosthesis that, let me check. Do you have a suction?
The suction, yes.
The problem that is too small. And so I don't know if this is good for this. We will see.
È 5. Yes.
It's not such. It's block. This block. That's to check before to perform the whole. It's quite strange. It's bended. I don't know. Let me check.
È 0,4.
Let me check. We can try, but it's really thin. Because I have a 0.6 drill, and this is a 0.4. So I don't know. It's can you block the suction, please?
Yes.
Block the suction.
Block, yes.
Okay. Cos'è? We can drill and we can try. So, sì. Beh, noi proviamo, adesso vediamo poi, no? Please be ready also with the other prosthesis from the course, because if this doesn't fit, it's not fit.
Where is the pedal? The pedal?
So,
The pedal.
where is the pedal? Okay, let me check.
Actually, you have to press this button, the black one, this one.
And after? And after?
This one, yeah.
That's the 0.8 bar, millimeter bar.
Doesn't work.
Yeah, Professor.
Yeah.
It's a 0.8 or 0.6 millimeter bar.
Yes, yes. This is a 0.6, but the prosthesis, it's 0.4.
Yeah.
Oh. Please check. Doesn't work. It's working. We can check if his drill is working because actually it's not working. Se no mettiamo quell'altra cazzo di protesi da me. Adesso vediamo. Can we have also the other prosthesis here? The course, please. Yeah, because this is too small. Now we are checking the drill because it's not working. If you have a cotton ball, I put inside the cavity during this step when you're. No. Let me check. You can check.
If you press this now, that light is shut off, then it's off. Right now it's working.
I don't know. I think that is not so. No, it's not a question of stable. It's really low power. It's the same. We can try. Okay, we can put the hole.
Yes, very nice.
And now we have to put a prosthesis. Please give me the prosthesis. I need the suction, please. I need the suction. And give me the prosthesis here. You have to put here the prosthesis. No. I don't know. I never put endoscopically this kind of prosthesis. So we will see what's happened. Dammi un uncino. This is not for endoscopic. One hand. This is prosthesis for microscopic approach. It's not good. Guarda, rompe il cazzo che è un lavoro. Hook. Yes, if you want to do something difficult, you have to put this prosthesis with the endoscope, with one hand.
Yeah.
Krishna.
Yes, I can go.
Yeah, but
Yes.
it's not for endoscopic approach. Touch. It's not good. It's not good.
Thick, long process.
I don't think that it's better to push more
Yeah.
because can I have a problem with the incus? Now it's fit, but
Okay.
the problem that you have to pull just a little bit, but you can see that you can have a mobilitations of the incus. So it's now it's good. Cagata, sta proprio su qua. Già, lasciamo così. I think that this is like fixed, but I'm not sure that could be sufficient.
Yeah.
Probably. Okay, so now it's
That's
done.
it. So, Professor,
Yeah.
you can hear the applause.
Please don't put this prosthesis with one hand. This is not for one hand technique. It's something crazy. You need a large, come si dice? Il gancio. You have a large hook and just, it's really simple to put endoscopically with one hand. If you have a right prosthesis, not like this, you have just to put the cream here and after you can cream. But you need a large, this is for two-hand technique. It's not for endoscopic technique. It's a totally wrong prosthesis. Anyway, yes, if you want for exercise, you can do, but it's crazy.
Professor,
Don't-
very nicely done.
Don't put this prosthesis, please. Don't put.
Sir, there is one question.
Okay,
Sir,
so this is
how
finished.
how the length of the piston is decided?
The length is 475. Sickle knife.
Erosion.
We have to replace the flap in appropriate way. No. Because it's dry now, and so we have just to wait. Rub knife.
Round knife.
Okay. Okay, so this is all.
Thank you, Professor. Very nicely done.
I'm sorry regarding the prosthesis, but anyway, please don't put the prosthesis like this endoscopically. It's not easy.
Bit difficult with the single-handed.
Yes.
But you made it easy.
And sickle knife? Oh, no. Gel form. Yes. Because especially with one hand, you can have an unstable incus if you push too much on the long process of the incus with one hand. So it's not a good suggestion. You have to pull in a gentle way, and you need the appropriate prosthesis, because this is a typical technique. It's not like a cholesterol that you can do as you please with some different instrument. You need the same instrument, and you need especially the same prosthesis to do endoscopic one-hand stapes. Jeff. Yeah. Oh, thank you. It was not so easy to put the prosthesis. This prosthesis is not for with a normal prosthesis. Is 1 second, and this is like this.
Hello, Mubarak.
No, like this.
Hello.
No.
Hello.
Hello.
Hello, can you hear me?
Yes, yes.
Yes, so see how extensive it was. I have drilled it out inside out.
Yes.
I have taken out the cholestatoma, and now I have to address the cholestatoma in the attic, and then in the mesotympanum, in the epitympanum, we will go to clean the endoscope. And I think I will be able to reconstruct this cavity, this whole thing. Okay, get oriented. Anterior wall, posterior wall. Now this is a sinus plate.
Yes.
Superior wall. This is a tegmen antri. Okay.
Yes.
And then this is a facial ridge, lateral semicircular canal, and this part. So this whole part I will reconstruct. I will create a mastoid here. Because you can't take out each and every cell here, but periphery it's in sclerosis, and this peripheral part I will obliterate with the bone paste, okay? And this part will be the mastoid, the neomastoid, okay?
Okay.
So let's see. And I will go a little bit near and get oriented now. Okay, give me the suction, again some anatomy. So see, this part, so this part we will create a neomastoid.
Neomastoid, okay.
It looks a huge cavity, but if you, due to the endoscope, but it's not. But it's an extensive cholestatoma.
Right.
Professor Marchioni said subtotal petroxerectomy he would like to do for this, but I don't think, you see how I reconstruct. See, these things, if you leave it, this keep on draining post-operatively, okay? Yes, this becomes a weeping mastoid cavity. So better to create this part, which will be connected to the epitympanum and then to the mesotympanum, okay? And this will get ventilated. So this mastoid is created. So this is how we have changed the concept to create the neomastoid. And this peripheral parts beautifully can be reconstructed or obliterated with the bone paste, okay?
You can.
So, yeah. So you must have seen with how I have taken out the whole cholestatoma with this, okay?
Yes, yes.
I hope the picture was there while.
Yes, yes. It was there. VIP, yeah.
Yeah. So now we need to deal with this. So I will lower this more because it should be coming a little bit down, quite small, narrow canal. So I want a good canal also.
Okay. So thin out the canals.
Yes. So Vijay, how you will do this?
Yeah, as per what you have done. perfectly.
Because
thin
but-
or
but- but
thin, yeah.
my philosophy is now to have following the cholestatoma. Okay,
Yeah.
that's the inside out,
Inside out technique.
not addressing it from behind.
Yes. Because that will create unnecessarily a big cavity.
Exactly. So I will not smoothen this because this will help me to put my palisades
Yeah.
and create a pseudomastoid. Okay.
Right.
So just here. So I lower this. This binary is, I'm using this binary. It's a very nice drill from Pridex. And you can control beautifully the speed. Huh?
Okay.
Yeah, it's those data. And I'm using the Akino. You compare the cameras, okay, by yourself. So you are the.
You are using which?
I'm using the Akino.
Okay.
It's from Japan, huh? And even in my place, I use this. So you just compare this. This is a Irato 3. Huh? They have Irato 3, Irato 2, and Irato 1 entry level. Huh? And entry level is a Irato 1. You can record everything with the USB. A lot of modes are there.
What is the cost, Mubarak?
Abhijit?
What is the cost?
Abhijit, kidhar hai? I think I exactly I don't know this Irato 3, but their stall is there. Sanjay is there on the stall, surgeon and now that's on Friday.
Right. Okay.
Abhijit, क्या cost है इसका?
Full system 25 lakh plus GST.
Full system में क्या क्या है?
इसमें light source है सर.
Light source, camera, and medical monitor. They have a wonderful medical grade monitor. Wonderful. How many inch? This
27 inch.
27 inch for monitor. So it's 25 lakh rupees for the light source and camera and medical monitor.
Okay.
And what is the cost of Irato 1? Irato 1. Okay. With full system, Irato 1, 16 to 18 lakh.
But that is the basic one.
That's the basic one, na? Irato 1. And Irato 2? Huh? So Irato 2 and Irato 1, there is not much difference except the pixelation. It's a 2 megapixel camera. What they do, medical grade monitor is very costly. So they give a Dell, I think, and they give at the price of some 7 to 8 lakh rupees, Irato 1. No, not Irato 3, Irato 1, entry level. Yeah, with the Dell monitor, 7 to 8 lakh. But they have a good system. And I think it's a worth of price. And even yesterday I operated with the Olympus. They have a 4K system. That's 4K is really is good. And today you must have compared both the things. Huh?
Yeah.
Yeah. Yeah. They have also 4K, but they have not provided here this. Huh?
Dr. Mubarak.
Yes, sir.
Delegates are reminding you of demonstrating the PRA.
PRA, अरे तुमने दिखाया नहीं, तुमने बोला दिखाया था करके external camera से. It's going on now.
They are shown. They're taking the blood.
No, they have taken the blood. Now
Yeah, that we have seen.
Yeah, so now see that that's my centrifuge machine.
Yes, yes.
Okay.
Just it costs 12,000 from this, I think Remy's, and they have kept it at the 5,000 rotation.
Okay.
For 15 minutes. Okay.
Okay.
So once they take it out, you see how those clot is formed of the platelet.
Right.
Okay. I will keep in mind. And already we have created some.
Okay. Thank you.
Yes. So here, can you show this? Can you see this?
Yes, yes.
Okay. So this already few platelet-rich fibrin is prepared. Another thing is going on because I need much more sheets for the reconstruction. So we will create the sheets from this. Yeah. Even tomorrow, Dr. Sapna will show you from our OT, because she uses PRF for the septoplasty also, for the small augmentations.
Okay.
Yeah. Small innovations to improve your day-to-day tough problems.
Yeah. That is very appreciable actually.
Yes, sir. Khali. And what thing we can do, we can see clinical success. I can't call this an hardcore research, but in private practice, I can do that only. That's seeing the clinical success.
Yeah. Right.
But now we are going to have a tie-up with D.Y. Patil to do this research.
Yeah.
And also, Prepa is a kind enough. He's a very nice man who is working in a oldest university called University of Malaya.
Okay.
So hope to have some good tie-up with the universities.
Okay.
And our professor, our own professor, our Marathi Manus, is so kind, because he's actually my guru, but he always say that don't call me guru or boss. I'm your friend. Professor Arun Gadre.
Gadre, yeah. We
Yes,
come to know that.
yeah. And small tips from these people.
Yeah.
Has improvised a lot. Okay.
Yeah.
During my early publication and all, sir has helped me and perfect guided me how to write those things for the prestigious journals.
Yeah.
And how to present it. So, sir, hi kya udhar, sir? Thank you.
Yeah.
Gadre sir hai?
Gadre sir is not there, it seems.
No, he just left. But he's not there present.
Okay. So see, it's in some tip cells, okay? Yeah. It's not a cole, but there is a hypertrophied mucosa, so we'll take that out and we are going to निकाला उसको निकाल होते तिला काढून घेते ते ट्यूब दाखवा आणि त्याच्यातनं कसं ते साधतात.
Yes, we can see that separation.
आहे का ग त्याच्यात? नाही आलेलं तुझ्या त्याच्यात आहे का?
Yes, you can see in the picture, PIP. The centrifuge thing.
नहीं हुआ है वो तो तुमने टाइम कम लगाया है, उसको घुमाओ. This is not prepared. This is just still not.
Okay.
Yeah. They will rotate more. Yes, better.
Yeah.
Still a lot of work here. I need to drill anteriorly and clear. That's a tough job to work in the middle layer and epitympanum and clearing all those areas. But we'll do it.
There's a lot of cells remaining there.
Yeah. Okay. थोड़ा देर से ले लेना कि एकदम साथ में मत लेना. इसको सर को दिखा के थोड़ा जाके तुमको खाने पीने दो. सब बहुत सारा एक साथ हो जाएगा. थोड़ी देर के बाद ले लेना. He is supposed to go and meet the vice chancellor. तो वाइस चांसलर को मिलने को जाने वाले हैं. तो उनको जाके आने के बाद फिर तो उनको बोल किधर कौन सा ये करेंगे ना. और तो उधर एक दे देना सर को. उधर एक इफ ही इज रेडी टू डू ही कैन डू द माइक्रोस्कोप और ये करके.
Hello, Mubarak.
दूसरे OT में. He is not going. Finish? Huh.
Hello, Mubarak.
Yes.
Yeah, Dr. Gadre is here.
Sir.
Hey, Mubarak, bol.
नाही सर, तुमचे आभार मानत होतो सर, म्हणून म्हटलं आमचा मराठी माणूस कुठे आहे. I was telling them how you have guided us to improvise those writing in the prestigious journals, huh? And how it takes your help for so many things. गद्रे सर, वातावरण फार छान आहे तळेगावातलं. फिरून आला का बाहेर? Okay, that's better. So we'll address now.
So Mubarak, am I allowed to tell the audience the real story?
Yes, sir.
Or do you want me to talk lies?
No, sir. Boss, your boss, you just tell the real story.
So the real story is I was on the editorial board of the Laryngoscope, and there was a paper that came from Mubarak Khan. I said, who is this Mubarak Khan? I didn't know who he was. And generally, when you're on the editorial board, you can find out who it is. There are certain clues you can find out in journals. Certain journals which will tell you that you cannot put the name of your institution, right? There are other journals which allow you to do that. Laryngoscope, you can generally see where they are from. It's not a big problem. And at that time, Dr. Ron Bailey was my chair in the Department of Otolaryngology at University of Texas Medical Branch in Galveston. And he was the editor of the Laryngoscope. So the Laryngoscope office was my office.
Endoscope.
And he said, I've received these 2 reviews about this 2-handed endoscopic technique. And one review says it's excellent. One review is terrible. What should we do? And he's not an otologist, he's a head neck surgeon. He was the one who devised the vertical partial laryngectomy. So he said, what should we do? I said, let me see the papers. And I saw the papers, and I read the paper myself, and I read the reviews side by side. I knew both the reviewers. And one of them I realized had a bias because he's a single-handed surgeon. He devised the so everybody respects him for single-handed surgery. So oftentimes what happens is, if it's your idea, it's not a good idea, but if it's my idea, it's a great idea, right? And so you have to be very, very careful about this, and you have to be fair. If an article is bad, it doesn't matter if it's coming from India, it's coming from Pakistan, it's coming from any place. You cut it, right? But on the other hand, if an article is a good article, and so then I got back to my chair, I said there are some issues that with this article that have to be corrected, but this is not an article that we should reject. And then I got in touch with so he said, will you take it forward from here? I said, fine. So I got in touch with Mubarak. And then I made some edits to the paper and told him to resubmit it. And then it got accepted. But that's oftentimes what happens. Sometimes what happens is, so for example, there was a otolaryngologist whom I know very well here in India. And that person thought that the paper was rejected because someone wanted to publish the same material before the person from India. Oftentimes in different parts of the world, 2 people can have the same idea. It doesn't mean that somebody is stealing your idea from you. That is paranoid thinking in my view. Most people are pretty fair about things. So you have to be very careful about when you make these kind of comments. You know, this chora, very idea chori. Why you are going to?
Nice rotation ho gaya barabar.
Oh, this is interesting. Okay, I want to watch this. I'm shutting up. So this is rotated at 5,000 RPM. Is that correct? For how long? 15
So for 15 minutes. Huh?
Yeah, got it.
So canal is very narrow. I'm just creating a canal, doing canal plasty. ये थोड़ा सा normal सा line. Take care of this flap. This flap is very important. This is a coarse diamond burr. Okay, very nice for the not cutting, but
one other thing I would recommend is when a new idea comes along, right? Initially, it is universally rejected. We saw this in India when endoscopic sinus surgery came. I mean, there are seniors in this audience who remember those days, right? You know, Messer-Klinger technique and Klein-Sasser technique and all this stuff came along. And first was rejection. We are doing Caldwell-Luck, we are doing Canfield, we are doing Denker. Why the hell we should do this small operation here and how can it cure anything? But then when they showed you what circus phenomenon looks like, what the mucociliary clearance looks like, and when people start producing their results, the other thing is China is coming on really strong with publications and we cannot fall back. We have to start publishing our long-term results. It's not enough to say I did 4 cases. Look at my case number 1, case number 2, case number 3, case number 4. That is a case report.
Coming.
Okay, we want to know your 10 years experience, 15 years experience. By now, we should have that data. There is no excuse anymore that we don't have computers. Everybody has a computer. That excuse is gone. And we have to come on strong. We have to start writing. There is no... Writing a book is fine, but writing a paper has a lot more academic value in a peer-reviewed journal.
Flush. So it's going here. Let's this is the head of the malleus which is remaining. Let's see our ink. Some flush.
In major hospitals, are electronic medical records universally available or not? Yeah, so if they're available, then extracting data from that is very easy.
See, this is going to the anterior repeat tympanum. So now we'll start elevating and see. Yeah. A clean. Total section. Yeah, this is better. Short suction.
Dr. Khan, how far is the tip of your endoscope from the operative field?
It's around.
Is it inside the meatus or is it?
No, it is at the level of the, yeah, it's at the level of the concha. Huh?
At the level of the concha, I see. Okay.
Yes. So this I will use. I'm not going to clean this cells little bit. I will not saucerize because I'm going to create a pseudomastoid here. Rest peripherally, I will obliterate with the bone paste. Give me the forceps. काय कुठे ग्रह okay, little bit more canal plasty because I'm not happy with those small canal. एकदम कमी दाखवाने एकदम कमी नाही याला नाही वापरणार नाही झालं रे त्याला See this is anti-repeat tympanum. Yes, Cole. We'll drill little bit more so that we can address that.
Oh, पाहिजे.
Dr. Khan, they want to know what happened to your test tube.
Who?
They want to know what happened to the test tube of blood.
Already we have created the plate. Say what happened? कुछ आया क्या उसमें? They have not done properly. So I don't think आहे का काही त्याच्यामध्ये बघ ट्यूब मध्ये बघ किती आहे ते ह्याच्यात मध्ये दाखवा आला. They have not rotated it properly. I have not seen for how many minutes they have done. So the clot is not formed. Platelet clot is not formed.
I see.
Yeah.
Does the tube have any EDTA or anything like that? Any
No, nothing. Huh?
Just
fresh blood. That's all. आहे का काही? देखो कितना है वो थोड़ा सा दिखाओ इसमें त्याच्यात दाखव ट्यूब आहे का त्याच्यात आहे का काही एक्सटर्नल किती आहे बघ त्यावेळेस बरोबर क्लीन करेगा एंडोस्कोप ना थोड़ा एक्सटर्नल कैमरे में उसका ये दिखा सर टेस्ट ट्यूब पे अपना फोकस करो.
It got clotted, kya, Mubarak?
No, it's yeah, exactly that they have not done proper loaded. The blood has clotted. That's why.
It
See,
is not clotted.
yeah, very small. Huh? This is not. They have not done properly. Huh? Yes. But already for the blood is equal. We have a good. 20 ml. I see. This we have created already. Okay.
Okay.
Yeah, this is from the first 20 ml blood. This they have not done properly. Somebody has just put it at and forgotten. Yes. Clean kar endoscope.
I know mastoid cavity.
From our place tomorrow, I will ask specifically show only this how to prepare the
PRF. Okay.
PRF. Okay, our Rafiq will do that, and Dr. Saptapur will be telling you. Okay, looks better now. Well, let's go here.
Yeah.
I'm going very near now. Let's make it crispy. Yeah, this is better. Give me pickle. This is our flap. See this. And the sac is going from posterior superior area. I will cut from here so that we'll take those out. This is our sac, okay?
Yes.
So let's see, we will elevate it right from here. Adrenaline are packed there. Now just try comparing with the single hand, and also with a microscope. The beauty is that everything is in front of you. It's called panoramic. From the tip cells to your whole of the mastoid, everything is in front of you. That's a panoramic view of the endoscope. Otherwise, with the microscope, you will zoom here and it will come near to you.
Yes.
Yeah. So now we have to go here. This whole completely surrounded by the cholesteatoma sac. That's malleus and the remnant of the incus. I have to be very careful while elevating because this sac is going and destroying the stapes, and that chole must be sitting over the foot plate. So I will elevate here. Now again, angle instrument, flag knife.
So you got to cut the head of the malleus.
Yes, I'm going to take it out, everything, because this is not a good option to keep anything here.
Yes.
And this is a young boy. So cholesteatoma is aggressive. So first thing is a safety. Yes, but we will start from here.
Mubarak, if you want to zoom in this area, how do you do it? Take the endoscope near to that?
No, yes, but that is the one good advantage of the endo hold. See, if you want to go near, just go like this. Yeah, see this. Okay.
Okay.
See this.
Right.
Yeah. So this is an over elevation here. So from here, we will start elevating. This bone, we will take it out. See, this much here, this flag is going completely in. So we'll take this out, this bone, so that will. So while drilling, come again. So that cholesteatoma sac is going between the incus, eroding it and traveling up. So it has got the posterior superior as well as the prosac space cholesteatoma. It has started here, this sac, and gone completely here. Give me the small. I will unpack and drill.
Can you see the IS joint there?
No, there is nothing.
Nothing. Okay.
See, this is, see. Oh, this is beautiful. I will show you how the sac. This is your incus, huh?
Okay, that's gone. Long process gone.
Yeah.
Even suprastructure.
And see the sac.
Yes, we can see.
I will go very near, the little bit. It's very beautifully. So, take.
आएगा.
We'll go near.
Hello, the image is freezed.
Images?
No, it has come.
See this. This is your incus. This is your sac.
Right.
Completely wrapping the facial, coming here and joining this.
Right.
Okay?
Right.
This is your facial. This is very nice cog separating the anterior
Epitympanum.
from the posterior epitympanum.
Right.
This is processes cochleariformis, malleus, and tendon. Can you see the tendon?
Yes.
See this. So elevating this will be a interesting thing. So I will create some space here. Tough job ahead. No problem. So at the low speed, I will drill that out.
The posterior buttress, yeah.
Yeah, this one. थोड़ा-सा एकदम कमी था. Be patient with us. 4,000, 5,000 speed. Just take this out. So you are not going to damage anything. The control should be in your foot.
There is an announcement. We'll be continuing with the surgery. There is one more surgery lined up by Dr. Mubarak. Plus, there will be some lectures also. So, lunch is ready. You can have a quick bite and come back. Thank you. Relay is there in the lunch area also.
So what age? I generally wait and see. Number of seats or let's go and do that. So there's a reason why you wait till that. Hard to see also. You cannot do a good job. And that child has to live whole life with your option. That's different. Completely different. Central perforation. No, it's Pocket में रखी है, तो तुम मत लगा। I was in Gandhinagar 2 months ago.
Crocodile. Just for sake of the measurement, it may look a very big cavity there, but just see this. This is this much area only. That is completely open crocodile. That is 6 millimeter. That's all.
Okay.
It looks better. We will go and elevate.
I don't have to be from Sweden. Maybe around 70, sir? 64.
Yes. Give me the sickle. So first, we'll take this out. It will obstruct our view. Give me this scissor, iris scissor. We'll cut the tendon. I am cutting the tensor. Yes. So this is a remnant of malleus and this is incus.
Yes, yes.
Yeah. So now this is a fibrous layer. Now it's better and we will take out the, we'll try elevating the things. Chota sara. Sickle de mala.
So now you can take out the whole matrix. Yeah.
See this now, this shining line. Okay.
Yes, yes.
So this is processus cochleariformis,
Yes, facial.
facial nerve, lateral semicircular canal, cog, anterior epitympanum, posterior epitympanum. This is a promontory. So let's find out our plane. Yes, it's there. We'll go a little bit near. Keep the eye now. See this. This is the beauty of endoscope.
Okay.
Yeah. Now we'll go. थोड़ा section जरा छोटा ready ठेव. We have to take care of this flap. जरा suction याच्यात बसणारा चांगला दे ना ग, काय आहे. आता मला थोडासा चांगला section लागेल. So go from here. See, keep an eye in the plane, huh? See this?
Yes.
मला एकदम छोटासा आयविलॉन पॅक लागेल किंवा तू ऍबजेल दिलास. You need to be very careful. This instrument is dangerous instrument. I am feeling, okay? With the tactile sensation, the bone, the over the facial, that's fallopian canal. Only gently you have to elevate. From here we will come. मला वाकडी दे माझी here. Sickle, this straight sickle will not work here. Very thin squamous epithelium, huh? Lining this cell, suggesting chronic hypoventilation. Taking out this will be a tough, but we have to find out the plane. And if it is going little bit deep, I will drill it out more.
Yeah, it's going into every cell there.
Yeah, this here, okay? See this here. So I will drill that a little bit more. So first, let's come from here. We'll address this. Because I have a plane here. See the plane?
Yes, yes.
Be gentle. I'm just trying to use a छोटा suction लागेल मला एकदम करनेला power फार जास्त आहे. हाँ? So now we'll use the suction to elevate this and guide me. See this?
Yes, yes. That's from the sinus tympani.
Yeah.
Okay.
Now I need to be very careful. If you lose the plane, then you might leave some squamous epithelium, okay?
Okay. That's the foot plate?
Yes. We'll go a little bit near.
Yes, yes.
Okay. I
Yes.
hope you are appreciating. I can see a fantastic picture here. This sac is surrounding your tensor, tendon and all. Okay. So see the use of the suction. Yes, I'm through.
Yes, yes.
Can you appreciate the foot plate?
Yes, yes, very much.
There, yes, that little bit eroded. Huh? We will address this now. First, come to this. Yes, I am through.
Beautiful.
Yeah. And now from here,
Probably the middle ear is over.
Yeah. Now give me the straight one and some I will unpack with adrenaline. So the crux is to be in that plane, find out that plane first.
Yes.
And slowly go on elevating. Because such thin squamous epithelium, if you leave something behind, see this completely clear?
Yes. Yes.
This is a facial,
See the
processus cochleariformis, promontory. Now we have to deal with this, okay? So, thoda sa andar, yeah. दे दे रे I will unpack दे दे तर थोडा अच्छा दिखेगा. तू तिकडे नको सांगू इकडे सांग मला दे इकडे तर टाक I will unpack टाक. So now over the promontory. I will unpack. We will keep, I will unpack there and then we'll address the superior part. So when we'll come back, so there will be a hemostasis. We'll address the anterior part. Yes. Give me the suction. And थोडंसं मोठा वाला diamond, a bigger diamond पण. But coarse वालाच पाहिजे. Coarse. एवढा नाही. इधर अजून थोडंसं ब्लड घेऊन हे करता आलं तर वो तो वेस्ट चला गया कुछ और खून निकाल सकते हो वो तो वेस्ट गया देखो निकाल दो सेक्शन मोठा दे
Daniel sir said he won't operate now anything.
Okay, no problem. No?
Just ठेवायची.
एक ठेवा झाली हा
एक piece.
हा काय त्यातल्या त्या हो ना मग ठीक आहे ना ठेव काय हरकत नाही हा थोडेसे मधले लेक्चर झाले त्यावेळी हा संपल्यानंतर मधले जेव्हा लेक्चर होईल तेव्हा इंड्यूस करा मग करू आपण हा हाँ वो क्या वो कुछ ना उन्होंने गड़बड़ किया इसीलिए वो वेस्ट चला गया पंप सामने वो ठेवलं होतं मग टाइम लावा ना व्यवस्थित बरोबर ते मोजून लावा नाही तर ते होत नाही ते ब्लड क्लॉट झालं त्याच्या क्लॉट होऊ द्यायचं नसतंय त्याच्या अगोदरच थोडाही तुम्ही उशीर केला तर हा उगाच टाकू नको मला दिसलं पाहिजे See how deep it is going. Huh?
Yes, yes.
It is going to this supratubal races, I think. Huh? Let's but go. Now we have to take it out. First, a clean curve, little bit more, and then we will access that area. Get oriented. This is an anterior wall. This is a posterior wall. This is a sinus plate. This is a dural plate. Okay.
Yes, yes.
Yeah. This is anterior. I am working in a anterior tympanum. Yes, almost we have reached. Slow and steady drilling. उगाचच काय एंडोस्कोप वर टाकतेस.
I think you're through now.
Huh?
I think you're through.
Yes. मैं उसी से उसको
Yes, yes.
डायमंड बर से सब पूरा क्लीन कर रहा हूँ. हाँ? Yes, we have reached. Let's see इधर का भी ब्लीडिंग रुक गया है क्या. क्लीन करें छोटा सेक्शन. Yeah, this is better. What's it? A ball point. Ball point. That's our flap. Down it is very thin, so we will divide this later on, huh? So this is a way of preserve. So we have to take this out.
So why don't you cut it anteriorly, that flap?
Yeah, This one, yeah, I'm going to cut it, huh? Because without that it will not, here we will cut it. Yeah. So give me the iris scissor. Now that has become a very short because canal has become wide.
Yes.
Yes, so we have to cut that. Iris scissors. Choti. हा निघतोय का एका ह्याच्यात नाही एका ह्याच्यामध्ये मला बुमरँग करायला लागेल ह्याच्यातलं हे बाजूचं काढ हे जे आहे हे एवढं इथं राहू दे हे इकडे बाजूला राहू देत
Yes. Now you have access to the anterior part.
Yes. There. Flag day. Walk in. छोटा section. एवढंच एकदम डायरेक्ट छोट काहीतरी मधलं दे की So here is the eustachian tube, so you have to clean that area.
You can see the eustachian tube clearly.
Yeah, I am elevating this flap so that we can keep our graft. Now we will take this out, some granulations. Xylokinetineचा pack दे इथे, हाँ? मोठा दे जरा. So this we have to elevate. हे विसरू नकोस. So this pouch we have to take, okay?
Yes, yes.
Yeah.
That you need to exercise because
Yeah, see this. Here is the plane. Keep an eye there. Yes, I'm through.
Yes.
And from here, obviously, lot of granulations due to the cholesteatoma. So here it becomes a bare promontory. So here that PRF sheets will help me.
Right.
See this?
Yes, sir.
Little bit bleeding, you can expect this because it's a chronic process going on there. Hyperemia is there. But that will stop.
One wash will stop it. Don't worry.
Yeah. So इसको भी साथ में ले लेंगे. We don't want this disease thing. दे मला iris scissor.
Mubarak, good clearance of the disease.
Thank you, boss. this came out. Yeah. Now, see, this is quite adherent, huh? So, but we can take it out. Round window niche,
Yes.
flag knife angled. Giving the angulation to these instruments makes a perfect your life very easy while we're doing this. Even for, I think, for the microscopic.
Yeah, I think so.
Yeah. Because see, just rotating this small thing, it will cover 1/4, huh?
Yes, yes.
And your forces becomes little bit milder when you give the angle.
Okay.
Yeah. So we have to take this and we are through. So come. Better. If you are in a plane and keeping eye there, you will not lose anything. And note the endoscope, how it is helping, because nazar sab jagah hai, everywhere, huh? Yeah. So that is the advantage. It's not rest. We will keep doing the panel endoscopic versus microscopic, no problem. But just see, my eyes are here. Huh? Tomorrow in that conclave, Kirtane sir has accepted my that one video, and in the morning it will be there, where the carotid, I think I have put that small video clip in our Pune group also, but that's an unedited video. Tomorrow will be shown. So where the carotid,
Okay.
yeah, it's bony plate is eroded, jugular is high. So in such scenario, that panoramic view helps. तो इसको उठा लेंगे, our graft will go.
Yeah, a lot of grand.
Now I am happy. You are happy, Vijay?
Yes, yes.
Huh? Yeah. So possible hai?
Hey.
Hai. No. Another important thing is that after this endoscopic, when I started doing this two-handed, so I started reconstructing the posterior canal wall, and that creating that idea came for the creating new mastoid, all because due to this endoscope.
Okay.
Yeah. So you start. Here it's an extensive, that's why I have gone up to here. Otherwise, I keep a facial ridge very high and then I create a mastoid behind.
Yes.
Okay?
Yes.
I think I have done my job.
Perfectly.
Yes. So we'll just go and see inside.
I was not aware of that. I'll look at the picture. I don't find out. So what's the evidence for it?
And we will go near and see. एक झायलोकेन एडेनलिनचा पॅक दे, इथं पॅक ठेव, थोडंसं छान दिसेल. दे हा मोठा आहे, छोटा. पेरिकॉन्डियम काढलंस, वाट बघतेस. ठीक आहे.
You use this Merocell, no?
Yes. I love this.
Yeah, instead of cotton.
और मास्टर्ड में झाड़ू पोछा करने के लिए भी बढ़िया रहता है. You know, like this.
Right.
Yeah. Only yesterday, Prepa was mentioning that because it was a tremendous bleeding, this doesn't give a pressure. Okay. That's
Yes.
that's an advantage of cotton plates. Huh?
Yes.
But here it doesn't give the much pressure. But it's very nice, lint free. Huh?
Yeah.
So yeah, that is most important thing when you are working. Yes. So till that, थांब का कोमल लागले. So looks better.
Yes, yes, definitely.
हाँ. So now इसको reconstruct करेंगे, इसको periphery को हम बंद कर देंगे. Let's see how it's possible. Give me the cartridge बघू तू काढलं ना इसका. इसको boomerang भी लगा देंगे. We have not assured the hearing for this patient, but in Indian setting they want everything in one stage. So boomerang most of the time works. In such patients, I advise to give 5 days of IV antibiotic, because whatever reconstruction we are doing, that should not get in. Infection is the
cause.
yeah. Sir. So I usually give a 5 days of ceftazidime with amikacin with metrozil.
Okay.
Yeah, and results are quite
good.
Listen. तुम जो भी केस दोगे वो कर लूंगा. तुमको जो देना है दे देना, ठीक है. मेरे को तो मालूम भी नहीं अभी मैंने कौन सा देखा, लेकिन कोलेस्टेटोमा दे दो. अच्छा, एक लेफ्ट ईयर हो गया, राइट ईयर का रख दो. हाँ, तो थोड़ा एनाटॉमी ठीक है. छोड़ राइट ईयर वाला कौन सा है देख लेना. सो विल यूज दिस एज एन बूमरैंग.
That is boomerang. Okay.
करेंगे इससे बूमरैंग करेंगे. और बाकी इसको now see how I create that. This part will go in anterior epitympanum and this will cover like this. So we'll create a L. So see, it will be going like this. Imagine this.
That's Mubarak's artwork
Huh?
with the cartilage.
I love cartilage, and again this is inspired from Gadre sir. उनका पहला full big grand rounds I copied. Yeah, I've cleared everything. Daniel.
What did you copy?
I cleared everything.
Yeah, I know.
And now we are doing the reconstruction. So I will be creating the new mastoid, and peripherally we will be obliterate that with the bone paste.
Yeah. But I agree. But the problem is just the hearing, and I don't know if.
No, I'm putting a cartilage boomerang.
No, I know. But if you see the audiometric examination.
Yes.
Very low. The
Yes. But we can try to give the dry. Here, yeah.
Not a question that I know that we are able to do. But
याच्यातनं हे काढून टाकतोय ना. चला क्लीन.
Mubarak.
Yes.
There's a demand that you take an angled endoscope and show us the sinus tympani area.
I will show it with the 0 degree. Don't worry. Now it's so beautiful due to that panoramic view. I'm not showing you. I just kept I will unpack there for that only. Okay.
Okay.
So that some hemostasis will be there. Huh?
Okay.
So till that time, I'm just creating that cartilage.
You use it along with the perichondrium?
No, here for the reconstruction, I will use a full thickness cartilage.
Full thickness.
Okay.
Okay.
So this will go like this. So we'll create a L. Like this. Yes. Yes. Kunala? हा कुठे तुम्ही जाऊन आला का? हा ह्यांचं नाही मी करतो ना नेक्स्ट सर्जरी. Let him go. Let him go and see something. Huh? You want to go? To Orchid?
Depends, because if I have the lectures in the afternoon.
In the lectures are there, and I think oration.
About 2:30.
Yes.
Probably
Yes. So let him go for the then drop karo de. And the prepa?
Prepa sir is
He's also going.
has left.
Left, no? So let him go and sir. Huh?
Okay.
So you can yes. Please. It's my pleasure. नवीन घेतलाय ब्लेड? नवीन ब्लेड घेतलाय? हे दे दुसरा पीस दे आता तो हे केलेला बूमरँग साठीचा
That's the boomerang?
Yes, this is a at present it's a vertical strut, so we'll create a boomerang.
I'm doing the obliteration cavity, right?
No, I will be creating the mastoid, pseudo mastoid,
The posterior canal.
posterior, and then posteriorly I'll obliterate with the bone paste. Huh? And this is for the just will trying to create a boomerang for the pairing. He's a young boy. Let's see whether if he get benefit. Pakadna hala. Okay.
How much is the length according to that grid?
10.
This is
11, 12. Huh? See this.
1.2.
Yeah.
Okay.
So just 4 millimeter, 1, 2, 3, 4.
Just to break the elasticity. Okay.
Yes, you just break the perichondrium.
Right.
Okay.
Right.
Yes.
So that
Don't go through and through.
Yeah.
Opposite side perichondrium. Okay. See this.
Yes.
This is a stable thing. Otherwise, I create an umbrella. But here, patient is not we have not assured the hearing. Just if it gets dry cavities in second stage, we may plan also. Okay, let's go and do some endoscopy there. You wanted to see the sinus?
Yeah.
Yeah. 4 seconds. चल. पकड चल फास्ट माग मस्त. What I like.
Mubarak, I have a question.
Yes, ballpoint.
How many, what is the height of the part that is going into the oval window niche?
4 to 4.5 depending upon your height. Okay, that's a vertical strut.
I see.
And the downward part will be around varying depending upon the patient to patient, from adult to children.
That's how much? How much? 4 millimeter or 6 millimeter? Hello? Hello? Hello, we lost your voice, Mubarak.
We'll just make it. Yeah, this is better.
Yes.
So let's go ballpoint. So we'll find, identify the structure. You can see the facial beautifully.
Yes.
So cog processes cochlear forming, little bit of part of the tensor, anterior epitympanum, posterior epitympanum, facial, first genu, second genu, and it's going like this. You
Yes.
can see the eroded foot plate,
Yes.
promontory, which is a bear, round window niche. So let's see.
Yes.
Mobile. So let's go near.
So you'll cover the footplate with some tissue?
Yes, PRF.
Okay. Yes.
Now,
you can see the part of the sinus.
now again you have to focus when you go near. So look at in the anterior epitympanum. I have focused here, okay? So you have cleaned it. So we have taken it out. That's an eustachian tube. All right. So now middle ear. Give me the clean. Okay.
Yes. Perfect. There is a sinus.
Sinus.
Yes.
Some hypertrophied mucosa. Daniel, you want to comment something? You want to comment something about the anatomy? A section.
Anatomy, yes.
Section. Yeah.
I think that it's okay. It's, you can see clearly the facial nerve.
Yes.
And of course, the supracupar SS in this case was really crucial. So it's really important, in my opinion, to drill the supracupar, but for the rest, it's perfect. Perfect.
Need not to drill much more. I think I have cleared.
Is like a canal with them, like with
Yes.
with the older.
So can you see the sinus now?
Yes.
Hello?
Yes, we can see.
Yeah, just see this now. I'm in the sinus tympani. Nicely, you can see the ponticulus subiculum 2 and eroded foot plate.
Yes.
You can see the annular ligament 2. So I will cover it with the PRF sheets. Yeah. हो करू कसं
दुसरी ठेवूया राईट
चालेल ना चालेल काय राईट राईट
पलीकडे चालू करतो कारण हे झाल्यावर तुम्ही
थोडस क्लीन कर हा
दुसरी चालू करायला होतो.
नाही पण ते कसे चालू करणार आहे
हा
चालू कसे करणार आहेत म्हणजे काय एंडोस्कोपी केली
नाही नाही
हा ते दाखवायचं ना
नाही
हा
2 केस येतात.
आहे का मग एक त्यांना करू दे मी दुसरी करेन
ते इंड्यूस करायला होतो.
ओके चालेल yes okay let's go for the reconstruction let's assess cartilage जे बघू म्हणून I have to elevate here and take out that create an anterior flap give me the force angled circular. So now you can see the eustachian tube.
Yes.
So the graft will go down. I'm just elevating the flap. That's a part of our annulus.
And that was retracted, right?
Remove. I will do that annulus. There is no problem for that. Okay. Yes. चल लाव ना पटकन काहीतरी अचानक काढू नकोस yes better this is a little bit of mucosa which is remaining. I will preserve, I will cover this with the PRF sheets and then try to do a reconstruction. Give me the IV on pack so that this much. Let's go and check out the eustachian. It was completely blocked by the granulations. We have taken it out. Okay. Oh, now external cannula picture. They have done with taken out very nice PRF.
Okay.
Camera.
Yes, we can see in the PIP.
Yeah.
But if you can make it. Can you show it on the main screen?
Yeah. Main screen. Adrenaline सबसा.
Can you see?
आणि त्याच्यातनं तिकडे जाऊन काढते. मला IV लावून पॅक टाक फक्त. ते दाखवते.
I think so. The upper layer is the PRF.
काढताना फक्त एक दाखव. Yeah, so that small bleeding will be controlled. Till that time, you see the PRF and I will assess. This is our flap, very much important for the reconstruction. Cartilage. तिकडे दाखवणं एवढं कष्ट का करते जा ना तिकडे
आणि जरा मास्क घाला तुम्ही
हा
मास्क
हा तरी म्हटले गद्रे सरांनी अजून कसं काही नोट केलं नाही कार्टिलेज मला कुठे ठेवल्या सगळ्या केलेले कार्टिलेज पीसेस एवढीशीच टेम्पोरली स्पेशा ते दाखव तोपर्यंत काढते त्यांना
mask hanging here.
Hey, this is how it will go. Amala, sickle those sister.
We want it on the main screen. PRF.
PRF दिखा रहा है क्या? Main screen पे
they are removing that. See. So that's the PR.
That's beautiful. Yeah.
I'm just assessing that, okay? घेतले का?
Now you just spread it on this.
This will go like this, okay? So down there will be the air, will be connected here. And 1 or 2 pieces of cartilage I will use so that underneath there will be the air pocket which will be communicating here. This we will close with the bone paste. Yeah.
That cavity will be connected, right, Mubarak?
Yes. Yes, better. Yes.
He's spreading it on.
What is he doing with the
He'll
cloth?
be using this PRF now. Just take a slide and spread it on that. Like
आपलं boomerang बघू. पहिले एक छोटस तुकडं दे मला हे याच्यात.
Mubarak, they want to see the PRF, how it is been laid down on the slide, press.
ते करून ते दाखव त्यांना ते घेतल्यानंतर. मला
We saw how it was removed from the test tube.
या कसं ते हे करतेस ते दाखवतो. मला ब्लेड दे.
It forms a film, I suppose.
This is for my promontory and
It was just spread or it was pressed?
it is pressed.
With what?
With again I will unpack.
I will unpack. Okay.
हे दाखवते. कैमरा दिखा दे उनको. So this we will use for the bare bone and foot plate. Okay. And this whole sheet we will be using for the constructions. Let's see. इसको एक टुकड़ा और बनाएंगे. Yes.
See you there.
Yes, boss.
Because no, you are the boss. So
Are
you
boss.
have to come back.
No, yeah, definitely. Yeah. Yes, thank you. Yes, thank you so much. We'll meet there. Yes, sir. Yeah. Yes, sir. Documents. Okay. Let's go. मला हे दे. एकदम छोटा section. एकदम छोटा section. फोर्सेप चांगलं दाबून जरा कर शीट्स लागणार आहेत.
त्याला कट करू का नको?
त्यांना करूया. अरे मला बॉल पॉइंट.
That covers all the bare area.
Yes, that's
Promontory.
covered the promontory and मला दुसरं बोन दे आपलं कार्डबोर्ड नाही आपलं बुमरँग बनवलेलं. Only problem is the infection. Okay, so that's why you have to give antibiotics. Huh? Here we are thinking now, because even for this, if we have what you can say, a titanium wire bent and woven through the cartilage, that will become a much more stable. That's an idea. So let's see how it will work, because it's still cartilage survives fantastically, but many of the time it gets dissolved. See, although it was looking like as an big here, but it's 4 millimeter is also a big here.
Yes. You make it short.
Yeah. Yes.
Yeah. You'll have a good height. Middle ear.
Thank you, sir. See, now, yes, it's fitting. But you have to do all these things gently, otherwise you have to rest your fingers. Yesterday I told you the both little fingers, so for the stability. We will cover this again. Yeah. Another piece of cartilage, and then PRF, and then temporalis fascia. Cartilage.
One more in the anterior part.
Yeah.
Hello, Dr. Mubarak. Good afternoon. Yes. This is Dr. Belsare here.
Yes, madam. Good morning. No, good afternoon.
Good afternoon. Yes. Have you made a notch for the inferior part of that cartilage, or it is resting on the hypotympanum?
No, it is just resting in the hypotympanum. Come again? ठीक है, उतना ठीक है, 70. PRF. छोटा वाला दे मला PRF. हे बघ, हां. हे तसं करू नको, जरा चांगलं बघ. कुछ दिख नहीं रहा. बस एवढाला आहे.
This is PR.
ठीक आहे. बॉल पॉइंट. काही इन्स्ट्रुमेंट लागतात तेवढेच ठेवणार. मला नॉर्मल सलाईन दे, ड्राय सगळे असे इन्स्ट्रुमेंट दिलेस तर कसं होईल. दुसऱ्या ठिकाणी आल्यानंतर विसरायचं नाही आपलं. Give me the big piece of PRF now. Mubarak.
Yes, sir.
What is the fate of this PRF later on? What happens to it?
Sir, this gets dissolved later on. The idea behind it is it has got the growth hormones, lot many stem cells. That is what this all dermatologists and orthopedicians are using. So wherever it is kept, if it is kept on the bone, it functions as a bone. It helps osteogenesis. If it is kept over the skin, this is a hypothesis, and that's why they are using. It's a lot of research is needed. Yesterday, I was talking about that only.
You mean to say it gets liquefied later on and get absorbed?
How much time? Oh, come again?
You mean to say that it gets liquefied later on and then?
Yeah.
Okay.
So the function is that now I have kept it over the cartilage. So it will help for the cartilage.
Means he wants to ask you whether it gets converted into a fibrous tissue or it becomes dissolved and
it dissolves and it function where it is kept. It takes a function of that tissue. That is an idea. That is means the stem cells which it has got. I don't have any research with this. Okay, this is just a clinical. What success I am getting, I am doing this. So the research needs to be done. Just what research we are doing at present, sending these PRF sheets and just asking pathologists to see how many platelets are there. And clinically seeing what is the with PRF and PRF results, whether it's improving or not. So it's encouraging that it's improving. Yes. So now some another piece if you have got. त्याला आपल्याला वर ठेवायचं. अरे. And I saw the very encouraging results with the mastoid, okay? In the recent, because we started this for the last 2 years, and the way the healing is happening, it's quite astonishing. And we are not doing any harm. These are the platelets are owned by the patient only. So we are returning back on a lighter note, but in a concentrated fashion. So just one piece here, I want in a anti-repeat tympanum because that's completely bare. Yeah, that's now better.
Dr. Mubarak, there is one question from audience.
Yeah.
For how many days or for how many months you've been using this as a material?
How many?
Like how many years you are using PRF?
This one?
Yes.
For 2 years.
For 2 years.
Healing is really, really fast. Okay. So if you see post-operatively this, give me the temporalis fascia. ये cartilage है?
No,
sir.
tissue.
You want to put the bone paste of?
Yes. In the periphery.
Okay.
It will not come over in the middle ear or near to the. No masala. PM fascia. The suction is really troublesome here, and instruments really makes a life ill, because whenever this crocodile forceps you use, many of the time that tissue ekdam chota de, ekdam chota. Okay. Ball point. बुडवून दे आणि एक ऍबजेल दे चांगला.
अच्छा.
It's very thin fascia. See that? काय रे, थोडस मोठं दिलं असतं तर काय झालं असतं. थोडस मोठं दे. But take a time, okay?
Hello, Mubarak.
Yes, sir.
Yesterday you put this PRF on above the graft. Today you're putting it.
Yeah, I am putting again. I have a lot of PRF. Huh?
So you will also put it on the graft.
Yes.
Sandwich. Okay. So you will not leave any bone bare anywhere.
Yeah, exactly.
So that is how the healing is fast. And how many days antibiotic you give?
For such extensive cholesteatoma, at least for 5 days. IV antibiotic.
Okay.
Because what I have seen initially, I used to be just given oral antibiotic for 3-4 days, but infection is really a problem at our. And then whatever you have done this, just washed away with the infection.
Don't you think 5 days is also less?
Huh? Actually, I sometimes feel it's less.
Okay.
But
no, you said injectable for 5 days.
Yeah, injectable for 5 days. Yeah.
And oral again for some.
And then oral antibiotic. Yeah, again for 10 to 15 days. Yeah.
So total for 15.
Depending upon the healing. Huh? You keep.
How often you call them for follow-up?
After 1 week, just take out that pack. And then every 15 days for 2 months, and then every month till for the 1 year.
Okay.
This we are going to cover up with the PRF. Okay. So adjust it. When the fascia is very thin, really sometimes manipulation is a quite tough one. And now try this with the single hand. And all this reconstruction. Again, note the panoramic view. Huh? Everything is in front of you. So whenever it is sticking, take a Ab-gel and just mop. Now it's better. And then we will elevate it again for the bone paste. Okay. Convincing?
Yes, yes.
Still not?
Oh, this skin looks very good. This.
See, I already had a very good flap here. It will come and cover like this. Okay, both the things will come.
Are you going to use the bony pate?
Yes, yeah. Now that's a turn.
Some people feel that the bone pate, is again inviting infection.
No, that's why I take that bone patty from the outer cortex only. If you have seen today's case, I have taken initially from this outer cortex.
Yes.
Not in this, yeah. You the bone paste. ये काय सॉफ्ट टिश्यू है क्या ये?
हाँ.
देख रहे हैं.
हवे. That's nine.
This is just as a soft tissue. Whatever we have kept that. Then nothing. Use all the material, whatever, because it is. एकदम पानी केलं नाहीस ना त्याला.
नाही.
हां. Only in the peripheral part. That's why this type of cartilage you have to keep. Then and then only the air comes from there, and then it functions as an neomastoid. And your beautiful functioning mastoid again. So I'm not completely obliterating this, okay? It's only in the peripheral part we are reducing the cavity. Even you can mix the PRF liquid, that is PRP, in this. So it becomes a more osteogenesis is a little bit faster. So she has mixed a little bit of that PRP also in this. गद्रे सर आहेत का सर काही कमेंट?
नाही मजा मी बघतोय.
अच्छा नाही जस्ट सजेशन किंवा काही सर?
नाही it's beautiful surgery. I'm enjoying it, so I'm just watching.
Yeah. Thank you, sir.
Did not even go for lunch.
Yes, sir.
कोकणस्थ ब्राह्मण आम्ही सारे वार लावतो.
हाँ सर.
मी आम्ही वार पण लावलेले नाहीत.
अच्छा.
Sir means to say that he has not even gone for lunch.
अच्छा, अरे sir, thank you, sir. And only in this part. And believe me, this functions beautifully, provided the infection doesn't occur. So you follow the patient. If you feel, whenever I feel that, yes, there is a little bit of chance of infection, yeah, I give IV antibiotic little bit more time. Huh? Yes, now see, it was so huge cavity. It was an extensive cholesteatoma going till the tip. Now we have reduced it. And this is a young boy, 17-year-old. And working as an OT technician. So he will be happy, hope so, for if we give this no cavity. So this is that flap, okay? Soft tissue flap, okay. So we'll go and repose back again, little bit more here. चल PRF, इसके ऊपर भी PRF.
बघणार आहे. आता
पहिले PRF दे हा. त्याला केलं नाहीस का काय?
नाही, ह्याच्यात आहेत छोटे तुकडे.
छोटे तुकडे नाही, याला मला वर ठेवण्यासाठीचे 2 तुकडे करून. Ball point.
So you put PRP on top of the body, is it?
Yes.
Sir, I am Dr. Sriram Murthy. I would like
Yes.
to ask one question to the Professor Gadre, sir.
Yes, sir.
I have a little doubts about that, but you have to clarify it.
Yes, sir.
This is completely, he filled the middle ear and mastoid with all materials. Then how does it functions like that? Where is the gas exchange? Where is the buffering activity?
Very good question.
Even he not having not even a 1 ml of volume of air inside the cavity. How it works? How
What gas exchange? Huh?
Sir,
I told you I created the neomastoid. See, this my neomastoid is here. It is connected to the epitympanum and then to the eustachian tube. Here it was completely blocked. We have taken out that cholesteatoma from there. Now the air is underneath that cartilage. Have you seen that L-shaped cartilage? We have created almost a nice space under that. And now this air will be coming from there, okay? And the air is underneath this. And if it is well functioning, even some air enters under this bone paste and neomastoid is formed, okay? Beautifully. So that is the idea only here. So we are not obliterated. That's why this bone paste. We have not used some muscle or something like that, okay? I hope I addressed your question. Or anything you want to say, sir?
Sir, I don't know because you have already filled up.
Even I don't know, sir. I'm just working, okay, and trying to understand the nature, how the nature is working, why this is happening. That is what. I'm also ignorant man. I'm just trying, doing trials and errors to get that extra 1% of success, sir.
That's not the correct. Nowadays, there is a lot of evidence-based medicine is coming because
yes, sir.
For a function of normal middle ear ossicles, the air should be at least 1 to 2 ml inside the middle ear cavity.
Okay, what you will do in such cases, sir?
Because that's why I'm asking. I don't know, but how
no, for this. Because I asked Daniel. Daniel said, I will do this subtotal petrosectomy for this. And there is no hearing. So,
sir, he is obliterating the mastoid cavity.
No, in periphery,
need not be aerated. In sclerotic mastoids, which are there in 20% of the normal people, there is no aeration in the mastoid region. We need aerated middle ear space for good hearing. But mastoid can be obliterated. We are doing it.
And that is in the periphery, not complete, okay?
Hey, Gauri, that is to avoid leakage. See, mastoid will weep if there is no air. So he didn't clean that area.
Oh,
so he created a new mastoid there.
Residents
the radiation should be there, it should not leak.
सब चलेगा? इसको IV antibiotic देना है?
So he has exenterated all the cholesteatoma and all the cells, and now he is obliterating it, thinking that this will get converted into a sclerotic area.
Yes, this will be the sclerosis, but it is not complete obliteration, please. I have created the neomastoid down there. Have you seen that L-shaped cartilage?
Yes, yes.
Underneath, yeah.
So what we are seeing,
idea is that
created a middle ear,
yeah,
which is connected to attic and up to the antrum.
Up to the antrum, yes.
The rest of the part is obliterated.
Yes, and so the idea is that if you start functioning from here, so the air enters into this bone. See, this bone in the bone paste is not going to become a rock solid in the next 6 months. Okay, so in this bone paste, this is a whatever bone patty we have used. Small air enters in that. Okay, So now our research is going on because we are doing it for the last only 2 years. We are trying to take the healed cavity. We are just trying to take the X-ray again and seeing how the mastoid is there. Okay. And even the CT scan. So those things are going on. We'll come up with something.
So,
Mubarak sir, what
Yes.
is the percentage of infection you have encountered in those 2 years, sir?
Yes, previously when I was just very overconfident and thinking that, I will not give antibiotic and all, 5% infection rate was there at that time. It's two years back when it started. When I started IV antibiotic, now it has come up to 1%. Still there is an infection because the problem is that this cholesteatoma is having a lot of pathogens. Okay. Although you are drilling, you are clearing everything. So there are so many things in that. So the PRF. So I think I have done my job. Any suggestions? Any opinion?
Very nice surgery.
Thank you, Mubarak. Nice demonstration. With a lot of patience, you have demonstrated. Good, sir.
Yes.
Thank you very much.
Mubarak sir,
Yeah.
can you show us the anterior repeat tympanum once? I think it is not totally covered.
So see, that's what I'm doing. Seriously.
Just anterior to that.
See, everything is due to the endoscope. You are seeing, there is small spot, this pocket is there, right?
Yeah, that's why I'm asking.
Yeah, so that's why I'm taking this face shot. See this.
Okay, thank you.
Yeah. Better. And now this is all important. If it is not there, definitely it's going to fail. So that's why I meticulously see that this flap is created. And now again, my lovely PRF sheets. Thanks to Dr. Sapna, because she and our one fellow Nilay, who has come for 15 days or 1 month. So we were just discussing, ऐसा करेंगे तो क्या होगा, कैसा करेंगे तो क्या, तो like this idea came. और नुकसान क्या है? पेशेंट का ही खून है, उसको रिटर्न कर देंगे.
Okay, great demonstration, Dr. Mubarak.
Yes.
Both the operative sessions were extremely lively because of the moderators. So as a token of appreciation on behalf of organizing committee, I call the moderators, Dr. Vijay Sonone, Dr. Haritosh Velankar, Dr. K. Jivan Pradeep, Dr. Rajesh Yadav.
Hello. I have already told you about the SEOCON, which is on 24th, 25th, and 26th of November. We have planned good academic things for you all. I hope you'll enjoy it as you have enjoyed today for the last 2 or 3 days, this program. So I once again invite you. So please register. All the details we will be putting on the screen sometime during the day.
I invite Dr. Gauri Belsari also on the stage. Please come. She is the organizing chairman. Welcome.
चल बाजूला कमी Okay.
I'm very happy to see so many interested otologists here. So my sincere request to all of you to attend SEOCON. We are holding ISOCON in Pune at Marriott. There will be live surgical demonstrations. This is on 24th, 25th, and 26th of November. And we are very happy to announce that we'll be showing very good surgeries, starting like eustachian tube surgeries. Probably first time we will be demonstrating in live surgery workshop. Then probably one middle fossa and facial reanimation procedures for long-standing facial palsies. So I'm sure you will enjoy this academic event, and I would request all of you to register for ISOCON. We have the details at NVK Pharma stall also, and we'll be displaying it here also. Thank you.
I also welcome Dr. Sudhir Bhalera, who is the treasurer for this upcoming ISOCON. Welcome.
जल्दी जल्दी section दे जल्दी.
Thank you very much. Basically, I would like to invite all of you. You'll definitely going to be very pleased with a Puneri welcome and in a Puneri style. So please do come and register for this ISOCON. It's going to be an academic feast, but definitely it is going to be a fun-filled extravaganza also. Thank you very much.
I present this moment.
So this is our flap. See this. Hello. पटकन चालू केलं ते ना लांबड्या केलेले कट करते पडत्या दे.
Hello, we'll have a series of 3 lectures now. For this, I welcome Dr. Rajesh Koli, Dr. Hitesh Patel, Dr. Prajakta Patil, and Dr. Poonam Khairnar as moderators. First of all, I call Dr. Khageshwar Raut for his presentation. Oh, sorry. Just 1 minute.
थोडंसं yes. बंद करो. Thank you very much to all for the patient watching. थोडंसं नॉर्मल सांगा. मी काय काय अँटीबायोटिक. काय करते थोडं छोटं पकड.
Good afternoon, one and all present here, respected moderators and delegates. I am Dr. Khageshwar presenting this my topic. At the outset, I will thank Dr. Mubarak and Sopra and team for inviting me and giving this opportunity. My topic of presentation would be endoscopic transcanal management of tympanoclerosis. As you know, endoscopic ear surgery has gained popularity in last few decades. And we are doing, you saw last 2 days, we are doing almost all standard otological procedures and advanced otological procedure being done with endoscopy.
कालचं राहिले लेक्चर आहे. एक मिनिट.
तिकडे दुसरा नंतर हे करा. पेशंट इंड्यूस करा लगेच, म्हणजे संध्याकाळी रात्र होईल, नाहीतर आपल्याला.
3:30 वाजले तर.
हा म्हणून म्हणतोय लगेच इंड्यूस करा. मग काय थोडस खाऊन घ्यायचं असेल तर तोपर्यंत इंड्यूस करतील ते.
आधी मला मगाशी रिलेशनमेंट बघितलं.
हा नाही, ठीक आहे ना, सगळे साइड एक्स मध्ये टाक.
I welcome Dr. Latkar as a moderator for this session. Yeah.
चल गे. हे दे मला. प्रेस कर पहिल्यांदा थोडस. घे. एक गॉच पीस थोडं सॉल बोला. वर उचल थोडा.
माझा फोन होता बोलायचे तुमच्या बरोबर 4:30 वाजता ओरेशन आहे. ओरेशन टाइमात व्हायला पाहिजे.
बरोबर. मग
केस करायची
मग सोडून
काय
हे करून टाक, कारण काय फारच जास्त येईल ना. होणार नाही कारण
ब्रेक करायला होतो मंडे.
ठीक आहे, ठीक. नाही मी करणार.
मंडेला येऊन करणार
बिलकुल. एंडोस्कोपिक
या की हे सगळं नसणार मंडेला.
कोण
ही सिस्टम नसणार आपल्या सिस्टम मध्ये.
नाही तुम्हाला
हे ना
स्पायकर आहे ना. हे
मंडे तुम्ही बोलत
नाही बोल. नाही ठीक आहे सांगून दे. यू कॅरी आउट करा. आता 3:30 म्हटल्यावर 3 लेक्चर असतो, 4 होतात. 5-10 मिनिटं राहतात. हा ठीक आहे. सांगतात त्याला की हे बरं गो अहेड म्हणा. बाकी उद्याचा अनाऊन्स कर. उद्याची हे सर्जरी आहे म्हणून तेवढे टॉन्सिल आणि सेप्टम. ठीक है. नहीं इधर नहीं होगा, उधर होगा. वो उधर संडे का. तो उधर चालेल. मला पाहिजे तर मग मी येऊन करेन, पाहिजे तर सांग.
So we have to manage with this. So endoscopy here has gained popularity, as you said, and you saw a lot of people are keen to do a lot of standard otological procedures, advanced otological procedures. So this is the institute where I work. The Kalinga Institute is a medical 2,500 bedded hospital.
आरामात काय नाही. आपल्याला 6 पोहोचलो चालते. आपल्याला टाइम आहे. सगळं विसरायचं नाही सुद्धा. And the whole
about little about the history. The Kasabah was fast described.
त्याला रफिकला बोलवून घेते. तिथं कोण आहे का आपल्याला? गाडी नाही तरी लागणार आहे ना. महादूला येऊ दे घ्यायला तोपर्यंत. हो ना, मग महादूला बोलवून घेतो. त्या रफिकला बोलून घ्या, सामान तुला घेऊन जायला. हा काय बोला.
Explain the difference between otosclerosis and tympanosclerosis in footplate area, and the term tympanosclerosis for first time, and how it was want to establish the possibility of surgical treatment. There is a role of surgery in 1960. Then sides are not coming. What are the slides are not coming? What is the problem? किसी का नहीं आ रहा है? नहीं तो चलो स्लाइड पे जितना आएगा देखेंगे हाँ टाइम पे ना अच्छी लीव इट टाइम डिले हो रहा है स्लाइड्स कमिंग कुछ कुछ आ रहा है सॉन्ग स्लाइड पे कम नो स्लाइड तो मैं पता चल जाता है ना नो 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 तो इसमें तो नहीं आ रहा है यहाँ कैसे पेन बैग see my laptop it's not moving no slide is there I thought all the slides huh no empty slide number 13 14 is there everything is there why is it not coming surprise no I make this okay video extra video everything is there I don't are you present then you will sufficiently do that
Yes, just close everything now.
but this is not closing now that's
There is
hang system has been hanged yes maybe my system has been hanged so I will take a so I will fix my problem and speak later maybe. So technical problem, sorry for disruption. I will ask my next speaker to come. By this time I fix my problem, I will come. Thank you.
Yeah, it's fine. Sit. Password है. नहीं.
नहीं गिर जाएगा
Good afternoon, everyone. You have been seeing and listening to a number of surgeries and lectures based on endoscopic procedures in otology. And this lecture is basically for the residents and junior faculty members probably who are wondering, how do I do it? Because I can see the experts doing it in an excellent manner, and it seems to be pretty easy to do it. But it's not something that can be mastered over a day. It's something they are doing over decades. So I thought it is better I take you through some brief descriptions wherein you probably can start learning the use of otoscope, the endoscope in ears, so that you can master this endoscopic ear surgery better. So I'll just give a brief introduction. Then I'll describe about the advantages and disadvantages of using the microscope for examining the ear or operating. Then what are the advantages of using the endoscope for examining and for the surgeries? What equipments or setup you need in outpatient departments to perform outpatient procedures using endoscope, and the procedures that can be performed in graded manner, and I'll give a brief conclusion of that. As you know, the use of otoendoscope was started in 1980s by Dr. Thomason. And do you have the slide changer and the laser projector? Laser. I on this also. Oh, yeah, it does. Yeah. Fine. So Dr. Thomason was the one who started using the otoendoscopes for visualizing the middle ear. As we all know, Dr. Muaz Tarabishi was the one who popularized endoscopic ear surgery. And we have with us Professor Marchioni and even Dr. Prasuti were the one who were the pioneers in this field, who have described the principles, the indications, and the surgical techniques for endoscopic ear surgery. So their work over the decades has come a long way, and it is really beneficial for the beginners to go through their literature to understand these things better. As a faculty in a medical college, I started using the endoscope for examining the ears many years ago, started doing endoscopic ear surgeries purely for tympanoplasties almost for a decade now. And I was fortunate to meet Dr. Mubarak Khan and get trained under him in his 9th master class in 2018. And that made me pick up this to a greater height, and I'm able to do most of the ear procedures under the endoscope now. What changed the way I started working was during the COVID again, because we were using microscope for the OPD procedures to visualize, to clean wax, and basic otological procedures in OPD. But as you know, during the COVID times, if you're doing a microscopic examination, the breath that's coming out of the patient's side of the mask is only about 25 centimeter, maximum feet from your breathing space. So I didn't like that. I thought this is not going to be a good way of doing. So we started using endoscopes for examining the ear, that most of us anyways do. But small procedures, we also started doing in the OPD with that itself, because at least you'll have a space of about 1 meter from patient's distance. And that helped us start improving our practice with the endoscope. So under microscope, either for the procedures or for the OT, you get a good magnification, bright light, sharp image, stable view, multi-axial field, and you can use 2 hands. That's what we always claim as an advantage of microscope. But in outpatient department, again, the second hand is always for holding the speculum. It's not of much benefit for the procedures as such. Yes, when the canal is narrow, it's difficult even under microscope. The field of vision is limited. You have to keep changing the area that you're focusing, and difficult to see corners. Sometimes, especially for the beginners, even the hand itself is an obstacle that blocks your view field. So if you shift to an endoscope in the OPD practice itself, you still need, you get good magnification, bright light, sharp image. And if you're doing it with one hand, the maneuverability is always in your hand. So you get a good proximal view, wide field of vision. You can see under the anterior recess, the hidden areas. And the best thing is you already have the setup in your outpatient department. You're doing diagnostic nasal endoscopy, video laryngoscopy. Again, someone who's starting a private practice, you don't need to have a microscope in the OP just to see, examine, remove wax, foreign body and other things. So you can manage with the same endoscopes. Yes, there are challenges because narrow canal is still a challenge. And to have the scope and instruments inside the canal again might look a little difficult. Of course, there is a learning curve. The fog and debris can trouble your view field. But for the shorter procedures, this heat is not a concern because you're repeatedly removing the endoscope, cleaning and putting anyways. This is something that has been always associated with endoscopic examination or procedures in the ear is lack of binocular vision. But people have gone through barriers of ear and nose. They are doing skull-based surgeries with the endoscope. So I generally cut this off because I don't feel it's the depth perception which is a major concern as such. So this is the field of vision that we get usually with the microscope, and this is the field of vision that you can get under the endoscope. This is again taken from Dr. Marchioni's book. So you can see this has all been explained very well in the past also. This is the field of view that you'll get with the microscope, and this is the field of wide angle that you get with the endoscope. That's the same reason why we need to go postorally most often to get a wide field of vision under the microscope. Even the axis of view is better in the endoscope. We will be able to visualize the attic region much better in the outpatient examination. We all know the positioning and how we sit besides the patient to operate and all that. That is also very well explained by Dr. Ajay yesterday in the tricks and tips for endoscopic ear surgery. Coming to the OPD setting, these are the patient will lie down supine with the head turned to the opposite side. You can be working like how you do a nasal endoscopy. You just need to ask one of your assistant to retract the pinna, control the suction tip, and through the monitor. For the other side, you don't really need to shift the monitor or anything. You just need to make the patient roll over to the right side to examine the left ear. Make sure the patient folds the hand, keeps under the head for the support. Make sure the shoulder, left shoulder is kept lower down so that the examination of the ear is easier without the obstruction by the shoulder. So you can do the OPD procedures under the same setting that is available for examination of the nose. So you can do simple procedures, suctioning out of the otomycotic debris, wax removal with the probe, foreign body removal, intratympanic DEXA you want to give, you want to cauterize small perforations, small granulation tissue in the canal, even large MRM cavities, which is hardly accessible through the microscope. All that can be visualized clearly and we can clean that. So when to shift from OPD to OT with the endoscopic procedures? Of course, there is no bypassing. You need to learn how to handle mid-ear structures under the microscope. That's the first thing to do. You also need to understand how to do endoscopic nasal surgeries, wherein you understand how to use your non-dominant hand for holding the endoscope and the dominant hand for doing the procedures. Then you club these two things together, start examining the ear under the endoscope and do minor procedures in the OP. You will be better off in the theaters, wherein you can start performing these procedures again in the theaters. And a patient who is having too much of pain, oil keratosis removal, or child wax removal, myringotomies, as such, you are not using your contralateral hand for the myringotomy procedure. In stapedotomy also, most often it is a single-handed procedure, the other hand hardly requiring much of a work. Then comes myringoplasty, tympanoplasties, limited attic work. When you want to do more of squamous cell disease, then yes, probably you require your both hands. As you already seen today, you may require mini endoral incision, and for drilling, obviously, you need your both hands. Of course, you need to go through literature. Marchioni sir's book is there. You have excellent description of anatomy. And as Garrison told, a book is a gift. that you can open again and again. So you need to go through this literature to understand the mid-layer anatomy with the from the endoscopic point of view, and you'll understand the mid-layer folds and the ventilation much better, because the endoscope has made it understand is much better. Of course, you need to attend this kind of courses. Dr. Mubarak holds master classes, and he has fellowship program which can be running through over a week, through a month, and definitely that's a good program which can help you understand how to build up your endoscopic ear surgery. We are also coming up with the association with cancer. We will probably come up with the otology and endoscopic ear surgery fellowship in our Manipal University, and from next academic year we'll be starting this 1-year program. Keep looking for it in the manipal.edu website. You will find all the details in maybe in another 6 months. So to conclude, you still have good magnification, brightness, sharp view field, and maneuverability when you're using an endoscope. You get a good panoramic view. You can see hidden area. You can perform most of the OPD procedures with the auto endoscope. Setup is already there. So for a practitioner, you don't really need to have a microscope nor have the space for that. You can manage if you started using it during your residency itself, and then you proceed towards the theaters using endoscope for basic surgeries. I thank Dr. Khan sir and Sapna ma'am for providing me this opportunity, and also starting this society for endoscopic otolaryngologists, and I thank them for making me the vice president of this particular association. I hope this is our first international conference. Hopefully we'll have many more, and we'll be happy to have many members in our association and develop this particular field. Thank you, everyone.
Thank you. Thank you, Dr. Devi Prasad, for sharing your experience and guides and tips. Please continue with your second lecture.
Yeah, it's on. I assume you people are not bored. That's why they want me to come up with my second lecture straight away. So again, it's another very basic topic, and you've already seen a lot about it. Okay. We'll use from here. Again, a brief description about why or how we use the grafts and what are the various types of grafts and their qualities. The tragal pericardium, which is predominantly used in endoscopic ear surgeries, either as a composite graft with the cartilage, is what I'm going to speak about in brief. The graft placements, and I'll give a brief summary of the description. So as you know, tympanoplasty is one of the most common surgeries performed in otology. And to reconstruct tympanic membrane and or the ossicular chain, obviously we need various types of graft materials. So depending on the type materials, grafts are either autografts, allografts, homografts, or heterografts. This again you would have studied in most of the undergraduate books. It's again promotion of our own book from Manipal University. We have written an undergraduate book for CBME, and I happen to write the chapter on myringoplasty and tympanoplasty. It's by theme publication. So in that I've described the basic autografts that are available. That's basically temporalis fascia, used by worldwide. Majority of the people use that as the preferred graft material because it's available in the same surgical site, because it's a post-oral incision which is done in majority of the instances. At the upper end you can always get this graft. The thickness is very ideal for the reconstruction of the drum. It has very less BMR, so requirement nutrition is less. You can expect it to stay for longer so that it survives well, and it is available in plenty. Tragal perichondrium, tragal cartilage, either in isolation or with the perichondrium. tragal or conchal cartilage. If you're doing post-roll, you can try and use conchal cartilage also. Slicer is very good to reduce the thickness of the cartilage, as Dr. Khan sir has mentioned, and it is already published. A 0.5 millimeter thickness of graft is ideal for the reconstruction of the drum. It will give a good stiffness. At the same time, the vibratory pattern and the nature is similar to that of a normal drum. So it is good to use it, especially when you have a atelectatic drum. In cases you're running short of grafts, we have fascia lata. Periosteum can be harvested from the lateral cortex beforehand. And these are things which are easily available, economical, and it is having a good take-up rate. Coming to the ossiculoplasties, we have all seen how the incus can be drilled, modified, and used as a vertical strut over the stapes suprastructure, or using the mastoid cortex bone. But again, a residual disease in that case might be a concern, for which we generally don't want the remnant of the incus to be used in the ossiculoplasty. Allografts are available in plenty, made up of either Teflon, titanium, glass isomer, polymers, either in isolation or combination of these are also available. The advantage is they are ready to use and a good shelf life. You can keep it for longer. You can trim it, you can modify the size, but they are not cost effective. In our case, we don't want to really tax the patient more. So that's why cost factor always comes into picture. You want to put a titanium piston, 10,000 rupees for that. And the surgery itself, if you're saying 30,000, patient will say that is too much of a cost for the piston, isn't it? Rejection and extrusion is another concern. So that's why people started using a slice of cartilage on top of this Teflon titanium also. Again, so it's not really serving the purpose then. If it is not really going to stay there for long, we probably go back to the cartilage grafts, and that's what is being done in majority of the places nowadays. And these are for the completion's sake. Homografts have been used in the past, wherein tympanic membrane and ossicle from the cadavers were harvested, used to reconstruct. Ethical issues, and as one of the professors explained in the morning, we were running around, even we did it in our residency, go to mortuary with 70% alcohol, and we assume that the cadaver, the person there for the post-mortem doesn't have any illness that probably will get transmitted by the dura, and you befriend with the person who is the technician there, who is doing the autopsy, and get the graft of the dura and use it. Because then the professor would claim that I don't even have to put any incision. We can straight away put this graft. So we believed all that is good, but now that is something that is having ethical issues, and probably it's not something that we should be doing. Coming to the precise usage of perichondrium and cartilage, there are certain techniques which again I learned from Dr. Khan only. You can use a small disc of cartilage with perichondrium on either side. This, he calls it a butterfly graft, wherein you need to use your round knife to measure the dimension, the rough dimension of the small perforation that is there. So of course, you need to freshen the margin. You have a rough idea about the diameter of the perforation that is there. Take out the composite graft and trim that size cartilage. Obviously, the grid will help to measure the dimension precisely. Then you're going to hold it sideways. With the knife, you're going to make a circumferential mark on the cartilage. So what happens? The perichondrium and cartilage on one side, one groove, and perichondrium and cartilage on the other side. So this more or less is like a grommet going into that perforation which you have freshened. And you can see one of the cases wherein it is taken up very well. You can see the vascularity also. This is a TS patch, of course. And when there is not much of a hearing loss per se, but the patient is irritated by on and off discharge, itchiness, irritation, this minimalistic approach is also good enough sometimes to take care of the disease process. Coming to the composite grafts, which they have demonstrated today also, you can peel off one side perichondrium. You can use it as an augmenting graft and see how well it can take up. And you can see the nice vascularity on top of also This groove will help you to accommodate the malleus handle well, and this kind of reconstruction is also possible with the composite graft. Tragal cartilage with perichondrium can be used in various other manners, like a cartilage shield to prevent a retraction pocket from arising again, atelectatic drum, palisading grafts, a disc. When the incus is missing, you can create a disc from the cartilage with at least perichondrium on one side, make a fenestra in that and place it on the stapes head. You can create umbrella. Again, when the stapes suprastructure is missing, through the same disc aperture, you're putting a strut of about 5 millimeter cartilage through that. Again, that will stay as the handle, the suprastructure of the stapes, and the remaining disc will help as the conducting medium. Boomerang, you have already seen. Vertical strut is another way of reconstructing the ossicular chain. And for a small cavity wherein you're doing a bondage inside out, you can always reconstruct with the composite graft as a soft wall reconstruction. That's about the tragal perichondrium and cartilage. When we are talking about graft, we are, again, for the residents' benefit, I would like to cover the various ways of placement of the grafts. Majority of the world follows underlay. This is how the perforation would look like, and this is how an underlay goes. So you're lifting the entire tympanomeatal flap and the tympanic membrane, including the annulus. Obviously, you're transecting the mucosal layer coming from the posterior part of the mid layer into the undersurface of the drum, and you're putting a graft underneath. So theoretically, there is actually 5 layers that's going to be created at the end of the day, but in practice, we know underlay is obviously not bad. We have seen that the results are, of course, good. But there are better ways of reconstructing the drum then, wherein you will not have, back again, the concept here is the mucosa is still lateral to your drum. The whatever reconstruction you're trying to do, the mucosal layer is still lateral to it. So there is always a chance of mucus secreting further, coming as a red drum and causing trouble later. So how to bypass that? So you can do onlay, wherein when you're lifting the canal skin as a tympanomeatal flap, you lift the epithelium of the tympanic membrane. We somehow believe that it is a difficult task, but I think over time it's not so difficult. You start with maybe a large central or a subtotal perforation doing this. Yeah, the concern is you may end up leaving some epithelium which becomes a pearl in the future probably. And I don't think it actually becomes a cholesteatoma. Pearl is a possibility. Anterior blunting is a concern. That's a possibility. So you need to make sure the graft is nicely tucked anterior inferiorly so that you don't run the graft like a bottom running through in the anterior part. So obviously you need to make sure the anatomy is held well here. Ideal to keep the graft under the malleus handle even in onlay. But in single-handed endoscopic ear surgery, it's practically difficult. So we do get away by placing the graft on top of the handle of the malleus, but you need to make sure it doesn't get lateralized in the due time. Interlay probably seems to be an ideal situation wherein you lift the upper 2 layers and place the fibrous layer between the mucosa and the graft between the fibrous and the mucosal layer. I've tried this, but when we are doing this, sometimes the mucosa doesn't stay back. It is more fragile than the fibrous layer. It ends up coming with the layer that you're elevating. So you don't really end up having a mucosal layer. It effectively ends up becoming underlay at the end of the day after all your difficult dissection. And we have Dr. KPS Prabhu in Kannur, who is popularizing this technique called total annulus excision. Maybe we'll keep the discussion for some other day. It is something which is always discussed in most of the conferences now, wherein you excise the entire drum head and you're going to reconstruct the whole thing. The idea is you will not have the remnant of mucosa on the under surface of the annulus, which potentially is a reason for further mucosalization of the drum head, discharge that you end up having, and the thick mucosa underneath the drum being the reason for failure of graft uptake. Probably that's how you can improve your surgical outcomes, is something that is, it's already been published also in international journals, and Dr. Singhal has published this from SMS Medical College. So these are the various ways we can place grafts also. Whichever material you are comfortable using is go ahead with it, because there are studies which have compared temporalis fascia with the tragal pericardium, plenty of them. And I think the results are equivocal. There is no reason to believe that one type graft is better than the other. Whatever works best with you, I think you should try and go with that. So to conclude, of course, graft materials are important. There are various types of materials, and I already highlighted their qualities. Try and using the tragal perichondrium and cartilage in your subsequent surgeries and see whether it suits your requirements, and look into doing onlays. Trying in a subtotal perforation in a large canal, probably you can do it, and you'll definitely understand that it's not difficult to elevate the outer epithelium of the drum. And when you're doing a tragal perichondral graft on an onlay with a single hand, it's probably the easiest way of reconstructing the drum head. Of course, these are my second talk was supposed to be apart from this one. But anyways, you can always go for all these fellowships. Hopefully we will start our fellowship, and I'm happy to associate it with this particular conference. Thanks to Khan sir and Sapna madam for this opportunity. Thank you very much.
Thank you, Dr. Devi Prasad, for a very informative lecture. I request the moderator, Dr. Santosh Latkar, to give the moment. Dr. Khageshwar, are you ready? Okay. Please start. एक मिनिट आता सांग काय
बेसिकली टाइम आहे 4:30 पर्यंत. प्रभा सर येणार आहेत. प्रभा सरांचं एक लेक्चर होईल. यांचं जर विचार केला 4 पर्यंत, रिजवानचं 4:15 पर्यंत. त्याच्यानंतर आपल्याला अजून कोणी आहे का तुमच्या बाजूने पेंडिंग?
आता कसं असेल तर काय एकच मिनिट.
How the habits will open?
Yeah. Thank you.
Talk about this because this is a special logo which is okay. It's okay. It's Dipti Tulsi
some sequence.
इसलिए कभी भी कर सकते हो अगर दर्शक कहते
हेलो. हाँ हाँ. टोणगावकर लगेच लगेच.
So good afternoon once again. So I hope my problem has been fixed. So I am Dr. Khageshwar. Once again, respected moderator and delegates. My topic of presentation is endoscopic management of tympanosclerosis. As you know, endoscopic ear surgery has been popularized in the last few decades. With an India, one of the founder, Dr. Patil sir is here. He was the founder and by inspiration, and Dr. Mubarak Khan. So this is the first conference. SEOCON is being held nicely, and you can see all kind of surgery can be done with endoscopy. So this is the hospital where I work. This is a medical college and university. The 250 students we admit, and we have 7 PG seat per year. So, and coming to this tympanosclerosis is a sequelae of otitis media. Chronic otitis media, as you know, it is a sequelae that characterized by hyaline degeneration of the fibrous layer, of the tympanic membrane and the deposition of some calcium or phosphate. The usually hyaline deposit of the cellular material visible as a white plaques in the tympanic membrane, and the as a white, look as a white nodular deposit in submucosal layer. Can be, and it is a history I was talking about. So Kesborn first described the calcareous plaque in tympanic membrane in 1734. Here he show with a torchlight or a headlight. Then Bontrus described the changes in the middle ear and tympanic membrane due to tympanosclerosis in 1873. And in 1956, Jolan explained the difference between otosclerosis and tympanosclerosis in the footplate area, and coined the term tympanosclerosis for the first time. And the house was one established the possibility of surgical treatment of tympanosclerosis in 1960. So usually this what part is affected in tympanosclerosis? Isolated involvement of tympanic membrane is more common though, but sometimes it is not symptomatic, more and termed as meringosclerosis. Unless until the big sclerotic patch touching this annulus will not cause hearing loss much. The tympanosclerosis plaque may also be present within the middle ear cleft and mastoid, and it is irreversible disease. It cannot be treated with medical treatment. Result from the infection and inflammation of the middle ear space could be the possibility. You can see this tympanic plaque. This plaque involving this anterior, whole anterior, superior and anterior, inferior, and some extent in the footplate area. Sometimes the extensive tympanosclerosis can look like this. You will expect such type of picture with a autoendoscopy. You will expect something inside also, like ossicular chain or the attic area could be involved. So how the pathology form of the tympanosclerosis, it is the end result of the healing process in which collagen and hyaline process in which collagen in fibrous tissue hyalinize and lose its structure and become fused with homogeneous masses. Thereafter, calcification and ossification takes place. There are theories how tympanosclerosis form. This local immunological hypersensitivity, one of the theory, increased oxygen concentration in the middle ear with exposure to oxygen free radicals, local continuous local inflammatory activities, one pathogen theory, and though pathogenesis is not clear, chronic otitis media is a prerequisite. Tympanosclerotic ear are free of active suppuration. Interestingly, they are most of the time not infectious. And this type of plaque, often we see it can be associated with perforation or a hill perforation or without perforation. So this type of small patches, the first picture, we don't bother most of the time unless it is a prerequisite for clearance for defense people. The doctor, they don't expect any scar mark or patches in the tympanic membrane. They require whole shining tympanic membrane. So we often operate those cases for clearance and transendoscopic, and often it is associated with heel perforation or associated with perforation. This is the pathogenesis again. I am not going details. This is how fibrocytic degeneration, extracellular matrix vesicle with calcium phosphate ions and supersaturation, then a deposition of the calcium phosphate. So the plaques occur in where it has been seen that tympanosclerosis often affect where there is less goblet cell area, particularly gland population are lowest, or ciliary activity motility is less. So these are the site where we find more of tympanosclerosis. Deposits tend to form where inflammatory exudates are liable to be trapped during the course of infection, and the absence of effective ciliary function where they stock and they keep on accumulation. This is the commonest area where you get the ciliary activity are less, and the most common site we encounter stapes, oval window area, and subfallopian group, upper promontory, and epitympano. So in our group, we have classified different types of the tympanosclerosis involved. Welling and Care classification use the type 1 where involvement of tympanic membrane and handle malleus. Touching the handle malleus, we treat as type 1 variety. Type 2 fixation of the malleus inguinal complex in attic with mobile stapes. Type 3 would be fixation of the stapes and mobile malleoinguinal complex. Type 4 is fixation of the stapes and malleoinguinal complex. These 4 types we group and we do different studies. What are the common symptoms you encounter tympanoclerosis? Most of the time they are asymptomatic unless it is a big patch or involving the ossicular chain. The difference would be there where it will affect the ossicular chain. There will be disproportion of hearing loss compared to the perforation. If somebody have small perforation can have more hearing loss, could be due to the ossicular involvement. And sometimes we'll have tinnitus, and the sign will see may have normal tympanic membrane with chalky white areas, may have favorite features of glue ear, you may have, and sometimes you get tuning fork test will be really negative, however will enter to same ear, and often will have normal or ABC. Investigation will normally the endoscopic, autoendoscopic will pick up the findings. Sometimes we do photon audiometry to the degree of hearing loss. Impedance often tell you about AS type of curve. X-ray mastoid will show poor nematization or sclerotic mastoid. CT scan often not necessary, but will reveal the unifocal or multifocal masses, linear calcifications. See, the CT scan will pick up, will show like this in the tympanic membrane. You can see if CT scan whether medullary cleft other part is affected. What is the treatment? As I said, treatment is irreversible disease. How do we treat? There is so many postulations, so many many people they don't favor for surgical treatment. Are the chance of recurrence is there? But you never know. It is very slow process. The surgery is the only treatment. If you will do meticulously clean the ossicle part, the part involved, definitely will give hearing result. Or if you are not confident, leave it or ask the patient to do hearing aid, to use hearing aid after this tympanoplasty. So if you are confident enough, you can take it out, like you do stapes surgery. The small plaques not interfering with the dictomy, small plaques not interfering with the mobility of tympanic membrane are usually normally left. If it's not touching or not causing any ossicular disruption, ossicular discontinuity or ossicular function, leave it better. Removal of the plaque before grafting is controversial. Otherwise, if small area is involved, plaques continuous with perforation and not interfering with tympanic mobility. I will show some video how you do. This is a case. You can see that the tympanoclerosis plaque involving this malleus as well as connected to the annulus area. We first peel up the epithelial layer like onion peel and we expose the tympanoclerosic patch. This is the tympanoclerosis involving rest of the. There is a perforation in the anterior in the inferior quadrant, and almost upper part is involved with tympanoclerosis that is involving malleus. So we just peel up this superficial layer and we take an incision, tympanometal flap. So before raising the tympanometal flap, you usually peel up this epithelium layer. It is easier. Now you can see this big patch, tympanic sclerosis involving touching the annulus. In those cases, it will reduce the hearing. Now it's involving this malleus, anterior and posterior part. So this type of tympanoclerosis requires surgical excision. So you have to take out meticulously without disrupting this other ossicle. Then after that we can do tympanoplasty. I'm sorry, I couldn't fix up. Other video is not working. One more video I want to show. This is a case. involving ossicle. This is a case where we involve again incus and malleus incus, between it bridging between malleus incus and touching almost the suprastructure. So I'm sorry, this is a edited video and it is very fast forward because of paucity of time, because you could not accommodate inside. So this is how clean utmost care has been taken to not to disrupt this. You can see the pyramid and stapedius tendon. We are clearing of tympanosclerosis. This type of tympanosclerosis, you need to surgical removal. Yes, you can left some tympanosclerosis if it is foot plate area is involved, or else we can do revision surgery later on, but without damaging the so the two options are released. If it is involving the attic area, then you explore the attic and cut the head of the malleus and release the tympanosclerosis pass, and you can reconstruct with the ossiculoplasty. Mobilization of malleoinguinal complex by removing plaques. You can do attic bypass surgery if you are not confident enough, and you cut it and do ossiculoplasty in those situations. So you have done a study, retrospective study done since 2020 to 2023. Out of more than 500 endoscopic tympanoplasty I have done, I have picked up only 30 cases. I have done 30 cases in which we have in a retrospective studies we use single-handed endoscopic surgery using 0° 30° telescope, 4 mm, and a narrow canal 2.75 2.7 mm scope, 18 centimeter or 14 centimeter. SD camera and spice SD spice camera use, and sometimes you require 300 technique. So we sometimes, because to remove the tympanosclerosis paths, we require suction, 100 suction, a telescope, and sharp instruments, of course. So we have resident, they will help to either to hold the scope or to hold the suction. So 300 technique we often use in critical bleeding area whenever there is a bleed or some critical steps. So either they can confident enough to hold the camera or they hold simply suction. So you have the assistant will keep the instrument suction with a finger like this as you do stapes surgery. So it will give stability. 3-hand technique you can use in critical cases to peeling off and to do suctioning and to using sharp instrument to clearing the tympanosclerosis. So out of 30 cases, we have seen a lot of hearing hearing outcomes. We have removed between malleus incus around malleoinguinal complex area with little curating as we do inside out mastoidectomy. Between incustostapedial joint, we have removed. So hearing results are good between 12 to 16 dB without much complication. So coming to conclusion, endoscopy here seem to be safe technique for the management of tympanosclerosis in experienced hand, and single stage surgery is possible in most of the cases with satisfactory hearing result. And fixation of the ossicle can occur in attic or oval window. For successful surgery, you have to release the fixation and reconstruct the ossicular if possible. And the foot plate is fixed. There is controversy whether you leave it or do second stage procedure. So usually unsuccessful second stage stapedotomy may be tried. General is that stapedotomy should not be done in concurrence with tympanoplasty or laryngoplasty. So this is my reference. Thank you very much. This is the picture last time SEOCON held at Bhubaneswar. I think I was the organizing secretary and invited a lot of endoscopic ear surgeon, Dr. Devi Prasad, Dr. Abid, and Dr. Mubarak Khan.
Then next session.
So I'm wishing all the best for this coming SEOCON to be held at Pune. Thank you very much.
Thank you, Dr. Kageshwar, for your informative lecture. I request the moderator, Dr. Latkar, to present a memento to Dr. Kageshwar. Yeah. Next. On behalf of organizing committee, just 1 minute. On behalf of our organizing committee, I would like to felicitate Dr. Latkar for as a moderator. Thank you. Dr. Latkar is president of ENT Association of Pune, that is AY Pune branch. He's leading practitioner at Pimpri and very close friend of mine. Thank you. Now there will be a short felicitation program. I request Dr. Devi Prasad to take over for that.
Good afternoon, everyone. Behind this work of logos that you're seeing here, there's a lot of hard work. So we wanted to felicitate particular members associated with this. So I would like to call upon Dr. Harshada, who is a budding ENT surgeon, who has created the logo of the SEOCON using the, you can see in the other side also, wherein all the equipments were used to make look like a ear. And I would request Dr. Sriram Murthy sir to felicitate her and give a memento from the SEOCON organizing team for all the hard work that she has put in.
I did my 15 days short fellowship with Sir in January. And just as a token of appreciation, I came up with the design. So I gave this as a token of appreciation to Dr. Khan sir and Dr. Parab ma'am. I think otology is all about precision and innovation. And what we are seeing over the last 2 days is a grand example of that. So I hope this logo is considered by everyone around here as a symbol of what is next in otology. And I'm really happy to see other young ENT surgeons like me looking up to endoscopic ear surgery and actually taking up in practice. Thank you.
Thank you. Next, we have Dr. Neil, and who is again recently passed out from Sharda Ben Hospital, Ahmedabad, who is currently associated with the Khan's team here, and Dr. Deepthi Tulsiani, who have come up with this logo of Athens. As Dr. Deepthi is not around, we request Dr. Nihal Patel, Associate Professor in Sharda Ben Hospital, to come over and accept the token of appreciation. I request Dr. Vijay Sonewale. Sir. I request you to felicitate these two budding ENT, and Madam will accept on behalf of Deepthi.
He's not there. Okay. That he posted. Thank you.
Thank you very much. We will proceed with the further talks.
Thank you. Thank you, Dr. Devi Prasad. For the next session, I call Dr. Kailash Sant is a leading otologist from Pune, practicing at Vadgaon Sheri and Pune camp area. He holds workshops on otology frequently at different parts of India. And he is a great swimmer. He has represented India in a recent competition and held with a good rank. Dr. Gauri Belsare, she is a leading ENT surgeon. She is associated with Ruby Hall and Bharti Vidyapit. She will be shortly joining. And Dr. Ravi Sardesai, who is practicing on Senapati Bapat Road, associated with Sassoon Hospital, Pune.
Dr. Hitesh Patel.
I also call upon I request Dr. Hitesh Patel to come forward.
Welcome. Yeah, give me the pen.
I call upon Dr. Prabhakaran sir for his presentation.
Hello, hi, good evening. Namaste. Thank you very much to Professor Mubarak and Professor Sapna for the kind invitation. I just want to show you very quickly about skull base and the learning curve. So what makes otology difficult? Why is it that otology is the most difficult field to learn, to teach, and for us to master as well? The problem with otology is you have a complex anatomy with a three-dimensional structure in a size of a 10-cent coin. That is a Malaysian coin. I think in rupees must be 1 rupee. One rupee is a coin, right? So in that 1 rupee, in a three-dimensional, you have balance, hearing, facial nerve. So it's difficult to learn, difficult to master, difficult to teach. Whereas head and neck surgery is the easiest, followed by rhinology, and otology is always difficult. But the other thing is the complications are unforgiving. Facial nerve palsy still remains as a complication that is the most obvious. Tinnitus, and when patients come to you with tinnitus, they can tell you anything that they feel suicidal, and there's nothing much we really can do. So what is required for otology is simple anatomy, anatomy, anatomy. And the other thing you need for otology is tactile sensation. You must know how to manage complications. So I'm just going to show you, instead of showing you the entire 40 minutes presentation, I'm just going to show you the bleeding videos. And the other thing is you need to know when to stop. And there are some personality traits that come with otology. Usually the otologists are more calm, more composed people, except when it comes to gala dinners and things like that. Otherwise, they are usually quite composed people, whereas the head and neck guys are usually much more aggressive, and the rhinologists are always in the center. I wear 3 hats. I do otology, rhinology, and head and neck. So most of the time, I have the temperament of an otologist. So this, I'm not even sure why I'm showing this scan. Anyway, it's a temporal bone, just a scan of a temporal bone to show the anatomy. You guys don't need all that. But when you operate, it's like driving a car. You need the 3 senses. Vision, to see the color changes when the dura is white, the sigmoid sinus is blue. You need the ability to hear the pitch, the high pitch that comes when you come close to a structure. And the most important is the tactile sensation. When you actually plunge through something, your leg must lift up from the drill immediately. It's like exactly like driving a car. So these are examples of anatomy. So this is again on the, this is again on the right side, the sigmoid sinus, the blue of the sigmoid sinus, how it becomes a transverse sinus. That's the posterior cranial fossa, dura. There's the middle cranial fossa, dura. This is the pre-sigmoid with the endolymphatic duct. This is sinodural angle, and all this will have a different tactile sensation. So this is something that we need to master if you want to do otology as such. The anatomy, we need to know anatomy very well. Lateral semicircular canal, posterior semicircular canal, sigmoid sinus, the labyrinth, retrolabyrinthine. And this is the anatomy before we do a translap. The lateral semicircular canal, the posterior semicircular canal, the superior semicircular canal, the subarcuate artery that forms or identifies the superior semicircular canal, the endolymphatic duct here that goes into the labyrinth, and the endolymphatic sac with the middle cranial fossa. There's a duct that's seen very clearly there. The jugular bulb, facial nerve, middle cranial fossa, sinodural angle. So all these are the anatomical structures that we need to know before we can start skull-base surgery itself. So this is a complete exposure after a translap. Again, you can see this is on the left side, and you can see now there's a middle cranial fossa, posterior cranial fossa, transverse sinus, the sigmoid sinus, the sinodural angle, the superior petrosal sinus that is here. And this is the pre-sigmoid area with the endolymphatic duct. That's the high jugular bulb, touching the internal auditory matrix with a tumor. The high jugular bulb, you don't have to worry because you can easily push it down, and that's the internal auditory matrix where the tumor is exposed. So this is the anatomy that we need to know, we need to be able to identify, we need to be able to have tactile sensation before we can manage complication. I'll skip all this in view of time. Yeah, I'll go straight to bleeding. Let me go to this one. Okay. So what do you do when you have bleeding? So this is a case that, this was many years ago. I was still young. I think I'm still young, but I was younger then. This is a very nice view of the facial nerve, the vertical segment. And this patient has got a huge schwannoma of the facial nerve along the vertical segment, the utricle, superior semicircular canal, lateral semicircular canal, IAM. And you can see how it's eroded into the floor of the middle ear. And you can see how the jugular bulb has got a very thin, this is dehiscent. So this will tell you even before surgery, you're going to have a bloodbath. So it tells you, be ready. So what do you do when you have bleeding? If you have not had bleeding during surgery, then you have not done enough. If you have not torn a sigmoid sinus during surgery, you have not done enough skull base. If you have not injured the jugular bulb during surgery, you have not done enough skull base surgery. Bleeding is part of surgery, and if you can't manage bleeding, let's be a dermatologist. Life is easier, you make more money, and you sleep better at night. First of all, don't panic. You are the captain of your ship. If you panic, the entire operation theater panics around you. So even if you panic inside, outside, you must look like Buddha himself. The calmness that comes with Buddha. Because if you panic, the entire operation theater panic, the nurse will panic, your assistant will panic, anesthetist will start having palpitations. Just be calm. Carry on. Do you remember the advertisement for Johnny Walker, the black label? Just keep walking. So just continue. The good thing about posterior skull base, there are only 3 scenarios. And the best part, if you open posterior skull base, you can put your finger at the exact point and the bleeding will stop. So you don't have that facility or that in endoscopic skull base. All you can use is a cotton bud. And there are only 3 scenarios that you can do. One is bleeding that's surrounded by bone, which is very easy, bone wax. Bleeding that is surrounded by soft tissue If it's a single point, you call bipolar. If it's a oozing all around, you use a Surgicel or gel form. The most difficult is your bleeding under the bone because you have to remove the bone first. So this is an example of I was doing a translab for a totally acellular mastoid. So it's usually said that it's not possible to be done. That's the middle cranial fossa. That is the sigmoid sinus. That's the ear canal. There's no space at all between the sigmoid sinus and the ear canal because it's a totally acellular mastoid. So this is a patient who's got a bit of oozing and bleeding from the transverse sinus. You can see the middle cranial fossa, the posterior cranial fossa, and that's the mastoid. Not a single mastoid cell. Now remember, this patient was 15 years old when I did the surgery. That is how the middle cranial fossa and the posterior cranial fossa is literally kissing and hugging each other, and that's the mastoid itself. Yeah. So this is, remember the case I showed you just now. So this is the torn jugular bulb. So you just have to identify, divert the blood away, identify the exact location of the bleeder, put in a Surgicel, and the bleeding stops like magic. Okay. Another video. So this is the case I showed you just now. I've already opened up the schwannoma. This is a very interesting video. It taught me a lot. I was much younger then as well because you can see the quality of the video. So the schwannoma has been removed from the neck. So the jugular bulb is torn. So I'm putting a bone wax. But what happens is the bleeding gets worse. Say, oh, I must have put it in the wrong place. So I'm going to take another piece of bone wax. My nurses are more than happy to give me bone wax after bone wax. The bleeding gets worse. Now I'm going to ask myself, this doesn't make sense. Why is it every time I put a bone wax, my bleeding gets worse? It's a totally unedited video. You see it as it is. Bleeding gets worse and worse and worse. Now I start to panic. I was 33, 34. I just came back from my fellowship and the buck stopped with me at the time. So it stops for a while, but when I take off the sucker, the bleeding gets worse. So what I did was, this is the last one. So I put a bigger piece of bone wax and you'll find the bleeding gets worse as well. So I say enough. So when you have too much bleeding, you don't know what to do, pack, take a deep breath, wait for, we operate with music at the back, 1980s music, the music when I was a teenager. And that English song takes 3 minutes. So it gives you 3 minutes to finish the song and calm yourself. Hindi songs are better, no, 7 minutes, right? So it gives you a longer time to calm yourself. Then I took off the pack. And you can see the kind of bleeding that you'll get from a jugular bulb when you take off the pack. There. So what I'm going to do now, I'm going to put a patty across it. But look at the way I put the patty here. It's not sitting properly. Okay, so that's the mistake I made. So I removed all the bone wax and then I said, no, I must place it properly. Place the patty nicely along the contours of the jugular bulb and the bleeding stops like magic. So please learn from this mistake I made. If you put something to stop your bleeding and it gets worse, it just means that the opening, whatever you're using, is actually smaller than the defect itself. So you have to remove the entire bone wax and put just one single layer of gel foam that covers the whole defect and the bleeding stops like magic. It's always easier to learn from other people's mistakes, so learn from mine. I had to learn it the hard way. So now, this is, I was doing a Ewing sarcoma for a child, a simple bleeding from dura of a 9-month baby where we're doing Ewing sarcoma. This can be easily malus, incus, middle cranial fossa, posterior cranial fossa, as you can see. This can be easily removed by using a bipolar. Let me show you examples of other cases. It's a patient, we're doing a retrosigmoid. Here you can see a jugular bulb, an hemispheric vein that is bleeding. After a while, you get used to seeing the shoot. The more you suck on it, the more it shoots. And after a while, you get used to the swirl of blood. There you go. So what's the mistake I made? Is the first dictum, bleeding from around the bone, you use a bone wax. I'm going to place a bone wax on the bleeding and the bleeding stops like magic. So this is the final view of the surgery. This is a very interesting video. Sometimes you have a dominant sigmoid sinus. So one side, there is no sigmoid sinus, but the other side, there's a very dominant sigmoid sinus. I was doing a translab for this and the sigmoid sinus like paper thin. So it's an unedited video. It took me 7 minutes to control the bleeding from this paper thin sigmoid sinus that is dominant. But a dominant sigmoid sinus, you cannot compress. You can only stop the bleeding by placing Surgicel on top, but do not compress. Because if you compress, you have an otitic hydrocephalus and you can see the kind of bleeding that you will have from a dominant sigmoid sinus. So this is when the nurses try to be helpful and try to adjust the light for you at the same time. I'm going to skip this in view of time, but I'll just go a bit quickly. You can see the kind of bleeding that you can get. And it took me 7 minutes to stop all the bleeders, because every time I remove bone, I got bleeding. Can you see? Nice shooting blood vessel, eh? Sigmoid sinus. Put gel foam again. So finally, we did stop the bleeding purely because it's a dominant sigmoid sinus, we went on with the surgery. This is a patient that they had already placed the patient before I land. So but when I went into the OT, they had already done a cortical mastoidectomy. So as I was doing a translap for them, I just couldn't understand why do I keep bleeding again and again. This was 2-3 years ago in another hospital. And I'll tell you what exactly happened. They take off the bone wax, bleeds again. I put a patty, bleeds again. I just couldn't understand why is there so much of bleeding. And I'll tell you why it was so much of bleeding. Okay, bleeding stopped. I'm just going a bit quickly in view of time. Emissary vein. Look at the size of the emissary vein that we have here. Can you see, guys, the size of the emissary vein? These are all unedited videos. I'm going to use a Surgicel. I'm going to stuff it in. Then I looked at the head. Usually when you operate a skull base, you always flex like this and extend, correct? In this case, what the neurosurgeons had done was they had flexed like that. So the head was like this. So what that has caused is caused the IJV to be compressed. So your sigmoid sinus and jugular bulb is compressed and it's become a high pressure. That's what has happened in this case. So always position your patients correctly, because if your neck is compressed, you will definitely have bleeding like this that you could have avoided in the very beginning. This is an example of a patient who's got a huge parotid CA going into the jugular bulb, the sigmoid sinus. So this is the kind of bleeding that you will get from the jugular bulb. Quite nice, eh? So you don't have to worry about bleeding like this. Put your finger inside. It's taken from my iPhone. And then put a bit of bone wax, and the bleeding stops very nicely as well. And this is the post-op view. You can see the jugular bulb has been exposed, the jugular foramen has been exposed, the 12th nerve, the 11th nerve, the carotid artery, and we've done the resection of temporal bone. This is a nice case. ICA, jugular bulb. There's the ICA here, there's the jugular bulb here. So if we are lucky, the jugular bulb will get thrombosed. If it gets thrombosed, you have no bleeding whatsoever.